True.
And today I really mean it, I do, because today is the linchpin for everything we do. Now, for years, I've used the analogy of a linchpin, and then I realized a few years back, you may not know what a linchpin is. You guys know what a linchpin is?
No.
How is that possible? If you take the linchpin out, everything what?
Falls apart.
Everything what?
Falls apart.
Guys, today is the linchpin for everything you do. You can't do this. You can't do this. You understand what I'm saying? Because today is Patient Assessment Day! Woo! Wow, you know, the excitement in this class is overwhelming to me. It's just too damn much. Patient Assessment Day! Woo! All right, everybody get out your patient assessments or I'll stick my dog after you. Guys, all that stuff that you guys learned yesterday, when I told you, don't panic, and then you guys panic. Right? All that stuff yesterday, anatomy, physiology, do you need to know it?
Yes.
Guys, I would start speaking up or I'll start going after you individually. Do you need to know it?
Yes.
Yes. Why? Because I told you. You cannot miss a question. A really bad reason to miss a question on an exam. Because you don't know some little Flopsman Jetson piece of anatomy and physiology. Right? And guys, it is pervasive throughout this class. You know what that means? That means you will miss questions in every single category. Because you don't know some little Flopsman Jetson piece of anatomy and physiology. You cannot do it. But the truth of the matter is, on a daily basis, right, we're not sitting there approaching our patient thinking to ourselves, okay, blood is coming from the body, heading towards the right side of the heart. Through what vessel? Really? Because I can go after you individually, guys. I just thought it was such a small class, I'd let you do it as a whole. Because do you need to know blood flow through the circulatory system?
Yes.
Yeah, so let's try this again. Blood is coming from the body, heading towards the right side of the heart through what vessel?
The intravena vessel? Cavana vena vessel?
Fuck.
The inferior.
Man, this is going to be a tough class. I just said the vessel. It's called the what? All right, so again, you guys want to do it this way. This is what we'll do, and now we'll just find out who knows what. Blood is coming from the body, heading towards the right side of the heart. Sir, through what vessels?
The left atrium vessels?
No. It is your major vein that you have in your body. It has a name. It's called the what, sir? Yeah, I guess we all took that. Guys, you know what? You don't want to speak up in this class. You don't want to say the words. And then when it comes time for us to ask you, you don't know. Sir, through what vessel? Yeah, you know what? This shit don't help you if you don't know. This means nothing. Through what vessel, young lady?
The superior inferior cava.
Could you speak up so everybody can actually hear the words coming out of your mouth?
The superior inferior vena cava.
Yeah, spent friggin' 7 hours of my morning class having the same issues. If you don't know, fine. Right? But if you don't listen to somebody else, hey, it's going to be a big-ass problem. And I got news for you. I know he told you yesterday, you don't just need to know it forwards, you also need to know it what?
Backwards.
Yeah, why? Because we have patients we're going to be talking about this class with things back up. Right? So the vessel that takes blood always towards the right side of the heart is the what, everybody?
Vena cava.
It's called the vena cava. Vena cava. You're making it more complicated than it needs to be. It's called the what?
The vena cava.
The vena cava. And then, back to you, sir. It's redemption time. It dumps into what chamber of the heart?
The right ventricle.
So the vena cava dumps into the right ventricle. It actually dumps into what chamber? It's an upper chamber. So it's called a what? Like, I gave you the opportunity to do this together, but you guys didn't want to speak up, so now I got to do it individually. Yeah, the upper chambers of the heart are called what?
The upper chamber.
No, it's called the what? It has a name. Yeah, no, it's not that, sir. We don't call it the all fuck chamber, right? What chamber?
It goes to the tricuspid.
That would be a valve, sir. Right? So I guess we didn't actually learn our shit. What chamber, young lady? I can't hear you.
The right atrium.
Okay, you understand you're not speaking up for me. You're speaking up for everybody else in this class who doesn't actually know it. So when we ask you to speak up, speak up. And besides, in this class, right, when you're actually assessing patients, you actually have to open up your mouth and speak up. This is a class of communication. This class has been quiet since the get-go, right? You need to communicate, which means you need to speak to other people. The what?
The right atrium.
The right atrium! Yes, it's coming back to you, sir. Sir, you already have this shit written down. Oh, and by the way, it is in your book, too. From the right atrium. To get to the lower chamber, it has to go through a special one-way valve. That one-way valve is known as the what?
The tricuspid.
You don't want to know why you can't say it? You want to know why? Because he asked you to say it last night. Just like we've been asking you to say stuff over and over in this class, and you don't want to speak up. How do you think you get the pronunciation? How do you think you learn your terminology? You actually open up your mouth and say it, so hopefully when you hear yourself say it, you'll actually know it. But if you don't want to say anything, then you're not going to end up knowing your shit. Yeah, you butchered it. Tricuspid. Say it.
Tricuspid.
God almighty, I tried to tell you this. You want to fight me? Okay. All right, look, we're going to teach the class no matter what. And we're going to go ahead and do everything we can to get this stuff in your head. But you got to help us, right? It is the tricuspid valve, sir. And then it dumps into what chamber?
Into the right finger? The right ventricle?
Yes, it's the right ventricle. Yes, your box heart. You just didn't learn it. The right ventricle. Now, you said you got it.
Yeah.
From the right ventricle, when it contracts, it goes out through a vessel, heading away from the heart. Look, if you're wrong, okay, but at least speak up. Pulmonary, what?
Pulmonary artery.
Is she right?
Yes.
I'm sorry, is she right?
Yes.
It's called the what?
Pulmonary artery.
What?
Pulmonary artery.
Yeah, it's the pulmonary artery because it's a vessel that's going away from the heart. Arteries go away from the heart, veins go to what?
D heart.
To heart. And what happens in the lungs? He doesn't do this. That's the diffusion dance. What am I doing?
Diffusion dance.
What?
Diffusion
dance.
Exchanging.
So, if you're wondering how we find out whether you actually learn your shit or not, this is how we find out. I told you we were going to call you out in class, right? And all I wanted to let you know was that's not what we're thinking on an everyday basis. I just needed to make sure that you actually understood that you needed to know blood flow. Oops. I'm going to get a quiz on this tonight, right? But on a daily basis, we're not thinking about that. What we're thinking about is this. This. This is the linchpin for everything we do. Everything. And guess what? In order to run a patient assessment, you have to talk. You have to speak. You have to be able to communicate. The majority of our job is what?
Communication.
Which
Communication.
means you need to be able to run this. Now let me explain this to you. Learning this, actually learning this, understanding this, you need to do in 3 phases. 3 phases to learning your patient assessment. Number 1, you have to get it in here. You need to know what you need to do and when you need to do it. Why? Because there is order to the patient assessment. You have to get it in here. But wait, there's
More.
I told you. This is a touchy-feely class. In order to assess somebody, you have to what?
Touch.
You have to be able to do the actual hands-on skills of your patient assessment. The actual hands-on skills. That's what you're getting. You're getting the signs with your hands-on skills. You have to be able to do the actual physical hands-on skills. That's 2. Phase 2, you have to be able to go from here to down here. But wait, there's
More.
Because the truth of the matter is, your patient assessment is really about recognition. Which means you have to be able to recognize what you're getting from your hands-on skills. And then, boom, it has to come back into here. Because you need to be able to go, ooh, I recognize that, bam! I need to do this for my patient right now. Because that's the only way you're going to recognize what you need to recognize in your patient assessment so that you can treat your patient appropriately as you go. You have to be able to integrate your knowledge with your skills. I told you that on the first day. I told you this wouldn't be like any other class you've ever had before. Because most of you have never done that before. It's not just about reading a damn book and taking a friggin' exam. And you're in luck. Why? See this thing? You want to know what this really is? Want to know what it is? It's just a framework. It's a framework of a patient assessment. Why? Because we pretty much do the same things every time with every patient with a few minor variations. The assessment is the same. The only thing that changes is what our findings are and what our patient tells us. It's the same. That's why it drives us crazy when we teach it to you and you don't get it down. Because nothing is going to matter unless you get this down. You have to be able to run the framework. Now here's the deal. Your job, first and foremost, is to get the framework down. Because you need to know what you need to do and when you need to do it. You understand? You get the framework down and it's going to be easier for us and it's going to be easier for you. Why? Because if you get the framework down, then all we need to do is fill the framework up with the knowledge of recognition we are teaching you in lecture. So that you can recognize what you need to recognize in your patient assessment and you can treat your patient appropriately as you go. And after all, isn't that what it's really all about?
Yes.
Is it?
Yes.
This is what they gave you last night. Right? And guys, let me explain. You cannot have one without the other. What do I mean? If you are didactically brilliant, you can pass any quiz, any final we throw at you, but you cannot run a patient assessment. You will not recognize what you need to be able to recognize, when you need to be able to recognize in your patient assessment, and you will not treat your patient appropriately. It won't matter how much recognition you have. If you can run a patient assessment, but you don't have the knowledge of recognition we're teaching you in lecture, well then you won't recognize what you need to be able to recognize in your patient assessment, and you won't treat your patient appropriately. And don't forget, you're not just taking a written exam at the end of this course, you're taking a what exam as well?
Skills.
And your skills exam is not just seeing if you can do the skills. You need to be able to integrate your knowledge with your skills. Get correct now, guys. Seriously. And whether you know it or not, we've already started teaching you that knowledge of recognition that you're going to need. And we're going to continue to do throughout this class. But if you don't get this down, nothing else is going to matter. If you're smart, you will spend most of your time trying to perfect this. But here's the other problem. Most of you, all you're familiar with is rote memorization. So you'll sit there and you'll try to read this and you'll say it in the mirror. And when you try to run it on somebody, you won't be able to do it. You have to run this on another human being. You have to actually do the hands-on skills. You have to ask the questions to another human being. And the best people to do it on are the people that are sitting what? Right next to you. Right here. So, you guys, a lot of you guys come in early. That's great. from here on out, what are you doing? What are you doing? You should start running patient assessments on each other. You should. Because the more you do it, the better off you're going to be. You got that?
Yes.
All right, guys. So, and it all starts tonight. First thing first, we got to get it in where?
Our head.
And the person who's going to take you through that, you listen well, going to teach you how to do it. Make sure you listen to them. Listen to them. We're going to try to make things easy for you. Don't want to make things hard. Try to make things easy. So my question to you, as it is every day, is, are you ready?
Yes.
The one, the only, Vincent Cutter. And Bourbon.
Woo!
Oh, you wanted to. Yeah, that was, I don't know, that was kind of contrived. Do you have a question? Do you have a question?
I don't have my paper. I'm going to ask my classmate.
Why don't you have your patient assessment?
I came too early on a rush.
I got an extra one. Any kind of extras that you guys, everybody always leaves in class, we always throw them right under here. Guess what we have a ton of?
Books?
Patient assessments.
Oh.
All right, guys, enjoy. Woo!
Alright guys, so we're going to go ahead and just go over the skill sheets, right? So like I said yesterday, you guys should already have made your account for your online content, which is going to have access to all of your skills that we're going to teach you in this class, okay? Now, as far as these skill sheets, like I said, these are basically the answer sheets for your skills that you are going to be testing out on. I won't tell you what skills you're testing out on, except for maybe one, right? But it's basically going to go ahead and lay it out like so. Now, the very tippy top of the paper, okay, it's going to say EMS, or Emergency Medical Services Agency of Los Angeles County. Okay, they are the ones who wrote out the skill sheet. Not myself, not Matt, okay, nobody else here, okay, wrote the skill sheet out. It's all about the county, which means when you're testing out, is it our standard or the county standard?
County.
It's the county standard, okay, and we don't have a choice, right, but to teach you to the LA County EMS standard, okay? Which means that if you were to make something relatively minor that I personally may not agree with, it's not my call. Right? You didn't do it, you didn't perform the skill, you didn't pass it, you failed the skill. Okay? We'll talk about fail criteria and stuff like that, right? But this skill right here is probably the number one reason as to why students, right, will fail out of this course. Right? Those at least make it all the way through to the actual final exam. Okay? So you need to make sure you're practicing this skill like it depends on it. Okay? Now as far as the margin down here, you guys are going to see a bunch of black diamonds. Okay? In pretty much each and every box. Those black diamonds indicate critical fail criteria, which again, you make a mistake on that, I don't have a choice but to fail you on that skill. Okay, and your fail criteria can be as minor as simply asking the wrong question at the wrong time, or stating a wrong number for a vital sign, okay, or flip-flopping two things that seem relatively unimportant. Okay, that's how easy it is to fail the skill. And as far as fail, right, it's usually the minor stuff like that. It's never really the big, overarching, big chunks of assessment that people miss that cause them to fail. It's stating a blood pressure of 113/71, right? It's not asking the patient what they had last to eat or drink, right? It's not clearing a contraindication for a medication, okay? It's little tiny attention to detail, or lack thereof, that cost people this skill, all right? Now, as far as this whole packet, right, it's gonna be all the nitty-gritty part of the patient assessment. What you guys should be using, okay, is this thing on the back, okay? So you guys can go ahead and tear this off, right? Maybe make a few copies. Okay, but that is going to be basically the framework for this assessment and summary of everything that's on there. Okay, you can go and tear it off in these as well. All right, so we'll be using this as a reference pretty much for the duration of the class. Okay, but the actual packet is where you're going to have all the little tiny attention to detail and stuff like that. All right. Now, as far as patient assessment, obviously we're going to be teaching you guys how to run through an assessment tonight. By Friday, by when?
Friday.
We expect you guys to at least get through most of the patient assessment. We don't expect you guys to be able to knock it out of the park on Friday, okay, but we should not have to sit here and hold your hand Friday night to run through a patient assessment. You make some mistakes, all right, fine, no big deal. You just were taught it a couple days ago. But if you sit there and you have no idea what to do, that's absolutely unacceptable. Okay, you need to at least have somewhat of a general idea as far as how a patient assessment actually runs. Okay, and there will be time tonight for you guys to practice, which means there's actually going to be forced interaction with your classmates. Okay, so as far as our patient assessment as a whole, Okay, kind of looking at the big macro picture of our assessment. The very first thing we do for every single call is going to be our what?
BSI.
It stands for
Body substance isolation.
And you wear that because everybody is nasty, right? So we're gonna have our BSI on, being our gloves, mask, eye protection, anything that's gonna keep body substances isolated from myself. Okay. Then we have to do a scene size up. So on Friday night, right, we just had you guys walk up, make sure that scene was safe. Okay. But tonight we're gonna teach you guys a mnemonic to actually know if the scene is safe, what things I gotta look out for, what do I gotta do to make it safe, and so on and so forth. Okay, so we're going to go through a whole scene size up. Now, once I know my scene's safe, after completing a scene size up, we're now going to approach our patient and start running a primary assessment, aka an initial assessment. Okay, we talked about this on Monday. The whole point of the initial assessment is to find and treat any, not trauma,
Shock.
no, not necessarily shock.
Life-threatening.
Thank you, sir.
Injuries.
Anything life-threatening. Anything what?
Life-threatening.
Anything what?
Life-threatening.
Right, anything life-threatening. Okay, so anything that's going to kill my patient, such as shock or obvious bleeding or respiratory issues, okay, we see it, we treat it. Okay, and that's what Matt was saying earlier. You have to be able to identify certain things in the assessment and know what to do and when to do it. Okay, because if you got a patient who's in shock, for example, okay, you guys will literally sit there and be like, oh no, my patient's in shock. Hey, do you have any disabilities you need to be aware of? And you just move on right to the next step of your assessment. And you're not recognizing the thing that's right there in front of you. And that's how we know you guys are not practicing the assessment the way you're supposed to. You're just memorizing it like a script and not actually doing stuff with the information that we're presenting you. Okay? So we take care of our life threats in the primary, and then we jump to a secondary assessment. And in the secondary, we have to do things like vital signs. We have to do a physical exam. We got to get a medical history. Okay? We have to gather other information about the patient, take care of any non-life-threatening injuries. So things like broken bones, dislocated joints, things like that. And we tie it all together with the provider impression, where I go back and I summarize everything in the actual call itself, and then we complete our ongoing assessment. Okay, now like I said, this is a big kind of macro picture of a patient assessment. As we go through tonight, we're going to go into every little tiny detail about the assessment. All right, so starting off with the very first top portion of that one-page little algorithm you guys have, we have our prep and scene size up. Okay, so we have our BSI, of course, our body substance isolation, and then we do our scene size up. And we have a mnemonic for that scene size up, that mnemonic being Penman. Okay, so we're going to be assessing personal, partner, patient safety. Again, who is the most important person on scene? We are. So we got to look out for myself, want to make sure my partner is okay, and then lastly, we check the safety of the patient. Okay, we'll be checking for any types of environmental hazards that may be present. Okay, we'll talk about what exactly it is that we expect from you guys. We'll go into this stuff again in much more detail. Number of patients, and this one's pretty straightforward. How many patients do I have on scene, or do I expect to have when I actually get on scene? Okay, because we don't always do a scene size up right then and there on scene. Usually, our first scene size up is done on the way to the call itself. So we're thinking, okay, we got called out for this type of issue. These are things I got to worry about. I may have this many patients. Right? We have to establish a mechanism of injury versus a nature of illness. And if our patient sustains a mechanism of injury, okay, we're suspecting this to be a trauma patient. What kind of patient?
Trauma patient.
Right. Whereas the nature of illness must be a... No. If mechanism of injury is trauma, nature of illness has to be... Medical. Thank you. Has to be what?
Medical.
Has to be what?
Medical.
Right, because I either have traumatic patients or I have medical patients. But could I have both a medical and traumatic patient? Yeah. Okay. If I have grandma who's driving down the road and she has a stroke, that's a nature of illness, but then she crashes into a tree, that's a mechanism of injury. Okay, so we have to think about it. Okay, what's the age of my patient, right? What's the call for? Could this be having a medical origin, causing trauma, or vice versa? All right, we have to check for additional resources needed. And then lastly, determine a need for extrication or spinal motion restriction. Okay, so again, we'll be going through all this stuff in finer detail, what it is we're actually looking for, how to actually identify it and assess it. Okay, so if you can get it all now, not a big deal. So, BSI, again, our body substance isolation, whatever we're going to wear to keep that nasty stuff away from us, because everybody's what? Nasty. So, gloves, mask, eye protection, all crap we've covered multiple times before. Okay, now we should have our BSI on before I even step out of the ambulance. Okay, because do you think every patient's going to sit there, right, on the porch of the house, just sitting there and just twiddling their thumbs until we walk up to them? No. Absolutely not. Okay, there are plenty of times where patients will come up to your door, right, waiting to be treated as soon as you step outside. Okay, so you can't sit there in front of your patient and be like, oh, I'm sorry, sir, let me put on my gloves here, right? You have to be ready to go as soon as you step out of that door. Okay, so as you go into the call, you're putting on your gloves and whatnot, and you're thinking with your partner, doing your scene size up. Okay, so obviously you want to make sure we're safe, partner safe, patient safe, right? And then we're going to start assessing things like environmental hazards. Okay, now you have to think about what type of issues may be present when you show up on certain types of calls. For this class, okay, we are going to expect you guys to list off certain hazards. You're not being graded or evaluated on them, right? But we want you guys to start critically thinking about things before you actually start running your patient assessment. I always treat it essentially like a warm-up for my brain before I'm actually ready to start running an assessment, okay? So let's say, for example, I'm called out to, we'll just say this call right here, right? So we have fire engine into a building. So what are some hazards I got to be worried about for this particular scene? And anybody can call out.
Structural gas.
Gas. What else?
Down electricity.
Down power lines. Sure. What else?
Oncoming traffic.
Oncoming traffic without reading what's on the slide. What else? Sarah?
Maybe water on the floor.
Sure.
Fire-
Yeah.
fire-
Water, right, from busted water line. What else?
Building collapse.
Structural collapse. Yeah. Building damage for sure. What else?
Fire.
Fire. Yeah. What else?
Maybe potential dangerous people. in
Yeah,
the area.
people themselves, right? Okay, especially nowadays, everyone's going to want to go freaking take a selfie with this, right? So we have to worry about large crowds of people who may be unruly, right? Things like that. Okay, so you have to sit there and we'll give you a call, right? You call out to a private residence, somebody's home. What are some things you got to worry about? Well, I got to worry about the patient, got to worry about family, got to worry about animals, possible weapons, they may have fire issues, right? Things like that. Okay, and like I said, you're not being graded or evaluated. You're not going to fail the skill if you don't say you're looking for this one particular thing. Okay, but we want you guys to start warming up. All right, now if you guys have watched videos on patient assessment on YouTube, don't do that, by the way. Okay, you're going to see people sitting there and be like, is the scene safe for myself, my partner, my patient? Yes, it is. Are there any environmental hazards? No, your scene is safe. Okay, they're not doing anything. They're simply asking for the information. Okay, they're wanting to be spoon-fed their information. We don't do that here. Okay, we want you guys to again start critically thinking what's going on with this assessment, right? Because again, this is kind of the warm-up, and then we can actually get into the assessment itself. So, right, we got a few things here. As far as potential for violence, we have to worry about this for any call. Doesn't matter what kind of call it is, there's always a potential for violence. Okay, our patient's always going to be happy to see us. No, okay, not all the time, right? So the patient themselves can be a hazard. Okay, as far as scene safety, okay, obviously scenes are not always going to be safe when we get there. Okay, so we have to make sure that the scene is safe for us to actually go there. Okay, that'll tie in with additional resources, right? Who I need to call to make the scene safe. Now, if it's not safe, make it safe. If we are on scene and the scene becomes unsafe, okay, I get one chance to try to pull that patient to safety with us, right, before we have to extricate and leave the scene. Okay, so we get one shot to try to bring our patient out with us if that scene happens to be unsafe while we're there. Okay, scenes are always dynamic, they're always changing. Okay, so let's say we have a car crash, right? As we get there, everything seems to be fine, but all of a sudden we see some smoke coming from the engine compartment. Possible indication of what?
Fire.
A fire, right? So, crap, possible fire is about to start. Get this patient out of here, right, and try to drag them out to safety. Okay, but again, we only get one chance to do that, right? If that patient's pinned in a vehicle and I can't pull them out to safety, okay, are we going to burn right next to our patient? No. Okay, at that point, the scene's unsafe. We have to leave and hope for the best. Okay, but we have to try to do what we can. We're not going to be like, all right, peace, and that's it, and not try to do anything. Okay, we have to try to pull that patient out to safety with us. Okay. Now, as far as the environment itself,
In times like that, do you still wait for consent or you just snatch it?
that's just a rapid extrication. We just pull them and go. All right. So, as far as the environment itself, obviously that can have effect on us too. Okay. Whatever happened to them can happen to us. Okay. Like we said before, we are not superheroes when we're in uniform and on duty. Okay. We are flesh and blood just like our patients. All right. Obviously, it's summertime now. Temperatures are pretty hot. Okay. The uniforms we wear are not very summer friendly. Okay. They're dark. They're polyester. They're heavy. Okay. So we have to worry about heat-related issues for us. Right. And in other places where it's really cold, we got to worry about becoming hypothermic. Okay, so the actual environment itself can obviously pose a threat to us. Okay, we'll talk about environmental emergencies in week 3. Okay, but patients will crash really quick, right, in those extreme environments, really hot, really cold. Okay, we have to worry about animals as well. It's never the big dogs, right? They're always going to bite us. Okay, it's always little tiny shithead chihuahuas. Right? That's why you want to wear, your nice 8-inch boots. That way they can't go through that. Okay, but we do have to worry about animals and things like that. And if you do have a patient who has animals on scene, okay, if available, try to have them be put away, right, put into another room, something like that, so it's safe for us to approach.
Have there been situations where the patient's injured by, say, an animal, like, say, like, they have, like, snakes swimming on the edge?
Of course.
So I've seen.
Yeah.
What would we do in that situation? Would we have, like, call animal control?
Yeah, call animal control, call when we need to, right? Have the patient come to us if that, snake's still running around, black widow spiders, things like that. Yeah, if we have to move them out of there so we're safe, then we'll move them out so we can actually do our job. All right, we got to worry about hazmat as well. Okay, so think about the type of call that you're getting called out to. Right, car crashes, there is going to be hazmat. You may not think of it, right? But oil, gasoline, things like that, those are all hazardous materials. Okay, getting called to somebody's garage, there's a lot of chemicals there. Obviously, factories, industrial plants, things like that. We have to worry about hazmat. Okay, when it comes to the number of patients, this one's pretty straightforward. How many patients do I have when I get on scene or expect to have when I actually show up? Okay, and certain types of calls are going to lend themselves to a certain number of patients. For example, most medical calls are going to have how many patients?
One.
One. Right? It's usually one person who's having chest pain or shortness of breath, or one person who's having abdominal pain. Okay, one person who's having a stroke. But in the case of trauma calls or traumatic calls, is it always just one patient?
No.
No. Okay, there could be multiple patients. So things like car crashes, right? Yeah, it could be a single patient, but we could also have multiple patients, right, for a TC, a traffic collision. Okay, so we got to think about that kind of stuff. Now, as far as triage, all right, triage is going to be sorting patients out based on the severity of their condition. Okay, so triage is sorting patients out based on the severity of their condition. So if I have more patients than rescuers, okay, we have to start triaging them. And the patient assessment we're going to teach you tonight goes right out the window when it comes to a triage situation. Okay, in fact, we're going to teach you triage is pretty much one of your last lectures because we say, hey, remember everything we talked about 3 weeks ago? Yeah, ignore all of that because we do this now instead. Okay, it's a very quick and dirty assessment, right, where we just move on to the next person if they don't meet certain criteria. Okay, so we need to figure that out. Obviously, the more patients we have, the more rescuers we're going to need as well, okay, which will also tie back into additional resources. When it comes to mechanism of injury versus nature of illness, again, a mechanism of injury indicates what kind of patient.
Trauma.
What kind of patient?
Trauma.
What kind of patient?
Trauma.
Right, trauma. Okay, now when it comes to assessing an MOI, right, we're looking at physical clues that we see on scene. Okay, so what do I actually see and observe when I get on call? So for example, here we have a car that plowed through a fence and ran into a tree. Okay, that red circle right there, that's circling what we call spider webbing, which is an impact on the windshield. Now, based on the location, that's driver's side, approximately head level. So, what do I think caused that crack? Somebody's head. Okay, that sign compared to everything else is the most important sign because that indicates they have what type of injury.
Head injury.
Head trauma. All right, so right there, that one sign alone already tells me this is going to be a critical patient. Okay, based on the fact that they hit their head against that windshield with enough force to crack it. Okay, now we can look at other things like airbag deployment. Okay, we can look at deformation to the actual vehicle itself. I'll be looking behind the car to see if there's skid marks indicating they at least tried to slow down before they plowed through the fence. Okay, I can look at the speedometer. Usually they'll lock on impact, giving us an idea of how fast they were going when they hit. Look for seatbelt marks on the patient. Okay, we're going to play pretty much CSI as we're looking for physical clues on scene. All right, tomorrow when we talk about trauma and all the other kind of stuff, because tomorrow is where we really start talking about real patients, okay, we'll be going over the evaluation of a mechanism of injury. Okay, what do I see or suspect, right, to indicate what type of traumatic injuries they've got and what complications we got to look for. All right, now as far as the nature of illness, okay, this is trauma, nature of illness must be, we just did this.
Medical?
Medical, thank you. Gosh, you guys are slow. Okay, again, mechanism of injury is trauma, nature of illness is?
Medical.
It's what?
Medical.
It's what?
Medical.
Can I have both in the same patient?
Yes.
Yes. Okay, so certain patients like geriatrics, which is a fancy word for the elderly, not old people, let's be nice. Okay, geriatrics, right, don't offend Matt. Okay, as far as geriatrics, right, fancy word for elderly, okay, they can have medical and traumatic injuries in the same time. Again, grandma's having a stroke as she drives and crashes. Okay, grandpa has a fainting or a syncopal episode and falls down and breaks his hip. Okay, these are things we got to worry about in that type of patient population. Okay, for generally younger, healthier patients, typically it tends to be one or the other, but we still have to worry about both. Okay, now if you are worried about nature of illness rather, okay, we start becoming more of like a detective. Okay, in the sense that I'll be asking questions in addition to looking for clues. All right, now there's a part of our secondary assessment we're going to talk about later tonight, okay, where we're going to try to establish the actual nature of illness, right? What medical issue do we think is going on with these patients so we know how to treat them? Okay, are we doctors?
No.
No, obviously not. Therefore, we cannot diagnose our patients. I can't sit there and as obvious as it is and be like, you, sir, you are for sure having a heart attack. I can't say that. But I can be like, looks like you're having a heart attack, okay, based on the other signs or symptoms. Okay, and hopefully with some of our medical issues, we can identify what might be happening with the patient based on the nature of illness. So, we want to go and talk to the patient. They're obviously going to be the greatest source of information about their issues because they're the ones having the issues. Okay, if not, maybe family or friends. Bystanders can provide us with a little bit of information, right? But we want to try to ask around to see what's actually happening with the patient. Okay, we'll look at medications as well, right? Because can medications provide clues for us?
Yes.
Yes.
Yeah. For example, if I see insulin on my patient's medication list, what do I know about that patient?
He has diabetes.
They're diabetic. Okay, so that one clue, right, can tell me a lot about this patient. Okay, they're unconscious, they take insulin, they're diabetic, they might have low blood sugar, right? We go down that path and sure as shit, yeah, it was a diabetic emergency. Or, okay, no, that's not the issue. They have diabetes, but it's not the problem. Then I have to transition and try to think about something else. Okay, so that's what we're going to start talking about starting next Tuesday when we transition into medical. Okay, now we like to say that trauma is very straightforward. Trauma is very what?
Straightforward.
Very what?
Straightforward.
Right. I see trauma, I treat trauma. Super simple. Okay, but when it comes to medical, right? Medical's hard. Medical's what?
Hard.
Medical's what?
Hard.
Right. It's hard. And the reason why it's hard is because there are so many similarities amongst all of our medical emergencies that if you focus on the wrong things, you're screwed. That's why we tell you not to focus on the similarities. Instead, you focus on the differences, because those differences will tell you exactly what's happening with your patient. For example, can a patient have chest pain or shortness of breath because of like 2 or 3 things?
Yes.
No. There's like 40 different things that cause a patient to go, oh, my chest hurts and I can't breathe. Okay, so you've got to be able to identify the differences, right, to see what's actually causing that chest pain and shortness of breath. Okay, and we'll talk about the questions we're going to ask to actually identify the difference. Okay, and we'll reinforce that as we cover our different medical issues. We'll be using senses as well to determine possible nature of illness. So what do I see on the patient, right? What are they telling me as I'm hearing what's going on? What do I feel as I palpate? Okay, things like that. Using pretty much every sense except for taste, because please don't lick your patients. Okay, but we'll be doing everything else as far as actual assessments. Right, we got to be really careful about multiple patients on scene. Right, whatever's happening to them can happen to us. Right, so if you got a patient who again is trying to kill themselves, right, by running the car in the garage, we got to worry about what gas?
Carbon
Monoxide. Okay, and if I sit there and I'm treating my patient, I'm like, oh man, my head's starting to hurt. All right, and I start getting really lethargic. Well, now I'm a victim of carbon monoxide poisoning, right? And now I'm a patient, which means people got to come help me. And if they're stupid and they sit there like, oh man, my head hurts too, right? Then we're just adding on more and more and more. Okay, so you've got to sit there and be like, hey, I got 5 patients that are all complaining of the same thing, and they were trying to keep warm by burning a stove inside the house with everything closed up. Shit, this is carbon monoxide poisoning. Let's get them out of here, right? Because we don't want to become patients ourselves. Now, as far as additional resources, okay, again, who would I need to help me out on this call? And that will depend on whatever issues you come across. Now, in order to determine your appropriate resources needed, you got to ask yourself 3 questions. First off, okay, is the scene safe for myself, my partner, my patient? And if it's not, who do I need to call to make it safe? Okay, so if the scene's not safe for us, who do I need to call to make it safe?
Fire department
Well,
or...
it depends.
Oh.
Yeah, depends on whatever issues we have. Okay, how many patients are there? All right, if there's multiple patients, we got to call for more rescuers. Now, as far as patient to help rescuer ratio, basically 1-to-1 is okay. If I show up with my partner and we have 2 patients, that's fine. We each take a patient and we're good to go. But once the patients outnumber rescuers, that's where we start triage. All right, so technically anything over 3 patients, right, is where we have to start doing triage if it's just myself and my partner. Okay. Now keep in mind that will depend on the amount of resources that are available. Okay, here in LA County, again, we're special. Okay, is it just going to be myself and my partner showing up on a call?
No.
Hell no. Okay, we're going to have basically half of a whole fire station coming in to help us out for grandma who fell, right, and triggered her life alert. Okay, so in that case, right, we can have a bunch of elderly people on the floor that need picking up, right, because we have a bunch of people there to help out. But if you were to go out to the Midwest, is it just going to be you and your partner?
Yes.
Yeah, right. And if you got multiple patients, well, we got to call for additional ambulances. Okay, so you do have to think about that. Remember, we're training you guys in the national standard. Okay, so yeah, you'll be working in LA most likely. Okay, but for now in class, right, we can transport this call to anywhere we want. And let's say we're in the middle of Kansas, where the hospital's 400 miles away. Okay, so you have to think with that kind of mindset right now while you're in class. All right, so how many people do we have? Do we need to call for more? And then lastly, do we have the resources and or training required to treat this patient's condition? Okay, so do we have the equipment and or the training required to take care of my patient? For example, as an EMT, okay, can I help my patients who have chest pain and shortness of breath?
Yes.
Yeah, absolutely. We can help them. Okay, there's only so much we can do, right? But I can definitely help them out. Okay, so if I can't do so much, who do I need to call for? I need to call for ALS because they can do a lot more, right? We can give them oxygen. We can treat them for shock, right? We can maybe help them out with the medication if they have it, right? And that's about the extent of what we can do. Okay, ALS, they can do all of that. They can start an IV. They can hook them up to an EKG, right? They can go and intubate as needed. They can give other airway adjuncts and stuff like that. Whatever they got to do, they have more tools in their toolbox. Okay, we only have so many that we can actually use.
Do BLS medics carry BLS airway adjuncts?
Mm-hmm. Yeah, paramedics will carry BLS stuff, right? So usually we'll be the ones doing that stuff, right? And then they'll come in and do whatever treatments they have to do that they can't do, right? So it's always BLS before ALS. We always go least invasive to most invasive, right? So we do whatever we can. Okay, there's not much we can do, and then ALS will come take over the call, right? And depending on where you're at, ALS will say, yeah, go ahead, do what you can, and I'll be here in case you need me, right? And they'll let us run most of the call, right? Other times, ALS will say, get out of here, and they'll do everything they need to do, right? So it just depends on the crew, the system, that kind of stuff, okay? So this is how we identify the resources that we need, right? Is it safe for us? And if it's not, who do I need to call? Okay, how many people do we have that we need to treat? How many patients do we have? And then do we have the right training and resources to actually take care of these patients? And if the answer requires additional resources, then we just call for who we need. So, a couple of examples, right? We have a chest pain, shortness of breath. We already said, who do we need to help us out?
ALS.
ALS, right? Based on the fact there's only so much we can do. Okay, if I have a school bus crash and I got 20 patients, how many people do we need, or who do we need?
A lot.
We need a lot of ambulances, right? We need other people to help us out. Okay, we have a house that's on fire. Who do we call?
Fire department.
Fire department. Okay, we have a patient with a gun. Who do we call?
Law enforcement.
Law enforcement. There's a down power line. Who do we call?
Edison.
Edison, right? There's a haunted house. Who do you call?
Ghostbusters.
Right. Okay, so we got to figure out who we need. Finally, you guys are waking up, right? We've got to go ahead and call for whoever we need, right? Depending on the situation that's at hand. And like I said, for class, okay, same thing as your environmental hazards. Okay, what do I need to call for to help me out on this scene? Don't sit there and be like, do I have other additional resources on the way? Okay, we want you guys to think about that stuff.
And you said triage is when the number of patients is greater than the number of
Rescuers. Yeah, that's when we start that process. All right, so lastly, the need for extrication or spinal motion restriction. Okay, now as far as extrication, okay, extrication is the removal from entanglement or entrapment. Okay, so extrication is the removal from entanglement or entrapment. So if I have a patient who's pinned in a vehicle following a car crash and we have to use a jaws of life to get him out, that is extrication, which is not the same as extraction. Okay, extraction is simply getting the patient off the scene, and that's it. Okay, usually we use extraction in reference of an air ambulance where we fly the patient out. Okay, but extraction is simply getting them out of there. Okay, whereas extrication is removal from entanglement or entrapment. All right, and then we have spinal motion restriction. Pretty straightforward. Do I have to restrict motion of their spine? Okay, and the need for SMR is based off of the MOI. MOI standing for
Mechanism of injury.
What is it? Right, it's a mechanism of injury, which indicates it's what kind of patient?
Trauma.
Okay, so based on the type of call that we're called out to, based on what I see when I get there, like, hey, there's a chance that their spine might be all jacked up. Let's go and grab our backboard or seat collar so we can put them on a backboard. Okay, now there's different spinal devices. We'll talk about a few of them tomorrow. Okay, but we have them pretty much listed right here. Seat collar, a CAD for patients who are in a seated position, of course, our classic longboard. Okay, these are all things that are designed to restrict motion of the spine. All right, now as far as spinal mobilization, just a little heads up, again, being in transition period right now. Okay, we're not backboarding everybody, right, in the field, but for class purposes, we still are in that kind of mindset of, oh, they have possible spinal injury. let's go and mobilize our patients. Okay, so like I said, things may be changing by the time you guys get out there, right, as far as what we still have to teach here. Okay, so we don't always need SMR, but for class purposes, at least be prepared for that. Okay, and I want to go and determine that need as soon as I possibly can. All right, so as soon as I get on scene and actually see my patient, that's when I want to kind of start this whole process. Okay, and we'll talk a bit about it more tomorrow. All right, now with that is going to conclude our scene size up. Now, everything we just talked about right now can be done without even making any type of patient contact whatsoever. Okay, when I get my dispatch call, again, I'm sitting there thinking, all right, I'm grabbing my BSI. Okay, is the scene safe for myself, my partner, my patient? What hazards do I have to worry about? How many people are going to be present? Is this medical? Is it traumatic? Could it be both? Who do I need to call to help me out? Do we have to extricate? Do we have to put them on a backboard? And then when I actually get up on scene and I can actually see my patient, then I go back and be like, okay, cool, yeah, everything's safe. I can cancel these guys. I don't need to worry about a backboard. Don't have to worry about this kind of stuff. We don't have to extricate. Right? We can go back and reassess our scene size up. For class purposes, though, we're only going to do it once prior to the call itself. Okay, but this is a continual process at all times.
Is the scene size up, is this all like spoken that you need to verbalize with your partner? Like you need to communicate?
Usually not, right? Because your partner's going to be doing the same thing, right? But you guys can kind of start discussing a few things like, hey, you know, if we have a traumatic patient, do you want me to grab the head first, or do you want to take the head? Do you want to take lead? Things like that. We can start prepping a game plan before we actually get there. Yeah, but I'm not going to be like, hey, partner, what do you think we're going to come up against when we get... You don't have to worry about that kind of stuff.
Is there any paperwork that we have to fill out along with this? Like you said, if it's not written, it didn't happen, do we have to do, like, when we're going to a call or something like that? Is there anything we can put, like, any of this on paper?
Nope. It's just things we're worrying about, and then as we get up on scene, if we have to call for resources, oh, we requested PD due to, you know, domestic dispute or something like that. All right? So, this will be our prep and size up, okay, all done prior to actually making patient contact. Now, once we do that, now we can actually get into the patient assessment. Okay, starting with the primary. Okay, and this will be the second section of your little one-page flowchart. So, when I actually get up on scene and I see my patient for the first time, this is where I develop a general impression. Develop a what?
General impression.
Develop a what?
General impression.
Right, and that's the first of 3 different types of impressions that we're going to develop on our patient assessment. We have a general impression, a field impression, and a provider impression. And you guys screw them up all the time. Okay, but basically with my general impression, it's just a little quick blurb about what I see with my patient. I haven't talked to my patient, I haven't touched my patient, I've only seen my patient as I walk up and make visual contact. So we'll talk about what has to be hit in an actual general impression itself, but that's the first thing I do for my primary. Okay. After that, we got to check our patient's responsiveness by going through what mnemonic? AVPU, right? So I want to see if they're alert, if they're tracking me. No, they're not. Okay, we start going on to verbal stimuli. Hey, with the ambulance, can you hear us? No response to verbal. Now move on to what? Painful stimuli. So we provide painful stimuli, and if that doesn't work, they're considered
unresponsive.
And at that point, right, we do CAB. Okay. For the purpose of tonight, however, our patients are responsive to something. Okay. That way we can actually run through a full patient assessment. Because if they're not responsive, we do a different type of assessment. Okay, so again, that's why you need to understand, okay, what do I need to do for these certain types of patients? So, once our patient wakes up to whatever type of stimuli, okay, we just simply run onto the introduction. Right, I've never seen this person before, they've never seen me, so I want to introduce myself. Okay, I want to introduce my partner as well if we have one, which we usually do, and I want to get the patient's name. Okay, I want to establish a rapport or a relationship with this patient. Okay, I don't want to treat them as just another run number. Okay, you want to establish a relationship with the patient to make them feel more comfortable, right, so we can make our job easier. Now, once we get that out of the way, we have to get a chief complaint. Okay, so once we've knocked out the introduction, now we get a chief complaint. Okay, and the chief complaint is not always the same as your dispatch call. Okay, they're not always the same. Dispatch is just gathering information, usually from a third party, about information about a patient. Okay, and there have been plenty of times where I've gotten a dispatch call that was completely different to the actual patient's chief complaint. And if dispatch can't tell you what's going on, they'll basically be like, all right, you're called out for an unknown medical, which is their way of saying good luck, right? And then you have to do whatever you can. And I can't tell you how many unknown medical calls we've had that are actually traumatic injuries. Okay, so you just have to be ready for it. Don't go off dispatch thinking, okay, that's what I'm getting, right? Because it will vary. So we want to have the patient tell us what's going on. And then lastly, just because I wear a uniform and a badge, can I go touch anybody I want?
No.
What do you have to get?
Permission.
Got to get consent. Okay, so we have to get consent to treat our patient. Now, once we've taken care of that, then I can move on to our ABCs. All right, airway, breathing, circulation, disabilities, deformities, expose, visualize, possibly palpate, formulate a field impression, and identify. Okay, so again, we'll be going through all these different things in their little tiny detail, right, so we can actually know what it is we're looking for. All right, and again, you guys have this on your little algorithm. So, as far as the general impression, okay, there's a grand total of 5 things we have to hit. How many things?
5.
How many things?
5.
Right, total of 5 things we got to hit in our general impression. Okay, now this is just basic information about them. It doesn't have to be 100% accurate all the time, right, for most things. Okay, I need to state the approximate age of my patient. Okay, so we got to state the approximate age of our patient. And that could be a rough age range. I got a patient in his mid-20s, right, female patient in her mid-30s. Okay, not a young man, because that can be anything from a 5-year-old to a 17-year-old, right? That doesn't tell me anything. Okay, so it's approximate age range within reason. Okay, the sex of the patient as well. The position they were found in. Okay, so if I've got a patient who's laying flat on their back, we'll start in the back corner, what position is that if they're flat on their back? Supine. Right, sir, what about if our patient's sitting up? Sir? Fowlers. Right, so if they're sitting upright, okay, they're up in a Fowler's position. Right, if they're on their left side, that'd be left lateral. Okay, so we want to state the position they were found in. Then we want to establish if it's a possible mechanism of injury, which indicates what kind of patient, or nature of illness, which indicates
medical.
There we go, finally. Right, or if it's a medical patient. Could it be both?
Yes.
Yeah. Okay, again, especially for certain patients like geriatrics, fancy word for elderly. Okay, right. So with geriatrics, again, I got to worry about medical and traumatic issues together. So again, if I find a patient who's on the floor, right, and they're a geriatric, hey, they could have fallen down, right, because of a medical issue and then broke their hip because of the actual impact itself, right? It's an MOI that was caused by an NOI, or vice versa. They may have sustained trauma and then fallen down or had some other medical issue like a seizure, right, or a possible stroke or something like that. Okay, so we got to worry about that with some patients. And then lastly, and most importantly, do I see or suspect any life threats? Okay, so do I see or suspect any life threats? Now, as far as the suspicion of life-threatening injuries or illnesses, play it safe, right? Assume the worst, hope for the best. Always assume that something's life-threatening until proven otherwise. Okay, so assume that most things are going to be considered life-threatening until proven otherwise. All right, that way if it's not, you're going to be pleasantly surprised. Like, oh, okay, you just had some gas station sushi and that's why your stomach hurts? Okay, that's fine. All right, versus, oh crap, you're having it at AAA? Yeah, that's a problem. All right, so again, just a quick little blurb about what I see as I approach. So for example, it would sound something like this. I have a female patient, mid-70s, laying down in the supine position, unknown MOI, NOI, and this might be life-threatening. That's it. Okay, you're just painting a picture about what you see in front of you as you're approaching your patient. We haven't talked to them, we haven't touched them, we haven't done any type of assessment besides just visually looking at them. Okay? Now, once we do that, we're going to try to go through our AFBU, so see if our patient's alert and if they're tracking us. Okay, so as I walk into the room and they look at me and be like, hey, what's going on? We know that they're alert. Okay, if they're not, respond to verbal stimuli, we yell at them. If that doesn't work, go to painful stimuli. And obviously, if they're unresponsive, again, we now go to CAB. Checking circulation, airway, and then breathing. Alrighty, so as far as patients and their responsiveness, it really depends on how they wake up. If we can determine the possibility of them having an ALOC, which stands for
Altered level of consciousness.
Okay, so if I have a patient who is alert and they're tracking me as I walk up, can I assume that they're altered?
Only if they're tracking?
No.
Oh, no.
Right, they may not be altered. They might be as well, but based on the fact they're looking at me as I walk up, okay, at this point in time, they seem to be okay. Now, as far as verbal stimuli, if I got to yell at somebody to wake them up, okay, can I consider them altered? No. Right? They may be taking a nap. Hey, wake up. Oh, what's going on? Why are you guys here? That's totally fine. Okay? But if I have to yell at my patient and they start waking up when they're still really lethargic, now can I consider them altered? Yes. Okay? So as far as verbal stimuli, it depends on how they are when they respond. Do they wake up and they're pretty much alert right away? Or are they very lethargic and kind of in and out of it? Now, as far as painful stimuli, if my patient responds to painful stimuli, are they considered altered? Yes. Okay, because think about it. I shouldn't have to hurt anybody to wake them up. Okay, if I got to hurt them to wake them up, that's not normal. right? And then obviously if they're unresponsive, are they altered?
Yeah.
Yes.
Absolutely. Okay. So when it comes to painful stimuli and worse, they're obviously altered. For verbal stimuli, it depends on how they wake up. Okay. Now we're not going to do anything about that information, but at least we already know that, hey, this person has an ALOC. All right, we'll talk about treatments later because we have to do it at the right time. Okay, but at this point in time, I've already planted that seed in my head that, hey, this dude woke up to painful stimuli. That ain't normal. I got to see what's going on with it. Okay, now once the patient wakes up, now we can get into the introductions. Okay, so again, introduce myself. Hey, my name is Vince. I'm an EMT. This is my partner, Casper. And what's your name?
Ramon,
Ramon? All right, Ramon, what's hurting you today?
my left toe.
Your left toe hurts, and you called us for that. Perfect. Can we help you with that?
I would hope so.
I would hope so. So yes?
Yes.
Okay, and that's it. That's my introduction. Okay, he knows who I am. He knows who my partner is. I know who he is. I have his chief complaint by asking him, what's hurting you? We can also ask what's bothering you, right? And then we have consent. Can we take a look at this? Can we help you? Can we treat you? Okay, that's how easy it is to start a conversation with somebody. And again, you guys will screw this crap up all the time because you don't talk to other people. Again, 80% of this job is what? It's communication. Okay? So you just need to go through that stuff, right, like you would if you're meeting a totally new person. Right? And for tonight, it seems like you guys are going to be meeting totally new people. Okay? So, as far as chief complaints, right, the two questions to ask, I've already said it. What's hurting you or what is bothering you? Okay? 99.999% of the time, okay, one of those two questions will get you a chief complaint. Okay? So what's hurting you or what is bothering you? Now, patients don't always call an ambulance for themselves, but if they do, it's because something hurts them or something doesn't feel right because they're sick. Okay, so if I ask them, hey, what's hurting you? Oh, my big toe kind of hurts. Okay. Or, hey, what's bothering you? Oh, it's kind of hard for me to catch my breath. Okay, so it kind of gives us an idea of medical traumatic issues, right, as far as pain versus just not feeling right. Okay, and then as far as consent, it doesn't have to be super formal like, oh, sir, do I have your consent to treat you today? It doesn't have to be like that. All right, it's, can I help you? Can we take a look at this? Can we treat you? Something where the patient says, yes, you can help. Okay, that way we can try to get that express consent. All right. So, as far as the chief complaint, it's not always going to be the most life-threatening issue. Okay, the chief complaint is not always the most life-threatening, the most pressing matter that we have to take care of with the patient. It's simply whatever is bugging them the most. Okay, so we kind of touched on it yesterday, right, as far as femur fractures. Okay, there's a very specific type of femur fracture that requires a very specific type of treatment. And with a femur fracture, again, they can lose how much blood?
Almost all of it.
A lot, yes, not all of it. Right, 1.5 liters. Okay, so they can lose 1.5 liters of blood from a femur fracture. Right, now is your patient going to say, I got a femur fracture? Or are they going to go, my leg hurts? My leg hurts. Okay, and that much blood loss is enough to put them in
Unconscious.
shock.
Oh.
Okay, now your patient again is not going to say, I'm in shock. They're going to go, my leg hurts. Okay, but you have to go through your assessment and go, oh crap, I'm seeing signs of shock, and shock kills my patient, so I got to take care of that first, and then I'll come back later and fix the broken leg. Okay, we've got to take care of the life-threatening problems first before taking care of the non-life-threatening things. And again, the chief complaint is not always going to be the most significant problem. It's whatever is bugging them the most, but it may not be the thing that kills them the fastest. Okay, so as far as signs versus symptoms, we'll cover this again in the secondary, but signs are objective, what I can actually see or observe, whereas symptoms are subjective, whatever the patient feels or tells us about. So for example, chief complaints, they're subjective. Right? It's what the patient feels as far as pain or discomfort. Right? My big toe hurts. Okay, I can't see that, but I'll take your word for it. Or it's hard for me to breathe. Okay, you can't really see your shortness of breath, but I can tell that you are. All right, as far as determining multiple chief complaints and which one's most serious, we have to run kind of a little mini triage assessment in that sense, right? Whereas, okay, they got broken leg and shortness of breath. The shortness of breath is going to be the most life-threatening problem first because it's a breathing problem over the leg pain. Okay, so again, chief complaints don't override ABCs, airway, breathing, circulation. Okay, we've got to take care of those things first. Now, as far as everything we've covered so far, going from my general impression to AFPU to my chief complaint and stuff like that, this is all happening in the first few seconds of patient contact. Okay, for class purposes, you have to verbalize it in a step-by-step process. But in the field, we're multitasking, right? My general impression is done mentally in my head. Again, I'm not talking to my partner and be like, hey, partner, we have a male patient in his mid-20s sitting up in the Fowler's position. We think it's trauma and it might be life-threatening. We're not doing that because my partner's doing the same thing. Okay, as far as checking responsiveness, as I walk in, they're looking at me, cool. I already know that they're alert, and I'll just be talking to them as I'm taking steps towards my patient. Hey man, my name is Vince, I'm EMT, my partner Casper, what's your name? And we're going through all this stuff. Okay, so just realize, and people ask me all the time, oh, how long does it take to do this? It's not very long. Okay, it takes just a few seconds to go through my first portion of my assessment. Also includes airway. Okay, now as far as our assessment, we run it in ABC order. What kind of order?
ABC order.
Right, ABC order. Easy as 1, 2, 3. Okay, so we go with A for airway. And we like to say that airway is king. Airway is what?
King.
Airway is what?
King.
Airway is
Airway
what?
is king.
Right, it's king. Okay, K-I-N-G. All right, the reason why we say the airway is king is because if you don't have a patent, a what?
Patent.
Which means
Open.
Open. If you don't have a patent airway, you're not breathing. And if you're not breathing, what happens to you?
Done.
You die. Okay, so we have to make sure that airway is patent. Now, it's the most important step of our assessment because without a patent airway, again, patients can't breathe and they die. So it's the most important step, but it's the easiest one to assess. If my patient's talking to me, do I know they have a patent airway?
Yes.
Yes. Right? So when he said, my name's Ramon, my big toe hurts, and yeah, you can help, I already know he's got a patent airway. Right? And again, bleeds in right into the first few seconds of my assessment. Cool, I know his airway's clear because he's talking to us, so then I move on to the next step. Now, as far as the airway not being patent, okay, if we see it, we treat it. We see it, we
Treat
We
it.
see it, we
Treat it.
We see it, and we treat it. So we got to talk about different ways to treat airway issues, and we'll save that for later. But if the airway's not patent, we have to make it patent. Okay, so if the airway's not patent, we have to make it patent. And we'll talk about how to do that on Tuesday. All right, but for right now, keeping it simple. Okay, if they're talking, they got a patent airway. As far as infants, can an infant talk to me?
No.
Right? They can't even go goo goo gaga. They just make noises. Right? Now, if they are crying, right, then we know they have a patent airway. Okay, so a crying baby is a relatively healthy baby, and the fact that we at least know they have an airway and they're breathing. Okay, but for us, again, if they're talking, cool, we know they got a patent airway. Now, after A comes B, which will stand for breathing. Now, for breathing, we're going to be looking for a few things. We're going to be checking the rate, rhythm, and quality of respirations. And as far as the rate, I'm not worried about numbers. Okay. So when it comes to a breathing rate in the primary assessment, we're not worried about numbers. All I want to know is, are they breathing fast? Are they breathing slow? Or does it look about right? Okay, so for rate in B, for breathing in the primary, is it fast? Is it slow? Is it about right? I don't care about numbers. For rhythm, is it regular or irregular? Okay, so for rhythm, is it regular or irregular? And for the quality of their breathing, do they have adequate tidal volume? Okay, so do they have adequate tidal volume, which is the amount of air they're sucking in and out per breath? Okay, and we can tell that based on their chest rise and fall.
Adequate tidal volume?
Yep, tidal volume. Tidal like a tidal wave, T-I-D-A-L, or Jay-Z streaming service. All right, so tidal volume, okay, how much air they're sucking in and out per breath. And we know just based on chest rise and fall. Okay, if I see their chest moving up and down at a decent volume, okay, cool, they got enough air to sucking in. Okay, we'll talk about numbers later in the secondary assessment, but for right now, again, is it fast, slow, or normal? Okay, now in addition to looking at the chest rise and fall, okay, we have to ask yourself one very important question, okay, which is right here in this green box. Okay, we have to be asking ourselves, does my patient need oxygen? And if so, how do I administer it? Okay, so we have to be asking ourselves, does my patient need oxygen? And if so, how do I administer it? So again, very important question. We got to ask yourself every time I get to this step. Does my patient need oxygen? And if so, how do I administer it?
Is there ever a bad, like, is there ever a time we shouldn't give high flow oxygen to
Mhm.
the patient?
Yep, we'll talk about those later. All right. Now, as far as this question, again, we should ask it every single time we get to B. I don't care if it's for a stub toe. I need to ask, does this patient need oxygen? And if so, how do I administer it? In the case of a stub toe, the answer would be no. Okay. But for other patients, the answer would be
Yes.
yes. Okay. So we're going to have you guys repeat it, and then we'll talk about the patients. So we'll do it step by step. Okay, so repeat after me. Does the patient need oxygen?
Does the patient need oxygen?
And if so, how do I administer it?
How do I administer it?
Let's try it again. Does the patient need oxygen?
Does the patient need oxygen?
And if so, how do I administer it?
How do I administer it?
Again, does the patient need oxygen?
And the patient need oxygen?
Let's try it again. Does the patient need oxygen?
Does the patient need oxygen?
And if so,
how
do I administer it?
How do I administer it?
Your turn, go.
Does the patient need oxygen? And if so, how do I administer
That
it?
actually wasn't too bad. Let's try it again. What is it?
Does the patient need oxygen? And if so, how do I administer it?
One more time.
Does the patient need oxygen? And if so, how do I administer it?
So I had you guys say it a half dozen times. Okay. Does that mean it's an important question to ask? Yes. Okay. Because if our patient needs oxygen, we have to give it to them. Okay. Now there are 4 patients that are automatically going to receive high flow oxygen. Okay. There's only 4 patients. Again, 4 is the magic number for this class. Okay. The first one is a patient who's having chest pain. Okay. So if our patient's having chest pain, okay, we want to give them high flow oxygen. The second one is shortness of breath. Okay, so chest pain, shortness of breath. Third is patients with an ALOC, which stands for
Alternate level of consciousness.
right. Okay, so patients with an ALOC. So again, that's chest pain, shortness of breath, ALOC, and lastly, patients who have sustained major trauma. Okay, so last one is patients who have sustained major trauma. So again, that's chest pain, shortness of breath, ALOC, and major trauma.
So whenever they have one of these 4, we have to give it to them?
Yes.
One.
Any one of those, yeah. Because that's a really messed up patient to have all 4. All right. So again, chest pain, shortness of breath, ALEC, major trauma. Now, as far as the purpose of class, what's that question you got to ask yourself? Why? Thank you. Finally, people are go, oh, does my patient? No. Okay. For the purpose of class, it's why. Okay. So,
What would you consider major as far as trauma?
we'll talk about that a little bit. Yeah, and tomorrow too. So, as far as why, okay, those 4 patients get high flow oxygen has to do with what's being affected in the body. Okay. So, if our patient were having chest pain, okay, what organ do we typically associate with chest pain?
Lung.
Not the lungs, the heart. And I like to call the heart a what?
Brat.
It's a brat. Thank you, sir. It's a what?
Brat.
It's a what?
Brat.
It's a what?
Brat.
Right. Okay. Because as soon as that heart becomes hypoxic, becomes what?
Hypoxic.
Okay. It's going to start throwing a tantrum in the form of chest pain or discomfort. So now your patient goes, "Oh, my chest hurts." Okay. So I want to try to give those heart cells some high flow too, to try to reduce the amount of injury or death that those myocardial cells are going to be going through. Okay. So it's saying my chest hurts. I'm assuming it's a cardiac problem. Here's some oxygen. Okay. As far as shortness of breath, what organs are being affected there?
Lungs.
Those are the lungs, which are responsible for putting oxygen into our blood. So if the lungs are having problems and the patient's short of breath, well, let's try to throw some more O2 at the problem to see if it fixes it. Okay, as far as ALOC, what's being affected?
Conscious.
Well, what organ is being affected?
Brain.
The brain, right? So if that brain starts to become hypoxic, that's going to cause them to be a little altered. Now, there's a lot of things that cause an ALOC, but the first one we can try to fix is going to be hypoxic issues. So we try to give them some high flow too. And then lastly, for major trauma, if they sustain major trauma, what do you think they're losing a lot of? Blood. And blood carries oxygen. So whatever blood they got left, I want to saturate as much oxygen as I possibly can, right, to try to maintain perfusion. Okay? So again, those are the 4 patients that we automatically give high flow oxygen to when we get to this step. Now, back in the day when I was taking the course, okay, we were taught that everybody got oxygen. So even our stub toe patients, we gave them 15 liters a minute with a non-breather mask because that's what we were taught. Okay, I like to call it the Oprah days of oxygen because we gave it to who? Everybody. Okay, but the reason why we don't do that anymore is because certain patients actually did worse with more oxygen. Too much of anything is
Bad.
a bad thing. Okay, and the patients they found were doing really bad on oxygen were patients who were having strokes. So too much oxygen causes cerebral vasoconstriction, right, where the blood vessels in the brain get smaller. And if they're having a stroke, they already have circulation problem inside the brain, which made the problem even worse. Okay, so they found out that, giving these patients high flow oxygen for long term was actually doing worse than those who weren't getting oxygen long term. Okay, now here in LA County, we don't have to worry about that because long term is hours of high flow oxygen. Right, for us in pre-hospital setting, we're not going to be with them for that long. Okay, so it's really more of the clinical setting in the hospital where they've got to be careful about how much oxygen they administer. Okay, but for us, right, if they have an ALOC, we go and give them high flow oxygen. Right? So, as far as some other things we're assessing for in breathing, besides this and asking ourselves this, right, we want to look for things like cyanosis. Okay, cyanosis means they're turning what color? Blue. And just because my patient's cyanotic, does that mean they're dead and I don't have to do my job? No. You guys blew that question last night. Okay, patients are cyanotic, that just means they're lacking oxygen, right? And that's a late sign of hypoxia. Okay, so crap, they're blue, I want to give them some high flow oxygen. All right, patients who are sitting in a position of comfort, sometimes it's a tripod position, okay, that's when they're going to be sitting with their hands on their knees, right? Almost like a sprinter when they're done and doing that, but again, sitting in a chair.
When I was studying this last time, my aunt said she saw a baby drown, and when they pulled the baby out of the pool, the eyes were like blue, and the lips were blue. Was the baby dead on scene, or could they have saved it?
It depends. If it drowned, then it was already dead, right? But cyanosis will happen with dead people, but they're not just dead because they're cyanotic. We have a patient that we'll talk about later that is cyanotic, but obviously they're not dead yet, right? So, as far as position of comfort, right, whatever's going to make them feel better, that can be the high Fowler's position where they're really sitting straight up, okay? Feet dangling kind of has the same effect where they're kind of sitting forward, making it a bit easier for them to breathe. Noisy breathing, we'll talk about abnormal lung sounds, and there are 4 abnormal lung sounds. Again, 4 is a magic number for this class. You don't have to write it down now, we'll talk about them later, because it is going to be part of our vitals. But if I hear some abnormal sounds, that's a problem. Air movement in the terms of unequal chest rise and fall or poor tidal volume, their chest isn't moving much. That tells me they got respiratory issues. And then we have 2 to 3 word dyspnea. Now this fancy word here, dyspnea, just means shortness of breath. Okay, so dyspnea is a fancy word for shortness of breath or difficulty breathing. It can go either way. And as far as 2 to 3 word dyspnea, that means our patient can say how many words? 2 to 3 before they have to catch their breath. So if they're sitting there going, I'm having a really hard time trying to catch my breath, okay, that's 2 to 3 word dyspnea. And are they short of breath?
Yes.
Absolutely. But if they're sitting there going, well, it's kind of hard for me to catch my breath and I can't really breathe very well, are they short of breath? No. Okay, if they can speak in full sentences, we know they're not short of breath. Okay, so we'll talk about that when we cover assessments in a little bit. As far as accessory muscles, okay, so we talked about that last night a bit as well. Right. As far as the primary muscle for breathing, Miss, what is the primary muscle that we use for breathing? No.
I was going to say lungs, but...
Lungs aren't a muscle.
Diaphragm.
The diaphragm. So as we inhale in this, where does that diaphragm go?
Does it expand? Or, it goes up.
Does not go up. Where does it go?
It lowers down.
It goes down. Okay, so the diaphragm contracts and it descends, it goes down, whereas the other muscles, what other muscles do we use to breathe? Sir, what other muscles do we use to breathe? Sir?
Oh, sorry, what?
What other muscles do we use to breathe besides the diaphragm?
I'm not sure.
I think you said only those have like the hugs up here, or like backups for the diaphragm not working.
Because the backups are different muscles, right? We have the diaphragm and these other muscle groups that also work every time we breathe. Sir? Sir?
The abdomen?
No, not the abdomen. Sir?
Intercostal muscle?
Intercostal muscles. Okay, so the diaphragm goes down as we inhale. The intercostal muscles, the muscles in between our ribs, they expand outward. Okay, so diaphragm goes down, intercostals go out, and that creates what kind of pressure, sir? All right, Miss, back to you. What kind of pressure does that create? Sorry? Nope. Sir?
I'm going to air pressure.
Well, yeah, it creates air pressure, but what kind of pressure? Is it positive or negative?
Negative.
Negative. Okay, so now we're going to have negative pressure, which allows us to suck that air in. Okay, so as that diaphragm goes down, intercostals go out, okay, the volume inside the chest gets bigger, and we got to fill that space with something, so what do you fill it with?
Oxygen.
Air, right? As we suck in. Okay, Now, with that, right, we got to make sure that those muscles are working properly. Now, for us adults, if those muscles start getting tired, then we start using trap muscles, right, to try to help expand that chest out a little bit more. Okay, but the trap muscles are a backup. With kids, do they have that backup?
No.
No. Okay, so for kids, they're still going to use their diaphragm, they're going to use their intercostals, but when those get tired, they don't have this tertiary backup for their traps, and then they start going to respiratory arrest. Okay, so we got to look out for that, and we'll see pictures of it later as far as what it looks like when they're actually using those accessory muscles. Okay, along with kids, we can have nasal flaring, especially younger kids, because kids are
Nasty.
freaks.
Oh,
Again, sir, they're freaks, not nasty. Okay, so, right, kids are freaks, right? Especially those younger kids, they're super freaky, right? And they breathe through their nose. So when they need more air, they're going to try to suck in more through through their nose. Okay, as they get older, they start to become more like us. And labored breathing, okay, breathing should be effortless, right? We're not sitting there having to work really hard to breathe, right? We breathe normally as is. But if that patient's sitting there having to concentrate on their breathing, then we obviously know that something's wrong. Okay, so these are things we're looking out for in addition to the rate, rhythm, quality, and if they need oxygen. Now, as far as O2 administration, okay, we already hit our 4 patients: chest pain, shortness of breath, ALOC, major trauma. Okay, but we can also look at rates as well. Now, the normal respiratory rate for an adult is 12 to 20 breaths per minute. Okay, so the breathing rate for an adult is going to be 12 to 20 breaths per minute. And sir, what is going to be controlling our rate of breathing?
Brainstem.
Okay, which part is brainstem? Which control center?
Respiratory.
Perfect, the respiratory control center. Sir, how does it control the rate of breathing in a healthy person?
I don't know.
Sir?
Looks the level of CO2 inside of us.
Right, through what kind of receptors?
Yeah, the receptors are wide, T-tau acidic, and how much CO2 is in it.
What would we call those receptors? What do we call those receptors? What do we call those receptors? What do we call them? What do we call those receptors that measure acid and CO2 in the body? I mean, they're measuring pH because they're measuring acid, but what are they called? Yes?
Isn't it the hypoxia driving?
Well, that's a backup if these receptors fail.
Oh, the primary. Chemo.
Right, it's the chemoreceptors. Okay, so the chemoreceptors are what's going to measure the levels of carbon dioxide and acid throughout the body. All right, miss, if we have higher levels of acid, how does that affect our breathing rate? Sir, how does that affect our breathing rate?
Our breathing rate would go up.
Goes up. Okay, so more acid, more respirations to try to get rid of the extra acid in our body. Okay, but if they're working on the hypoxic drive, they're now looking at levels of oxygen, right? And they are stimulated to breathe by low levels of oxygen. Okay, so for us as our healthy patients, okay, we're going to be breathing based off levels of acid and CO2 in the body. All right, so if our patient's breathing too fast, we can assume they might be a little acidotic. Right? They might have a little bit too much acid in their body. Okay, but we have to also think about that. If they just ran a mile, are they going to be breathing fast?
Yeah.
Yes.
Are they acidotic? Not necessarily, right? They're just breathing fast because they were doing something. So if I've got a patient who's sitting at home on the couch watching TV and they're breathing at 26 times a minute, is that a problem?
Yes.
Yeah. Okay. So we have to think about that. Okay, if they just did something, they're probably going to be breathing kind of fast. If they're in the sympathetic response, are they going to be breathing fast?
Yes.
Yeah. Right. So again, if they were doing something, they're probably going to be a little fast. But if they're chilling, not doing much, and they're still short of breath, breathing super fast, that's a problem. Okay. As far as breathing too slow, that can be caused by usually some type of CNS depression. Right. For example, opiate overdoses. Okay. Other CNS depressant overdoses, that'll cause slower breathing. Okay. We'll talk about the stuff on Tuesday as far as our different O2 delivery devices, right? Because we have to know the indications and contraindications for whatever devices I want to use for my patient. Okay, but for right now, until we teach you guys that stuff on Tuesday, you're totally fine with getting away with high flow oxygen, right, for any patient who needs it. Okay, but we are going to figure out different devices and use that. All right, so other patients who need O2, right, breathing too shallow, we already talked about ALOC, shortness of breath. Poor skin color. Okay, so patients who are cyanotic, which again means they're what color? Blue. Late sign of hypoxia. We want to give them some oxygen. All right. So when it comes to positive pressure ventilations, this is when I would have to breathe for my patient. Okay, so this is when I got to bust out the BMV and provide ventilations. So when it comes to indications for ventilations, if they're breathing too slow, so anything less than 8 times a minute, we ventilate. So we have a little rhyme. When ventilation's less than 8, we
Ventilate.
Okay, so respiration's less than 8, we ventilate. Okay, and that's regardless of their total volume. I don't care if they're taking nice big full deep breaths, but they're doing it 5 times a minute. That is not enough oxygen to maintain perfusion. Okay, so breathing less than 8, we ventilate. If they're breathing too shallow, regardless of the rate of breathing, okay, we also provide ventilations. So if they're breathing at 16 times a minute, but they're doing shallow breaths like that, that's not enough air into the lungs, so we have to go and breathe for that patient. Okay, and if they're breathing too fast with inadequate total volume, usually around the rate of 28 breaths per minute, okay, then we also provide ventilations.
For asthma patients, if they're breathing shallow, do you still give them oxygen or do you give them like the asthma medicine?
We'll still give them oxygen, and then we'll go for medications, and we'll talk about that next week.
How can we give them air both when they're breathing too little and too much? Because I thought when the body's breathing less, it means it's like it knows it has enough oxygen. Like usually if they're hypoxic, so it's guarding like the level of oxygen inside of them.
That's only one patient where that applies. Yeah. So any other patient, right, unless it's that one person, we want to give them oxygen. Even if for that one patient we still do, but we'll talk about that next week. All right, so this is when I got to bust out the BMV and provide ventilations for our patient. Okay, if they have a pulse and they're breathing, we do assisted ventilations. But if they have a pulse and they're not breathing, what do we do?
Rescue breathing.
Rescue breathing. What do we do?
Rescue breathing.
What do we do?
Rescue breathing.
Because they have a
Pulse.
they're just not
Breathing.
They have a
Pulse.
they're just not
Breathing.
So what do we do for them?
Rescue.
Right, we breathe for them by doing rescue breathing. Okay, so we'll go and take care of that in that circumstance. Now after B comes C, which will be circulation. We have a mnemonic that we use to help you guys understand what we are assessing for circulation. That mnemonic is COPS. What is it?
Cops.
Right, COPS, COPS. Now the slides we're going to cover are not in COPS order, right? But you can run your assessment in COPS order if you'd like, because it gives you a nice little mnemonic to understand flow. Okay, so the first thing we're going to cover is pulse. All right, now because we're doing ABCs, we know our patient's not dead because they responded to something. Okay, so we already know that they have at least a pulse somewhere, right? But we want to check to see if they have a radial pulse. What kind of pulse?
Radial.
What kind of pulse?
Radial.
Right, we want to check that radial pulse. All right, because it's on the furthest end of an extremity, sir, what is that term that we use that's furthest from the point of attachment?
Distal.
Distal, whereas closer would be
Proximal.
proximal. Okay, so we want to check a radial pulse because it's the most easily accessible distal pulse that we have, okay, without having to take off their socks and shoes. Okay, so we just want to know if they have a radial pulse if they're an adult. If they're an infant, we go for what? We go for the brachial, right? Because they got short little fat hands and wrists, so I can't get a radial pulse. And they got short little fat necks, and that's why we don't go for carotids either. Okay, so all we want to know is, do they have a radial pulse? That's it. Again, I'm not worried about numbers right now. It's, can I feel it? Is it fast? Is it slow? Is it about normal? Is it strong or is it weak? Is it regular or irregular? Okay, so first off, can I feel it? And if I can, is it fast? Is it slow or about normal? Is it strong or is it weak? Is it regular or irregular? Okay, we're checking for just a couple of seconds just to gather that information again. I don't care about numbers. All right, now as far as different qualities of the pulse and whatnot, okay, fast or slow, right, or about normal, it doesn't really tell me a whole lot about a lot of patients, right, but it will tell me again if their heart's working harder or less than it needs to. Okay, what really does matter, okay, is the quality or the strength. Okay, if we have a regular pulse that's normal, okay, we just call it strong. Okay, so a normal pulse will be referred to as strong. One that's not as strong, we refer to it as weak. Okay. So a weak pulse is one that's not as strong. Right, and if it's rapid and weak, okay, so now we have it together with the rate, that we call thready. What do we call it?
Thready.
What do we call it?
Thready.
And a thready pulse might be an indication of shock. Okay, so a patient who has a thready pulse, which is rapid and weak, might be an indication of shock. Okay, and that tells me the heart is pumping fast, right, to try to compensate for something, possibly shock.
So I know you said not to take that number. So then, at what point in our evaluation do we take the vitals out of the patient?
In the secondary assessment. Right? So a rapid and weak pulse is thready, might be an indication of shock. Now, as far as the patient having an irregular pulse, what kind of pulse?
Irregular.
Right, which is not the same as thready. Irregular just means that it's irregular. Okay, that tells me they have some type of cardiac problem. Okay, so that's the heart essentially throwing its tantrum, right, when it's hypoxic or having other type of issues when it's being a brat. Okay, so an irregular pulse, one that's not regular, indicates that it's a cardiac problem. Okay, but a thready pulse, right, means the patient might be in shock. All right, now if I can't feel a radial pulse, but the patient's obviously not dead, okay, that tells me they have low blood pressure. And we'll talk about that when we cover vital signs, okay, because the pulses are tied directly to our blood pressures. All right, as far as bleeding, okay, we're going to scan for obvious signs of bleeding. So P in COPS is pulse, O is obvious bleeding. And if we see it, we
Treat it.
we see it, we
Treat it.
We see it, we
Treat it.
Right, and as long as it's a life-threatening bleed. Okay, so the two major bleeds we got to worry about are arterial bleeds, which will be indicated by bright red blood that spurts out of the patient. And we got to worry about venous bleeds. Okay, they're dark red bleeds that ooze out of the patient. Okay, so arterial bleeds are bright red that spurt out. Venous bleeds are dark red that ooze out of the patient. All right, now treatment for those types of bleeds is the same. Doesn't matter if it's arterial or venous. We do the same thing. First thing I do is apply direct pressure. So I'll take my gloved hand. Okay, preferably take some 4x4 dressings. 4x4s are not pieces of wood, but gauze squares. You'll always think that. Okay, so we take some gauze squares that are 4 inches by 4 inches, and we place that onto the wound. Okay, applying my direct pressure. That's step one. Step two is we elevate the extremity and we wrap it up. Okay, so step one is apply direct pressure. Step two, we elevate and wrap. What do we do?
Elevate and wrap.
Right, we elevate and wrap. Okay, and I want to try to put enough pressure on that wound to stop the bleed. Okay, I'm not trying to make tourniquets out of that, but I want enough pressure to stop the bleed. I don't want it too loose to where it doesn't do anything. Okay, so step one, apply direct pressure. Step two, we elevate and wrap. And if that doesn't work, then we can go for the application of a tourniquet. Okay, so if direct pressure and elevation doesn't work, then we can apply tourniquets. Okay, years ago we used to put more pressure dressings on before we went to tourniquet application. Okay, but we don't do that anymore. And the reason why we don't do that anymore is because people screwed it up. Okay, they weren't putting enough pressure on the wound itself. So what would happen is that 4x4 dressing would slip off of the cut and therefore cause more bleeding. And as we're wrapping, we'd see blood coming out. We're like, oh no, it's still bleeding through. So they would take pressure dressings and put it at the exact wrong spot and keep wrapping and putting pressure, right? Causing patients to still bleed out, right? And then too many people were losing too much blood. So LA County says, you know what, screw it. If you guys can't get it right the first time, just put a tourniquet on and bring it to us, right? Now there's that old common myth of, oh, you put a tourniquet on, are they gonna lose that limb? No, okay, they're not. Okay, it takes 2 hours for skeletal muscle to start to die without oxygen. And here in LA County, is the patient going to be in the hospital within 2 hours?
Yes.
Absolutely. Okay, so that's why we go right for tourniquet applications nowadays if our initial treatments don't work. Okay, but when you're wrapping up, you should be able to apply enough pressure to stop a bleed. Okay, we'll cover that on Monday when we go over bleeding control, and we'll show you guys how to do it on another date. Okay, but those are going to be our different steps. As far as skin signs, okay, so when we check skin signs, we're checking color, temperature, and moisture. And that'll be S in COPS. And the best place to check skin signs will be close to the neck because we have easy access right here. It could also be the upper chest, the shoulder, right? Because it's all going to give us an idea of the core. We can go for the forehead as well. I'm just not the biggest fan of that, but it does work. All right, but we can go right here for the core. Okay, so again, we're checking color, temperature, and moisture. Now, patients who are pale, cool, and diaphoretic, okay, that tells me they're kicking what response?
Shock,
No.
What?
They're kicking what response?
flight, or
The
flight.
sympathetic.
Oh.
Right, they're kicking that sympathetic response because they might be going into shock. Okay, so pale, cool, diaphoretic skins may be an indication of shock. Okay, doesn't always indicate that because one, not every single patient who has those skin signs will be in shock. It just means they're kicking a sympathetic. And two, not every single type of shock is going to have pale, cool, and diaphoretic skins. We'll talk about that tomorrow. Okay, but for the time being, for right now, okay, if they're pale, cool, diaphoretic with the ready pulse, rapid and weak pulse, and they have the next part, which would be cap refill, that is delayed, those are all of our classic signs of shock. Okay, so if the ready pulse, that's rapid and weak, pale, cool, and diaphoretic skins, and delayed cap refill or capillary refill, these are all of our classic signs of shock. But, as we will talk about tomorrow, not everybody who is in shock will show those classic signs.
What does turgor mean?
Turgor is for moisture, so we're going to go ahead and pull back on the skin to see if it snaps back. All right, we really care about that for, again, patients who are dehydrated. So for right now, it's not going to mean much, but when we cover environmental issues, right, then we'll come back to what turgor actually is. All right, but checking the back of the skin to see if it snaps back. All right, now as far as capillary refill, that'll be the C in COPS. Okay, we're going to go and check the very tip of the patient's finger. Okay, cap refill is not the same as painful stimuli. I say again, cap refill is not the same as painful stimuli. Okay, I'm not trying to hurt my patients as I check cap refill, nor if I'm trying to hurt my patients do I want to check cap refill. Okay, when we're doing cap refill, we go for the very tip of the finger, and you push to see how long it takes for color to return after that fingertip turns white. Okay, so we go and push at the very tip of the finger to see how long it takes for color to return once we let it go. Okay, again, of course, nail bed pinch, we go down where the cuticle is and drive straight down. All right, now I know there's one of you thinking, what if our patient has nail polish? You go for the fingerprint and you do the same thing. What if my patient doesn't have fingers? You go for the stump. What if they don't have a hand? You go for the stump. Okay, we want to go for the most distal portion. That's what it's called. All right, you want to go for the most distal portion, right, to go ahead and check cap refill. All right. Now, as far as cap refill in adults, it doesn't mean really much by itself. Again, by itself, cap refill doesn't mean anything. But if I see cap refill with other things, then it may indicate a problem. Okay. Now, the reason why we say cap refill by itself doesn't mean anything. Okay, you can have delayed cap refill if you're cold or you're old. Okay, so if you're cold or you're old, you'll have delayed cap refill. And there's really not much wrong with you besides the fact that you're cold or you're old. Okay, but if I see cap refill with a rapid and weak pulse, right, and obvious bleeding and pale, cool, diaphoretic skins, for example, that tells me this patient's in shock. Okay, now again, this all goes back to that sympathetic response. As we activate the sympathetic response, what are our blood vessels doing?
Chilling.
No, they're not chilling. What are our blood vessels doing when we go into a sympathetic response?
Oh.
Contract.
They're constricting. What are they doing?
Constricting.
What are they doing?
Constricting.
Why are they constricting, sir?
To get the high flow, the blood faster to the body.
Not necessarily faster. Why are they constricting, sir?
The situation is. I'm asking because I blanked out before that.
Okay, sir. Why are they constricting?
I want to say, does it relate to the blood pressure going up? Heart rate going up?
Yes. Not really the heart rate going up, but the blood pressure. But why are we constricting blood vessels, especially like in the extremities?
Oh, to make sure that there's proper circulation.
Going to where?
To the heart?
Right. Okay, to the core of the body. Right? So our body, again, doesn't need blood in the hands or feet at all times. Okay, so we're going to start vasoconstricting or shunting, or what?
Shunting.
Shunting blood towards the core. Okay, so I squeeze all that blood out of my hand, start bringing it back to the core of the body to make sure that all my vital organs get perfused. Okay, now that can happen again if we're cold or we're old. We're still going to have vasoconstriction, but for different reasons. Well, it's really more for cold. right? As we're cold, okay, blood vessels, again, are constricting in the extremities to get that warm blood to the core to make sure our core organs don't get too cold. That's why when you go out in the cold, the first things that get cold are your what?
Feet.
Fingers. I don't know why you're going out barefooted, sir. Okay, right? It's usually the hands. Okay, so the hands, right, are going to start constricting, getting that blood away. That's why the fingertips go numb first. Same thing with your nose, right? We got capillaries in the nose that will constrict, and that's why they get cold. And that's why those are the first places to start having frostbite injuries. Okay, because there's not a lot of blood in that tissue. Okay, now as far as people that are old, right, they're going to have delayed cap refill because their heart simply isn't strong enough to push that blood all the way out to the fingertips anymore like they could when they were younger. And that's just a part of being old. All right, so if you've got an 80-year-old patient and you check cap refill and it's delayed, should you start freaking out? No, not at least based on that one sign alone. But if they got delayed cap refill, their heart rate is rapid and weak, and they're pale, cool, diaphoretic, should you start freaking out? Yeah, because that's a possible indication of
Shock.
possible indication of
Shock.
possible indication of
Shock.
And what does shock do to your patient?
Kills them.
So once we see it, we
Treat it.
say we
Treat
say
it.
we
Treat it.
So, miss, what would be the treatment for shock?
Increase of oxygen.
So what do we give them?
Oxygen.
Okay, so we give them high flow too. What else?
We put a blanket on them.
Uh-huh. Miss, what else do we do?
I don't remember the
Go down the line. Don't know either. Don't know either. Sir?
Sit them in the right position.
Proper position. Okay, so we place them in the proper position. Place them in what?
Proper
Place them in what?
Proper position.
So, sir, what if our patient has a spinal injury? What position do I want him in?
So high.
Supine, which means what?
Facing down.
No. That's prone, sir.
Oh yeah.
Yeah, so what is
looking
supine?
up.
So they're laying on their
On their back.
right. Okay, so if they got a spinal injury, you leave them flat on their back. If they have a respiratory issue, what position?
Well, what type of respiratory?
They can't breathe. That's their chief complaint.
You'd lay them in probably a phallic position.
Well, we don't lay them in a phallic
Or you
position.
sit 'em.
Sit them in a phallic position, right? Keep them upright. Okay. Now, for patients in shock and doesn't have any of those issues, sir, what position could I possibly use?
If they're not in shock,
No, if they are in shock, but there's no spinal injury and no shortness of breath.
you could put them in prone.
No.
Or supine.
No. Sir?
Is it left lateral? Or
No.
frontal groups?
No.
Whatever they're comfortable with.
Nope. I don't care about their comfort if they're in shock. Miss?
I thought it was gonna go over.
No, that's when they're on the backboard. And they won't be on the backboard in primary assessment. Sir?
I'm just spelling.
Nope.
Would it be supine? Back to supine?
Okay. But that's it? Just regular plain old supine?
With their feet up?
Okay, sir, what do we call that?
Elevated feet supine?
Make it way more complicated. Sir? Sir?
Is it shock position? The shock position.
Right, it's a shock position. What is it?
Shock position.
What is it?
Shock position.
Oh shit, that's right. They're in shock, so I might want to use a position that we use to fix it called shock position. Okay? Now, as far as shock position, how high are we elevating those feet?
Only 6 inches.
Just 6 inches flat?
Yeah, about 6 inches.
6 to 12 inches.
Right, 6 to 12 inches. Okay, so we want to bring those feet up 6 to 12 inches, right, to again use gravity to our advantage to help the body does what the body normally does, bring that blood from the legs back to the core of the body to maintain perfusion. Okay, I can't do that for patients who got spinal injuries because if I move their back, we're going to compromise their spine, right? And if I have a patient who's got respiratory issues and I lay them down, depending on the issue, right, they may drown or it's going to make it much more difficult for them to breathe. Okay, so we got to know what the proper position is for a patient who is in shock. Okay, now again, once we get to shock, we see it, we
Treat it.
see it, we
Treat
see
it.
it, we
Treat it.
Right. Okay, and like I was saying earlier, you guys always make this patient assessment about the questions and not the answers. Because on Friday, and I can guarantee you it's going to happen at least once, okay, somebody's going to go through in the scenario and be like, oh no, I think my patient's in shock. Hey, sir, do you have any disabilities I need to be aware of? Okay, without taking care of the shock that's right there in front of your patient. Okay, you need to identify what's going on with your patient, right, and take care of what's happening. All right, so move right on to the next step, right? Once you've taken care of shock, or we said, all right, there's no signs of shock, now we move on to the rest of my assessment. So D is going to stand for disabilities and deformities. Okay, we ask the patient if they have any disabilities while we look for any deformities. ask about disabilities, whereas we look for deformities. And please do not ask them if they're deformed. Okay, it hurts their feelings. Okay, so ask about any disabilities, right, where we're looking for any obvious deformities. And you can just be straight up and ask, sir, ma'am, do you have any disabilities that we need to be aware of? Right, medical history is not the same as a disability. I don't know why, but people think that diabetes is a disability. It's not. Okay, we're looking more for things like, complications following a stroke. Okay, so slurred speech, weakness or paralysis on one side of the body. Things like that is what we're looking for with disabilities. All right, we get to E, where I expose, visualize, and possibly palpate their chief complaints. Okay, so E is where we expose, visualize, and possibly palpate their chief complaints. Palpate means to touch or feel. What does it mean?
Touch or feel.
Right. Okay, so we have to expose the area at a minimum. So we have to remove clothing. I have to look at the area to look for any obvious trauma or anything that's abnormal. And then if I want to, I have the option of
Touching.
palpating. Okay, so palpation is completely optional, but it is strongly recommended. Okay, so expose, visualize, and possibly palpate all of their chief complaints. Not just the chief complaint, but all of their chief complaints. Okay, because can a patient have multiple chief complaints?
Yes.
Absolutely. I want to assess all of those in the primary assessment. All right, so we'll talk about palpation a little bit in the secondary, and on Friday we're going to show you the right way of going about doing it, okay, because you don't just poke and prod however you want. Okay, there are certain ways to palpate. Now after that, we develop our field impression, which is the second of 3 impressions we develop. Okay, with the field impression, it's almost a summary, it basically is a summary of everything in the primary assessment. Okay, so we talk about what I've seen, talk about what I've done, and I talk about what I want to do within the context of a secondary assessment. Okay, so talk about what I've seen, what I've done, and what I want to do as far as the context of a secondary assessment. Okay, and we're summarizing the macro, not the micro. We're looking at the big picture, summarizing that instead of every little tiny attention to detail that we notice about the assessment. Okay, this is probably the best way to formulate it, with a nice chronological order and a formula to follow. Right? That way you have some structure instead of just going around and just start listing off a bunch of random things. Okay, talk about what you've seen, talk about what you've done, and talk about what you want to do from that point forward, which would also include I, which is where I identify the patient priority in their transport decision. So I go blah, 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 blah. I have a critical patient, transport code 3, reassess every 5 minutes, or yada, yada, yada. I got a stable patient, transport code 2, check every 15 minutes. Okay, and as far as code 2 versus code 3, okay, that's in reference to how we transport and how we drive our patients. Code 2 will be regular driving conditions, like we drive every single day on the street, whereas code 3 is the fun lights and sirens. Okay, so code 2 is regular driving, code 3 is lights and sirens, code 1, before you ask, right, is when you're ready for service.
Do you ever do code 4 where you like run the lights and all that? Or is that code 3?
That's code 3. Code 4 is typically PD's way of saying all clear. We don't use code 4. All right, so I'll give you guys an example of what this field impression will sound like as we go through the assessment just a little bit, okay, but kind of focus on what I've seen, what I've done, what I want to do. I can also add an I, which will also state my transport decision, right, while we're setting up our game plan for the secondary. Okay. Now, as far as identification, right, of transport decision, we can look for a few things. Okay, namely if the patient's critical or non-critical. And to help in our decision of transport method, okay, we have to think about a certain time for our patient. Actually, 2 times. We have to think of the golden hour and the platinum 10. So the golden hour is in reference from the time of onset of injury or illness to the time of receiving definitive care. Okay, so the golden hour is the time of onset of injury or illness, the time of definitive care. So let's say, for example, I got a patient who's working on something and they fall down. Okay, let's say they fell 2 stories. The second they go on the floor, okay, that's when the golden hour starts. And from there, we have 1 hour to get them to definitive care, which in that case is not the ER, but the OR. Okay, I want to get them to the operating room where they can get the treatment that will save their life. Okay, and we have 1 hour to try to get them there to give them the best chance of survival. Anytime after that first hour, chances of survival start decreasing dramatically, depending on the type of injury that it is. Okay, now in order to try to stick with that golden hour, we have to follow the Platinum 10. What do we have to follow?
Platinum 10.
Okay, which is my on-scene time. The Platinum 10 is 10 minutes to assess my patient, stabilize my patient, and package them for transport. Okay, so we would have 10 minutes to assess my patient, to stabilize my patient, and to package them for transport to get them to the hospital to try to beat that golden hour.
If you're supposed to do that whole thing in 10, how long should our first assessment take usually?
The whole primary assessment should be done in about 90 seconds or less. Okay, now keep in mind, again, when we're on scene, we're not sitting there, all right, I'm going to develop my general impression of my patient, but we're doing it all simultaneously. Right? So airway, breathing, circulation can be done in a matter of 15 seconds. Right? As long as there's no issues, and if there is, we take care of that. Right? Disabilities, deformities, we ask about it. E, exposed visualized palpate. Formulated with field depression. Right? For class purposes, we're going to say it's to ALS or somebody else, but I can also do it in my head. Right? Where I'm just recapping, okay, what do I got? What do I got to do? All right, cool. And then we go to work. Right? So in the field, this whole assessment doesn't take very long. But for class purposes, if you guys didn't say it, you didn't do it. So you got to say it and do it. Okay. Now, as far as critical patients, okay, these are examples of some people we want to take code 3. So shortness of breath patients, obviously, right, want to take them to the hospital ASAP. Poor general impression. What that means is our patient pretty much looks like shit as I walk up to them. Right? Again, my general impression, I haven't even talked to them or seen them or touched them yet. I've just seen them. So if I got a patient who's, on the floor, they're cyanotic and they're laying in a pool of blood, oh crap, that's a problem. Okay, and that right there is enough to say I got to go to the hospital code 3. Okay, unresponsive and no gag reflex. This means that they cannot maintain their airway, and of course, airway is king. Airway's what?
King.
Airway's what?
King.
So if they can't maintain an airway, right, that's a problem. Okay, so if they were to throw up, right, and they can't maintain their airway, they can aspirate or suck in that vomit, and that'd be really bad. Patient with severe chest pain, signs of poor perfusion, aka shock. Okay, that's going to be a code 3 call. Complicated childbirth. Go ahead.
What's the code for when the sirens are on, but it's not making noise?
That's a silent code 3, but we don't really use that very often. All right, so complicated childbirth. We'll talk about those when we cover childbirth. Any uncontrolled bleeding, which means we had to put on a what?
The gauze?
No. Tourniquet. Yeah, if I got to put a tourniquet on, that's an uncontrolled bleed. We go to the hospital code 3. Okay, because with my direct pressure and elevation, that should be enough to stop most bleeds. All right. Responsible can't follow simple commands. That means that they're altered, right? Severe pain, and as well as the inability to move any part of the body, okay, which can include a simple fracture, right, with compromised CMS. Compromised what?
CMS.
Which stands for?
Circulation motor sensor.
What is it?
Circulation motor sensor.
Right. Okay, so if they got some weird funky forearm fracture out at some weird angle and they don't have CMS, okay, that can be an indication for code 3 transport as well. Okay, because there's a chance that they may lose that extremity, which we want to try to preserve life and limb whenever possible. All right. So again, these are just a few examples of when we'd want to go code 3. All right. So as far as the primary assessment, okay, here we have it again. Right. Again, you guys got it in a flow chart. So I'm going to go ahead and run through a primary assessment with you guys so you can hear what it sounds like, and then we'll give you some time to practice with each other, and then we'll start getting into our secondary assessment. Okay. So Ramon, I'll use you again, but this time you have an abdominal pain in your house. Okay. So call out to his house. He's got abdominal pain. So the first thing I do for every call is going to be our what?
BSI.
Going to be our what?
BSI.
Stands for?
Body substance isolation.
And you wear that because everybody is? Nasty. So I got my BSI on. Now I'm going to go through my scene size up using what mnemonic?
Penman.
What mnemonic?
Penman.
What mnemonic?
Penman.
Penman. So I want to make sure I'm safe, make sure my partner's safe. I want to make sure the patient's safe. Because I'm going to his house, I do have to worry about environmental hazards. I have to worry about the patient being a threat, any crazy family, any animals they have, possible weapons, possible electrical, chemical, or fire hazards. Okay, just a few things when I'm going to somebody's home. As far as number of patients, because it's an abdominal pain, how many patients do I think I'd have?
One.
Just one. Right? Mechanism of injury? Maybe. Nature of illness? Possibly. We don't know yet until we get there. As far as additional resources, at the very least, who do I need to call for?
ALS.
ALS. Right? And then anybody else that I need to call for, I'll determine when I get there. As far as my hazards, again, maybe PD, maybe animal control, but we'll see. All right? Now, lastly, need for extrication or spinal motion restriction. With the chief complaint of abdominal or dispatch calls abdominal pain, I probably don't need extrication, and I probably don't need SMR either, but still want to be open to those possibilities. So once I get on scene, I'm going to go to the patient's house. Okay, we knock on the door because we're not the police. We can just kick doors down. Okay, we knock on the door. We introduce yourself as the ambulance, as the what?
Ambulance.
Right, and let's say we get permission to go ahead and go in our patient's house. So now that I've walked in the house and I see my patient for the first time, okay, we start our primary with a general impression. So I have a male patient in his early 20s. He's sitting up in the Fowler's position. Unknown MOI, possible NOI, and this might be life-threatening. Okay, so now my general impression is complete, and I start approaching my patient and checking his responsiveness using what mnemonic? ABU. And as I approach, he is alert and he is tracking me, so I can move on to my introduction. Now, as we're doing that, okay, you guys are going to be taking a knee. I'm going to stand so you guys can all see me, but as you run your assessment, take a knee. Okay, because when I'm with a real patient, do I want to tower over them? No. Okay, I'm going to make them scared, not make them comfortable. By getting down to their level, it's going to make them feel more comfortable. Okay, so we take a knee and we start running our assessment. Hi, sir. My name is Vince. I'm an EMT. This is my partner, Casper. What's your name?
Ramon.
Ramon? All right, Ramon, what's hurting you today?
My stomach has been hurting me.
Your stomach's been hurting? Is it cool if we help you with that?
Yes.
Awesome. So again, he knows who I am. He knows who my partner is. I know who he is. I have his chief complaint of abdominal pain, and I have consent to treat. Okay? Now, in this case, because I have a partner, right, we can split up our workload a little bit. We'll say that Casper is going to start working on vitals. Okay? Now, as far as the secondary, and we'll talk about this in a bit, we can split it up a little bit. But as far as a primary assessment, it only takes one person. Okay? So I'm going to go and run through primary. We'll say Casper's working on vitals now. So because he's talking to me, I know he has what kind of airway? Patent. Kind of airway?
Patent.
Kind of airway?
Patent.
And I know that because he was talking. So I can move on to B for breathing, where I ask myself, what question?
What does it sound like?
No. The question I had you guys repeat a half dozen times that you already forgot.
Does my patient need oxygen? And how do I administer it?
Thank you, miss. Everybody, what is it?
Does my patient need oxygen, and how do I? And if so, how do I administer?
Let's try this again. What do we ask?
If my patient needs oxygen, and if so, how do I administer it?
What is it?
Does my patient need oxygen, and if so, how do I administer
Well, that was even worse. What is it?
Does my patient need oxygen, and if so, how do I administer it?
Okay, fine. Let's do it again. What is it?
Does my patient need oxygen, and if so, how do I administer it?
One more time.
Does my patient need oxygen, and if so, how do I administer it?
Okay, so we've said it about 12 or 13 times now. Is this an important question to ask?
Yes.
Yes, and every single time you get to this step, you need to ask yourself, what question?
Does my patient need oxygen, and if so, how do I administer it?
Right, in this case, does he need oxygen?
No.
No, right, he's not having chest pain. He doesn't appear to be short of breath. He doesn't look like he's altered yet, and I don't suspect major trauma. So at this point, I can withhold oxygen. But if he was complaining of chest pain, he was showing signs of shortness of breath, he appeared to be altered or I suspect major trauma, then I want to go and hook him up to high flow oxygen. Okay? So now that B is done, I'm going to move on to C, where I check for circulation using my mnemonic of COPS. All right, Ramon, I'm going to go and pitch your finger. Is that okay?
Yeah.
All right, so when you go and check his cap refill, we'll say it's immediate, so it's less than 2 seconds. That's good. I'm going to scan for obvious signs of bleeding. I'm not seeing anything. So I'm going to go and check your pulse here. Right? So he's got a strong and regular pulse. I'm going to go ahead and peel back my glove and touch your neck. Is that cool?
Yes.
All right, so we'll go and check his skin signs there, right? And he's normal, warm, and dry. Okay, so based on what I found in COPS, he doesn't appear to be in shock. But let's say I checked his COPS, he had delayed cap refill, right? I didn't see any obvious bleeding, but he had a rapid and weak pulse that we call thready. What do we call it?
Thready.
And he's pale, cool, and diaphoretic. Ah, crap, these are all signs of?
Shock.
All signs of?
Shock.
All signs of?
Shock.
And if we see it, we?
Treat.
So I want to give him high flow,
Oxygen.
cover with A,
Blanket.
and then put him in the?
Proper position.
What kind of position?
Proper position.
Right, the proper position for whatever situation he has. Okay? Again, we have to take care of that shock right then and there if we see it, because shock is what to your patient?
Kills.
Kills them. All right? So, again, recapping, no signs of shock. So now I can move on to the rest of my assessment. All right, sir, do you have any disabilities I need to be aware of?
No.
Okay, a little hesitation, sir. All right, and then after that, we're going to go ahead and assess for any obvious deformities. Okay, we don't see any obvious deformities. Again, don't ask him, sir, are you deformed?
I'm not deformed.
Okay, good. Don't cry, sir. It's okay. All right, so we'll go and assess for any obvious deformities. After that, I'm going to move on to E, where I expose, visualize, and possibly palpate, okay, the chief complaints. All right, so at the minimum, I got to expose the area. So we're going to lift up the shirt, visualize the abdomen. Okay, we're going to make sure there's no obvious signs of trauma. And then if I want to, again, we have the option to palpate. Now, me personally, I like to palpate in the primary assessment. And the reason why I like to palpate in the primary is it gives me an idea of what I need to expect in the secondary. Okay, so if you don't want to palpate, that's totally fine, but it's strongly recommended that you do. So let's say that we do palpate his abdomen, and he's got pain to his lower quadrants on palpation. Okay, now based on the fact I'm not seeing obvious signs of trauma, right, it's probably medical, but I still can't rule out traumatic abdominal pain yet. So now I'm going to move on to my field impression, talking about what I've seen, what I've done, what I want to do. So let's say we have ALS who shows up and they don't have any idea what's happening on this call. Okay, I want to fill them in so that way they have an idea of what they need to do, right? So it's going to sound something like this. We have a male patient in his early 20s. We found him sitting in the Fowler's position. He was complaining of abdominal pain. Our patient appears to be stable. I'm not seeing any signs of shock. I did expose and palpate the abdomen. There was no obvious signs of trauma, but he did have pain on palpation to his lower quadrants. Since he appears to be stable, I like to go and run my secondary assessment on scene. And when we transport, moving on to I, when we transport, I like to transport code 2 and check his vitals every 15 minutes as we go. Okay, so we're just going in and summarizing everything we have in that call. Okay, focusing in on the big picture, not the little itty bitty tiny attention to detail like, oh yeah, he's wearing white Crocs and apparently it's his birthday based on the shirt, right? So we don't want to mention things like that. Okay, it's going to be focused on the important information that they would need to know. Okay, now as far as getting in a field impression to sound like that, it takes a lot of what?
Practice.
It takes a lot of practice. Okay, and that's totally fine, right? What we don't want you guys doing is he's got a tummy ache, and that's it. Okay, you've got to be able to at least paint a somewhat decent picture of what's going on and what you're going to want to do from that point forward. Okay, and that's what you guys are going to practice right now. All right. Now, as far as your practice scenarios for the time being, it's just a matter of you guys going through the assessment. Okay, you guys only know like that much information, believe it or not. Okay, so for right now, it's not about solving problems in your assessment, which it will be later on. But for now, it's just a matter of can you run through the structure of that assessment. Okay, so I want your practice dispatch calls to be very simple, straightforward calls. You guys can do a basic abdominal pain. Okay, you guys can do some basic chest pain or basic shortness of breath. Okay, if you want to do trauma, a basic arm or leg injury. Okay, nothing super critical like a pregnant lady who's delivering, who just got decapitated, yet she's a diabetic, while she's on Mount Everest. Okay, nothing like that, just simple, straightforward calls. Okay, we're going to run this for about 20 minutes, right, and then we'll start getting into the secondary assessment. Okay, so you guys should be practicing with each other. Now, as far as practicing with your assessments, okay, again, you guys should not be practicing your assessment like this. Okay, BSI, personal point of view, environment. That's not practicing an assessment. Okay, you have to verbalize it with somebody else. Okay, and that's why you guys are the best ones to practice with, because you guys all know the standard of your patient assessment. Okay, if you were to practice with your roommate or somebody else, okay, they're going to be like, oh, cool, man, you're doing great. Because they have no fucking idea what you're actually responsible for knowing when you're writing your assessment. Okay, but you guys can call each other out. You didn't check skin signs. They're going to fail your ass if you do that again. Okay, because you know what has to be done. All right, so like I said, 20 minutes. Okay, you guys can just work on primaries, and then we'll start jumping to a secondary. All right, so I'll leave this up. If you guys have any questions, of course, raise your hand and ask. Okay, but you guys can get started.
I'm gonna pass it to the rest of you.
Wait to be like, oh no, you can't. Yeah. Okay, I'm out. I'm gonna leave now. Let's go.
Just lots of stuff.
I think like
When are we going to do this today?
No, we're doing this more on Friday, he said. Like, we're gonna actually like more do it today. But we're like, this is like, I guess it's the lecture day. This is Friday's day.
The online book, are these valid for DNR? Or do you still need the paper?
They would still need paper. Yeah, so it says right there, they have polls called blah, blah, blah. So, like, let's say, for example, if you have that, they would have a contract for somebody like that. So, essentially, if that's the case, we call it maybe the power of and then we just talk about that.
But this is not something.
It's not a big deal, yeah.
You want to make sure.
So one, for using which polls to check like guidance like that. What if, because we asked for deformities and disabilities afterwards, what if they have a disability with like more advanced conflict of 30 days or something like that, and you feel that, oh, you treat that as actually already medication.
That's why we look for other things. That's why no one particular thing in cops is enough. We have to have the whole picture.
Polls.
Yes.
First thing that pops up.
Stuff like the ventricular restriction, so the blood's going away from the
Even though we just did that. Is that what you did first?
Yeah. The last couple of scars, the red last less
so they don't assume it's gonna take my continue over here.
Or like
That'd be trauma.
This is trauma.
So if
It could be anything.
say,
Okay. And then right at the top.
there's trauma.
Yeah.
Yeah, so that'd be MLI.
A little bit harder.
And then
But yeah, watch.
nature.
And you'll see it like turn
So, like,
white and then
altered. That's
back
like
to red.
if
and then I check for your other.
let's say that they're beneficiary, so they were having a
Good.
heart attack.
Okay, so then I ask you,
That's the next one. So it can be
No.
either MLI or NLI. or
Okay.
And then at the same time, you're checking for deformities.
Actually, bro.
And then
Nice to meet you, bro. My bad.
so
Wanna go
single
first?
position.
Okay,
So
15 minutes.
in the same.
That
There's a lot.
Yeah,
Oh, no.
I don't remember when that comes up, but he was
There's
checking
some,
You don't gotta worry about the season, right?
What are the other positions?
I can try if you want to be the dispatch.
skin sensitive.
No, and what?
That's what you know.
So I have to take notes.
So after
Yeah.
So.
Right? No, right? So I can do it in this order and be totally fine. Right? But I don't want to delay care by doing vitals that I don't have to do first. So, starting off with blood pressure. Okay, there are two types of blood pressure that we're assessing. There is a systolic blood pressure and a diastolic blood pressure. Okay, so we're checking a systolic and diastolic blood pressure. All right, now as far as getting a blood pressure, okay, for us, we're going to auscultate a blood pressure. What are we going to do?
Auscultate.
Auscultate. Okay, and auscultate means to listen with a stethoscope. Okay, so we're going to auscultate a blood pressure. So we listen with the stethoscope. Yeah, auscultate. A-U-S-C-U-L-T-A-T-E. Something like that. Okay, so we're going to auscultate a blood pressure. We'll see it later. So as far as the auscultation of a blood pressure, okay, it's going to be an accurate way of doing it without actually using a cardiac monitor, right, that a paramedic would have. Okay, now it's hard for me to describe it, and you guys get it right now, and that's totally fine. It's something you have to do to actually understand it. Okay, but when we auscultate a blood pressure, what I'm doing is I'm using the blood pressure cuff essentially as a tourniquet. So we pump it up, and there's an air bladder that fills up, and it compresses the brachial artery. Okay, so what it does is it basically shuts down blood supply on that brachial, right? And what we're doing is we're listening. What are we doing?
Listening.
With a stethoscope, hence auscultation. We're listening for that blood flow to return. Okay? Now, the first sound that I hear when that blood flow returns, that is going to be our systolic blood pressure. Okay, and that's what's happening during the systolic phase of the heart when the ventricles are contracting. Okay? So as you're auscultating, it's gonna be the first loud thump, really. That's what you hear. You're gonna hear this when you auscultate. Right? That's what it's gonna sound like through your stethoscope as you're listening. Those first few soft thumps we don't really count, but it's that first big thump that we're gonna count. Okay, we're gonna be looking at a gauge as it's going down while we're listening for their blood pressure. And wherever that needle's at when I hear that first thump, that'll be recorded as our systolic blood pressure. And we document it as an improper fraction, big number over small number. Okay, systolic over diastolic. So with this example, okay, the systolic blood pressure is 124 millimeters of mercury. We don't really use the units when we talk, right? But it's 124 over 72. And the diastolic number, we get that based on the last soft sound that we hear before it completely goes away. Okay? So that's how we document our blood pressure. And again, when you guys do it on Friday night, you'll actually hear what I mean, okay, as long as you do it properly. Now, I need to palpate where the brachial pulse is, and we talked about it yesterday. The brachial artery comes underneath the bicep, and it bifurcates, or it splits, pretty much right at the head of the bicep, okay? And one keeps going straight like this, and it stays nice and shallow, where it's close to the skin, and then it goes deep, and then we don't really feel it after that. But we have another part that branches out this way. It stays deep, but then it becomes more shallow, and then becomes your radial pulse. Okay, so you kind of sort of have to turn on X-ray eyes sometimes if you can't palpate, which means to feel. Can't what? Feel or palpate the brachial pulse. Okay, now like I said, you can palpate a brachial pulse right around here for most people and get a blood pressure. That's fine. I'm not a huge fan of that because if you got patients with big biceps or big arms, you may not be able to really palpate that brachial pulse. Okay, but if you come down right here just below the crease of the elbow, that brachial pulse or brachial artery rather stays pretty shallow for most of us, and it's pretty easy to palpate. Okay, now with some patients, if I can't palpate it, again, now I turn on my x-ray powers, and I know that, okay, the brachial pulse comes underneath their bicep, it comes up, and it should be somewhere in about this little $half circle on the medial aspect. Which aspect?
Medial.
Which means it's closer to the middle of the body, right? Medial aspect of their forearm right here. Okay, so then I just put my stethoscope head on there, and then I listen to see what's going on. All right, so again, it's complicated, I get it, totally understand. When you actually do it, it'll make more sense. Now, as far as the difference between the systolic and diastolic blood pressure, we call that the pulse pressure. What do we call it?
Pulse pressure.
Okay, now we're going to talk about pulse pressures tomorrow, but you do need to at least know the definition of a pulse pressure. It's the difference between your systolic and diastolic blood pressure. Okay, we basically subtract your diastolic from your systolic, and whatever number it is we get, that's the pulse pressure. Because tomorrow we're going to talk about conditions where we have a widening pulse pressure as well as a narrowing pulse pressure. Okay, and even though they're completely two separate conditions, you guys will screw them every freaking time because it's the only things we talk about in relation to pulse pressure. But you see pulse pressure, and then you just figure out which one it is, and you usually get it incorrect. Okay, but you need to understand why one patient has a widening pulse pressure and why another patient has a narrowing pulse pressure. Okay. Now, as far as the diastolic pressure, okay, that's during diastole when the ventricles are relaxing and refilling. Okay. With that, it's basically resistance of the blood vessels. Okay, it's measuring PVR, or peripheral vascular resistance. Okay, now for one of our types of shock, being distributive shock, which is a pipe problem, kind of problem.
Pipe problem.
Okay, that's where we have widespread vasodilation. Okay, remember, do we have enough blood in our body to maintain decent pressure when the vessels are fully dilated? No, we don't. Okay, and that's why the patients go into shock. Okay, so with those blood vessels being wide open, the pressure in those things is really, really crappy. Okay, so we're going to have a lower diastolic blood pressure, right, which means the blood vessels can't move that blood back to where it needs to go. Okay, so we'll talk about that in our distributive problems tomorrow. Now, as far as palpating a blood pressure, in certain situations we can palpate a blood pressure, which just means to feel. Okay, now this is only done if I can't auscultate a blood pressure for whatever reason. I left my stethoscope in the rig, or it's too noisy on scene to where I can't hear. Okay, we can do a palpated blood pressure. Now, the palpated blood pressure, it's not very accurate, but it gives us a ballpark of what their systolic blood pressure is going to be. Okay, and with that, I don't get a diastolic pressure either. Okay, as far as documentation, I would write it as number over P. So, for example, it would be 128 over P for palpated blood pressure. Okay, that way we see it on documentation that, hey, we couldn't auscultate, right? For whatever reason, I couldn't auscultate, but I did a palpated blood pressure, and it came back as about 128. And then later, a couple minutes later, when I got them in the back of an ambulance, their systolic blood pressure was actually 114, and their diastolic was 68. Right? That way we kind of have an idea of where it's at. Okay? Now, when it comes to pediatric patients, we generally don't get blood pressures in kids because there's a different way of assessing them if they have adequate perfusion or not. Okay? Especially for kids under 3. Right? If you guys have dealt with kids that are under 3, do you think they're going to sit still as you squeeze the shit out of their arm? No. Absolutely not. Okay? They're not even going to sit still, period. Okay? So, there's other ways of assessing if they're decently circulating. But if I got a kid who's really sick and not doing anything, then you want to get a blood pressure. Okay? And we'll talk about that when we cover pediatrics in a couple weeks. So, these are the normal systolic ranges for different patients. Don't focus too much on kids or infants. Right? Focus on the adults. Okay? Now, for us as adults to maintain a decent perfusion, okay, to make sure we're getting enough blood throughout organs or tissues, okay, we have to have a decent blood pressure. The average systolic range for an adult is 90 to 140. Okay, so the average systolic range for an adult is 90 to 140. So if their blood pressure is somewhere between 90 and 140 for their systolic blood pressure, that's called normotensive. What's it called?
Normotensive.
Right, normo with an O. Okay, so it's normotensive. Okay, normal meaning normal, tensive referring to pressure. So that just literally means, it's a normal pressure. But if their blood pressure is less than 90, we call that hypotension. What do we call it?
Hypotension.
Hypo meaning low. What does hypo mean? Low. So whenever you see hypo in front of something, that just means low. Whatever it is, it's low. Hypotension is low blood pressure. Hypoxia, even though it's not pronounced hypo, it's still in there. Hypoxia is low oxygen. Hypoglycemia, low blood sugar. Okay, so hypo just means low. In the case of a blood pressure, if it's over 140, we call it hypertension. What do we call it?
Hypertension.
Right, hypertension. Because hyper means
A lot.
high.
High.
Yeah, hypo is low, hyper is high. Okay, so hypertension just means high pressure. Hyperglycemia, high blood sugar. Okay, now patients who are hypo or hypertensive may be an indication of something, right? But those are changes that we'll see in addition to other signs or symptoms. Okay, and we'll talk about blood pressure in relation to shock tomorrow. Okay, and again, you can identify abnormal if you don't know what's normal. Okay, for kids and infants, their blood pressure is lower because they're not dependent on blood pressure nearly as much as we are. Those kids rely on cardiac output. What do they rely on?
Cardiac output.
Which is the fact that they got to move blood as quickly as they can around their body. Okay, that's what kids use to maintain perfusion. That's why the blood pressures aren't super duper relevant for kids. Okay, because they're going to perfuse a different way. Now, as far as eyes, okay, we're going to be checking their pupils. And these right here on screen are abnormal pupil reactions. These are things that we shouldn't see. And if we do see something like this, that tells me they have problems with their
brain.
Because eyes are windows to the brain. Okay? So, first off, we have fixed reaction with no reaction to light, or fixed pupils with no reaction to light. Okay, so that means the pupils don't do anything when I shine a light in them. Okay, so fixed pupils means they don't do anything when I shine a light in them. So that can mean a few things. One, the patient's probably dead, because the eyes don't do anything if they're dead. The patient might be blind, or it's an artificial eye that we're viewing. Okay, so they're dead, they're blind, or it's a fake eye that we're looking at. Okay, if they have fixed reactions. As far as dilate with the light and constrict in the dark, that's opposite of what should normally happen. Okay, when we shine a light into the eyes, the pupil should constrict. Okay, the pupil should constrict, limiting the amount of light going into the lens so we don't fry our retinas. Okay, and when we get into a darker environment, the pupils are going to dilate so we can try to let in more light. Okay, but this is opposite. Okay, if we shine a light and the pupils get bigger, okay, that's a problem. That usually indicates some type of head injury, be it from trauma or strokes. Okay, but there's something up with the patient's brain. Specifically, the occipital lobe, since that's responsible for vision. All right, reacting sluggishly. That means the pupils will change the way they're supposed to. They just do it very slowly. Okay, the pupils should react pretty quick, right, when you're shining a light or taking light away from them. Okay, we call that brisk. But sluggish reactions means that they're going to do it very slowly. All right, and we also have unequal pupils. Okay, so that's when the pupils aren't the same size. That could be an indication of a head injury or stroke. All right, so anytime you have something wrong with the eyes, again, that indicates there's probably something wrong with the brain. Okay, so here we have a couple pictures of what different pupillary signs would look like. So up on top, we have constricted pupils. Okay, if they're really, really small, we call them pinpoint. What do we call them?
Pinpoint.
Because they're really, really what?
Small.
Really, really small. Okay, so that would be an indication of CNS depression. So for example, if they're overstimulating the parasympathetic response, okay, they will have pinpoint pupils. If they're overdosing on certain opioids, they will have pinpoint pupils. Okay? Dilated pupils would be the opposite. Okay? So if these are downers, we see these with uppers, or they're stimulating what response? The sympathetic. Right? They're activating that fight or flight, right, with pupillary dilation. Okay? Patients who are on hallucinogens as well, they will have dilated pupils. Okay? And that's why I say when it comes to drugs, the eyes tell no lies. Right? Because they're not going to lie to us as far as what drug they're on. Could the patient lie to us? Absolutely. Okay, they're not going to tell us all the time. I just snorted meth, right? But the pupils are going to tell us that along with their vitals. All right, and then again, here we have unequal pupils. So one eye is normal, and then one eye is large. Okay, and that tells us, again, some type of head injury, be it traumatic or non-traumatic.
With dilated, would you say that they're in CNS elation, or is that not a term?
We don't really say that. Yeah, we just say they're in the sympathetic response. Right. So, as far as normal pupils, we don't say, oh, pupils are normal. Okay, instead we use a mnemonic called PEARL, which is pupils are equal, round, regular, and react to light. And you might see PEARL spelled out in different ways, but they all basically mean the same thing. So here we have it spelled out with 2 R's. You might see it with just 1 R, like the regular word PEARL. You might see it PERL. Again, they all mean the same thing. Okay, the pupils are equal, round, regular, and react to light, which is a fancy way of saying they do what they're supposed to do. Okay, they're of equal size. They move around properly. When I shine a light in them, they will constrict briskly. If I take the light away, they will go and dilate briskly. Okay, so there's nothing wrong with the eyes, right? And you can just say pupils are PEARL. Everybody in medicine knows what PEARL means when you're talking about the eyes. Okay, but if you go to a doctor and you're like, oh, his eyes are good, okay, does that make you look smart? No. Okay, that's why you got to know how to use proper terminology. All right, so as long as pupils are normal, we say that they are PEARL. Now, as far as lung sounds, okay, again, 4 lung sounds, magic number being 4. Okay, we want to try to break it down. And when we start talking about our different respiratory emergencies, I feel the best way to start breaking them down is based on the lung sound that you would hear for those different respiratory problems. Okay, once we start getting into stuff tomorrow, okay, the best way to get this down is simply break it down to different categories. Okay, break down your different kinds of shock. Break down your different respiratory emergencies. Okay, cardiovascular is pretty much already broken down as it is. Neurological emergencies, break them down separately. Okay, and then you can further break it down to its final little things, and then you can essentially rebuild it back up, right, to help understand the difference of things. Okay, so as far as our lung sounds, first one we'll talk about is rails, also referred to as crackles. Rails is kind of the old school classic term. Crackles is more of the new school. Right, but rails, aka crackles, indicates fluid in the lungs. Okay, so rails indicates fluid in the lungs. And we have a term for fluid in the lungs. Sir, what do we call fluid in the lungs?
Pneumonia?
Pneumonia can cause fluid in the lungs, but that's not what we call it. Want to give it another shot?
I don't know.
Sir, what do we call fluid in the lungs?
Emphysema?
Nope, that's trapped air. Miss? It's fluid in the lungs.
Pulmonary edema.
Right, pulmonary edema. Pulmonary what?
Pulmonary edema.
Pulmonary what?
Pulmonary edema.
Right, pulmonary edema. So edema, for our purposes, usually means fluid. Sometimes it means swelling. Depends on how you use it. Right, but in the case of pulmonary edema, that's fluid in the lungs. All right, now if this patient has fluid in the lungs, do I want to lay this patient down? No, right? Because again, we can end up drowning that patient by causing that fluid to shift, taking up more surface area, and then kill the patient. Okay, so you want to have them sitting upright in a Fowler's position. Okay, there's quite a few things that can cause rails to occur, and we'll talk about that on Tuesday. We'll talk about another cause tomorrow because it is one of our kinds of shock. That's why if they're in shock and they have respiratory distress, they might have rails, and you want to keep them up in the Fowler's position. All right, next up is wheezing, which is caused by bronchial constriction, sometimes referred to as bronchospasm. Okay, and that's when the smooth muscle, kind of muscle?
Smooth.
All right, so when the smooth muscle in the respiratory tract begins to constrict. Miss, what part of the brainstem controls our smooth muscle? Which control center?
The back of
No. Miss? Sir? Sir? Part of our brainstem controls the smooth muscle.
The vasomotor system.
Right, the vasomotor center. Which center?
Vasomotor.
So, besides the respiratory tract, where else do we find smooth muscle in the body?
You find it in the lung or the eyes
Okay, so the pupils.
and in your digestive system.
Okay, where else? So we got respiratory tract, pupils.
Yeah.
Well, that's part of the GI tract. So where else? Sir?
Blood vessels?
The blood vessels. Okay, so we find it in the respiratory tract, right? We find it in the GI tract, okay, which also includes urinary. Okay, we find it in the blood vessels and the pupils. Okay, so again, the vasomotor center is going to send signals to constrict or dilate those smooth muscle as needed. Now, if we have constriction of the smooth muscle in the respiratory tract, especially in the lower airway, okay, that's where we get wheezing, right? And two conditions that can cause wheezing will be anaphylaxis, okay, which is a severe allergic reaction, and asthma. Okay, so anaphylaxis and asthma will cause wheezing. There's a few other infections we'll talk about later that can also cause wheezing, but those are the big two. All right, and that's kind of what you have to look out for to indicate what type of issue it may be. So when you guys start getting more complicated scenario-based questions, which will be coming up next week, okay, you have to look out for specific indicators in your question to provide clues to the correct answer. So for example, if I see wheezing in the question, okay, and I have either anaphylaxis or asthma as one of my answer choices, that's probably it, right? Because we're going to be adding in other respiratory issues that aren't going to have wheezing as different lung sounds, okay? And that's when we might break it down. Okay, cool, right? I know rails, there's going to be fluid in the bases. There's a few causes of that, so I'll make a flashcard for that. I'll make another one for wheezing, so it'll be asthma, anaphylaxis, and a couple other things we'll talk about later. I'll write that down on a flashcard. Another one for rhonchi, and rhonchi will be an indication of a lower airway infection. Okay, so rhonchi will be an indication of a lower airway infection, such as pneumonia. Right, so if I hear rhonchi, and that's how we pronounce it, not raunchy, but rhonchi. Okay, rhonchi is an indication of a lower airway infection. And the best way to describe rhonchi and what it sounds like, it's a very coarse bubbling sound. And because it's infection, just think about when you get sick and you have that first phlegmy cough in the morning. Right? That's kind of what rhonchi would sound like. Now, rales is more of a wet, bubbly sound, right? Where it's more of a finer kind of sound. In the field, it's really hard to tell the difference between rhonchi and rales. But for class purposes, right, rhonchi is that thick, coarse kind of phlegmy sound. Rales is more wet and bubbly, almost like you're blowing bubbles through a straw. All right. So if I see rhonchi in the question, then I know it's going to be one of the infections that may or may not end in itis. And then lastly, we have stridor. And stridor is an upper airway obstruction. Okay, so stridor will tell me the patient has an upper airway obstruction. So that can be caused by a patient who has a foreign body airway obstruction, which means they're choking on something, or one of two different upper airway infections that we'll talk about later that primarily deal with kids. Okay, so those are our 4 different lung sounds. Right, and they'll give us an idea of most of the respiratory issues we'll be talking about later on in class.
So since you said stridor comes from like an airway obstruction, would you only be looking at that in children because if you were adults choking, you would deal with the choking item before you took your vitals?
No, we would still hear stridor. Right, we just hear it as they're breathing. Right, but with kids, there's 2 infections that primarily affect kids. All right, so this guy right here, this is the tripod position I was talking about earlier. Okay, so again, hands on his knees, kind of bent forward. We can see the accessory muscle use. So you can see his traps are flexing, causing the clavicles to kind of pull out a little bit more as well. All right, this guy right here is a classic textbook example of a COPD emphysemic patient. All right, and we'll talk about him. We'll see him later. All right, see the reason why I say he's textbook because he's quite literally in your textbook when we cover emphysema. All right, but we'll see this guy later. But those are the signs that we're looking at. All right, the accessory muscle use, tripod position, sitting up in the high Fowler's position. All right, you can tell just by looking at this dude that he's in respiratory distress. All right. Now, as far as location of lung sounds, okay, we have to know where to place our stethoscope because I don't go la-di-da-di-da-da wherever I want. Okay, there's specific places we auscultate. So, for our apices of the lungs, or the apex, okay, we're going to start at the mid-clavicular line. Which line?
Mid-clavicular.
Which is in the middle of their clavicles, okay, along the second intercostal space. Which place?
Second.
Right. So using those 2 lines, right, essentially making a grid, mid-clavicular line, second intercostal space, like we said, is the first palpable spot under the clavicles. I put my stethoscope right here. Have the patient inhale, exhale, and then zigzag over to the other side. The second place we're going to listen to is the mid-lobes. Now for male patients, we continued down the mid-clavicular line all the way through. Okay, but for women, we now shift to the mid-axillary line. Which line? Mid-axillary. Which runs right under their armpit. Okay, so it's going to be just inferior or just below the armpit, right down the middle. Okay, now we're going to use the 5th intercostal space for that landmark. Okay, so for guys, mid-clavicular 5th intercostal space, pretty much just below the nipple line. And then for ladies, we go along the mid-axillary line, 5th intercostal space. Okay, have the patient inhale, exhale, and then I bounce over to the other side, inhale, exhale. All right, for the bases, or the bottom of the lungs, we go for the 7th intercostal space, which again is going to be right at the bottom of their sternum. Okay, for guys, using the mid-clavicular, for women, mid-axillary. Okay, so these are the anterior, which side?
Anterior.
Which is a fancy word for?
Front.
Front. Okay, that's how we get the anterior lung sounds for our patients. Okay, so 2nd, 5th, 7th intercostal spaces, using the mid-clavicular line for guys, right? For ladies, we'll use the mid-axillary for the 5th and 7th intercostal spaces. Okay, now as far as the posterior lung sounds, posterior meaning back, okay, we're basically going to trace the scapula between the shoulder blade and the spine, using the same intercostal spaces, so 2nd, 5th, and about 7th intercostal space right here. Okay, so you got to palpate, which means to touch or feel, to find that soft spot between the shoulder blade and their spine, and that's where I place my stethoscope. Okay, because I can't listen through bone, especially the scapula. Super duper dense bone, you're not going to hear anything. All right, we'll see a picture of somebody's back later on, and I'll show you. But basically, we're just tracing out the scapula along the back. All right. So that gives us a total of 12, how many?
12
different spots that we're going to auscultate lung sounds front and back. 6 for the front and 6 for the back. All right? Now, as far as our level of consciousness, okay, we don't ask these questions in the introduction. Okay, per LA County standards, I do not ask these questions in the introduction. Okay, the introduction is just that. Getting the introduction, chief complaint, consent, and that's it. Okay, if you were to do this on an exam, that is a fail. Okay, because you're delaying patient care by not getting the information you need right away. And that's how easy it is to fail your assessment. Okay, now as far as the questions we got to ask to get the level of consciousness, we ask person, place, and time. Right, and for LA County, they only require the patient to be alert and oriented times 3 to those 3 questions, person, place, and time. Now, when we're asking these questions, they are open-ended questions. Kind of questions?
Open-ended.
Kind of questions?
Open-ended.
Right. What that means is that I cannot ask it in a yes or no way. Like, do you know your name? Yes, I know my name. Can you tell me your name? Yes, I can tell you my name. Are they answering the questions?
Yes.
Yes. Is that the way I want them to answer?
No.
No. Okay, because I need to know if our patient can actually answer the questions. What is your name? Where are we? What time is it? Okay, that is how you have to ask the questions. Okay, and again, this is a business of communication. You have to know how to talk to people. Okay, and because you guys are so quiet, shy, and timid, you guys will go up to your patient and be like, sir, do you know your name? Or can you tell me your name? Yeah, of course I can tell you my name. Do you know your name? Of course I know my name. Okay, but if you go up to them and be like, hey, what's your name? Oh, my name's blah, blah, blah. Okay, where are we? We're at my house. What time is it? Oh, it's about 7 o'clock. Okay, the patient's able to answer the questions in the way that I need them to answer the questions. All right. Now, as far as person, just simply know their name. Okay. Now, you can play it off because I already know their name. You can be like, hey, sorry, I got to ask you this stupid question, but what's your name? All right. That way they can tell us. Okay. As far as place, where are we? That's totally fine. You can ask what city, what state, things like that. That's totally fine. When it comes to time, there's a few different questions we can ask. You can simply ask them, what time is it? All right. And you can be forgiving. Right? If they say it's 7:15, like, no, you're wrong, you're altered. Right? It's not even 7 o'clock yet. That's fine. Right? But if they tell me it's 4 in the morning, is that off?
A little bit.
Absolutely. Okay, so then I can ding it as being incorrect. Now, if our patient doesn't know the time and they look at their watch to update themselves, can we give them credit for that? Yeah, that's fine. They're like, you know what? I actually don't know. Oh, it's 7 o'clock. Okay, cool. That's fine. Because at least they have the knowledge, right, enough to update themselves on the time. You can ask them what time of the day it is. I don't like that because that's a stupid question, but that works too. What time of day is it? Morning, right? So anything like that. All right. As far as day of the week, we can do that too. What day of the week is it? Okay. What day of the month is it? With that one, I usually give plus or minus a day because I don't even know what day of the week it is half the time. right? So in that case, if they go, oh, it's Tuesday, it's technically Wednesday, but you're close enough, right? That's fine. Same thing for day of the month. What day of the month is it? Oh, it's August 4th. Actually, it's the 3rd today, but you're close enough, okay? But if they were to go, oh, it's Sunday, is that okay?
No.
If they go, oh, it's 25th, is that okay? No, right? Because they're too far off, right? We can even ask them what month it is, right? So what month are we in? Oh, we're in August, right? And if we're at the beginning or end of a month, again, same thing, a little overlap is fine, right? So if it's August 1st, and I ask them, hey, what month is it? And they're like, oh, it's July. It's like, oh, no, actually, we're on the first day of August. Oh, shoot, okay. That's fine, right? But if they tell me, oh, it's December, is that okay? No, right? Because now we're too far off. Okay, so it doesn't have to be an exact, precise answer, but as long as you're close enough. Okay? I usually don't like to go any further than that. Some people like to ask the year. I feel that's a little too broad. Some people like to go what president. Again, maybe too broad. So I like to just stick within the month. Okay, and somewhere within that. Now, as far as documentation, if our patient's A and O, which stands for alert and oriented, what does it stand for?
Alert and oriented.
Right, alert and oriented times 3, right? We could write PPT, which is person, place, and time. Now, after ANO times 3, I don't necessarily have to write PPT because we already know that they're able to answer all questions correctly. But if you wanted to, that's fine. Now, if they're altered, so let's say they're ANO times 2, then I can write PP, which would be person and place. Okay, which means they couldn't get me the correct answer for time. If they're ANO times 1, A and O times 1 to whatever it is. So because it says P, that doesn't tell me if it's person or place. Okay, so you may want to add a couple letters after that. PER for person or PL for place. That way I know exactly which one they were able to answer, and they got the other ones incorrect. And if the ANO times 0, just write ANO times 0, and that's it.
I was gonna ask, because like, so he easily like answers like person or place, but they like make a mistake on time.
Mm-hmm.
But like, if maybe it's like an honest mistake, like, would you still be like, okay, they're altered, or would that still?
It depends on that. If I were to go back and ask them again, they give me different answers, more correct. Okay, it was probably a slip up. That's fine. All right. So that's how we'll document the patient's ANO status. And again, we do not ask this in the introduction. Okay, don't ask in the introduction because LA County deems that a critical fail because of delaying patient care. All right. So in the intro, just get their name, and that's it. We'll ask these questions later. Now, as far as causes of an ALOC, okay, there are multiple causes of an altered level of consciousness. And if you haven't figured it out yet already, we use a shit ton of mnemonics in EMS. All right. So another one, right, is going to be AEIOU tips. Okay, so we use AEIOU, basically all the vowels. No Y this time, right, and tips. So this is just a tool to help us identify what's causing them to be altered. It's not an actual part of our patient assessment. Okay, but if I got a patient who's altered, crap, I got to run through this checklist using this tool to see what might cause them to be altered. Some things we can fix, some things we can't. All right. So as far as A, we have alcohol. So if my patient's under the influence of alcohol, can they be altered?
Yes.
Absolutely. If they're withdrawing from alcohol, can they be altered?
Yes.
Absolutely. Okay, so we have to worry about the intoxication or withdrawal from alcohol to see if they're altered. Okay, we got to check for allergic reactions, right, or anaphylaxis, because if they're in shock, they will be altered. We have to check for anoxia. So because we have an, what does that mean?
No.
Absent.
Without. So anoxia means they're going without oxygen. Okay, so anoxia without oxygen. Obviously, if you don't have enough oxygen, you get altered since the brain's not perfusing properly. Okay, and that's just a little bit of the stuff that can start with an A. Right. You can add a crap ton of stuff to this, but this is just a few of the common ones. Right? E, epilepsy. So patients who are having some type of seizure disorder, right, that can cause them to be altered. Electrolyte imbalances. Right? Again, we said electrolytes are important for muscle function. The heart is a muscle. So if electrolytes are off, heart can't pump properly, blood can't get to the brain, now your patient's altered. Not on here, but environmental issues as well. So excessive heat or cold can cause patients to be altered. Insulin in either hypo or hyperglycemia. Okay, so patients who have low or high blood sugar, they can also be altered due to some type of insulin problem, either too much or too little. Overdosing can clearly make people altered. just as underdosing, especially on prescribed medications, antipsychotics, antidepressants, things like that, okay, that can cause them to be altered. And uremia. So uremia is toxic buildup in the blood. Okay, so uremia is toxic buildup in the blood, generally caused by liver or kidney failure. Since those are solid organs, what do they do with the blood?
Filter.
You filter. So because those filters aren't working, they're not going to filter all the toxins, therefore leading to uremia. All right, so that's going to finish the bowels, and then we have tips. So T is trauma. So if my patient were to take a baseball bat to the head, are they going to be altered?
Yes.
Yeah. All right, so we got to worry about head trauma. Okay, infection. Psychiatric disorders. Okay, so certain psychiatric disorders, schizophrenia, all right, things like that. Post-ictal is the part after they've had a seizure. We'll talk about that next week. Poisoning goes along with overdosing. And then we have palpitations. Okay, palpitations are not the same as palpations. Okay, because palpate means to touch or feel. But palpitations is when your heart is skipping a beat and you feel that fluttering in your chest. Those are palpitations. Okay, and that tells us that something's not quite right with the heart, which can cause inadequate blood flow to the brain. Okay, so if they feel that kind of fluttering in their chest, right, they may not be able to get enough blood flow to the brain, causing them to be altered. And then we have S, which would be strokes and seizures. Okay, so whenever I got a patient who's altered, I'm going to go through this checklist. Okay, am I seeing possible signs of alcohol intoxication or withdrawal? I don't really smell anything on their breath. I don't see any alcohol bottles around. That's probably not it. Do I see signs of anaphylaxis? I don't see any hives, nothing like that, no wheezing. I can rule that out. Anoxia? Maybe. Let me try to give them some oxygen. Okay, my A's are pretty much done. Going to move on to E. Environmental issues? No, it's relatively fine here. Electrolyte imbalances? I have no way of knowing as an EMT, so that's a possible issue, right? Epilepsy? I don't know. Maybe they have it, maybe they don't. We'll see. Okay, as we just go down the list and try to figure out what might be causing them to be altered. Okay, so we are going to be using this mnemonic later when we talk about our different ALOC issues next Thursday when we cover neurological emergencies. Okay, so you need to know that stuff by then. Now, as far as treatment, okay, this is going to be our first of many treatment slides. Now, whenever you see a treatment slide, okay, you're going to see a lot of things that are pretty common. You're going to see complete initial assessment, support ABCs, initiate, transport, reassess. To save your wrist and save time, we're just going to call that supportive treatment. Okay, so completing a primary, supporting ABCs, reassess, and transport, we just call that stuff supportive treatment. And we do supportive treatment for just about everybody. Okay, so don't focus on the similarities, instead focus on the differences. Okay, different signs and symptoms for different medical traumatic emergencies. Different treatments for those different problems. Okay, because there are certain patients that you have to do a very specific treatment for that one particular issue. You can't do it for other ones because it won't work. All right, now as far as an ALOC, okay, we have our supportive treatments that we do for everybody, but there's a couple other things we got to consider. One, we want to give them high flow O2. All right, we want to consider possible hypoxia to the brain, and I can fix that by giving some high flow O2. Depending on what happened to the patient, we also may want to consider spinal mobilization, especially if they're found on the floor and it was unwitnessed. Okay, hey, I don't know if this person fell, hit their head, compromising their spine, right? Or if something hit their head and then they fell down and they still compromise their spine, right? I don't know that. So I want to play it safe again for the purpose of class and consider putting them on a backboard. All right, in addition to that, airway, breathing, circulation, we get to the secondary. We're going to run through AEIU tips, see what's going on with that patient, and then prepare for transport. All right, and again, we'll be seeing these treatment slides for a lot of other things. So again, supportive treatment plus the few other things that are specific for that particular type of injury or illness. All right, when it comes to skin signs, again, we're checking color, temperature, and moisture. So we're going to expand upon what we saw earlier in COPS. Realistically, I'm checking skin signs twice. I'm doing it once in COPS as I go through my primary, and then I do it again as I go through my secondary assessment, and I'm doing vitals. Okay, now if I got a partner, let's say Casper is doing vitals, can I feel what Casper feels?
No.
No. Okay, so I have to check my own skin signs even if he were to do it in the secondary assessment for vitals. And besides, could they have changed from the time that they check skin signs to the time I do it?
Yes.
Yeah. Okay, so that's why we want to go back and double check our skin signs. Now, the first things that we see for every criteria here, those are considered normal skin signs. So for color, pink will be considered normal. You can also just say normal, that's fine. And pink is really in reference to mucous membranes, one of them being the conjunctiva, right, which would be the mucous membranes around the eyes. Now, the reason why I was saying it's important yesterday is because I would peel back the eye to check the conjunctiva for patients who have darker colored skin. Because I can't really tell if they're pale or they're flushed or they're cyanotic because of the darker pigmentation on their skin. But their mucous membranes are going to reflect that. Okay, so I can go ahead and take a look at their eyelid, or if it's safe for me to do so, I can look on the inside of their lip, right, to see how the color has changed there. Because there, they will show flushed, they will show pale, they will show cyanotic in those mucous membranes. All right, warm is normal. Okay, and then dry is what we should be. Right? We shouldn't be sweaty or clammy or diaphoretic or anything like that. We should be dry when we're normal. So if I got a patient who's got totally fine skin signs, I would say they're normal, warm, and dry. Normal color, they're warm, and they're dry. If I got a patient who might be going into shock, they could be pale, cool, and diaphoretic. Okay, so they're lacking color because they're basically redirecting blood towards the core through vasoconstriction. They're cool because they don't have a lot of blood in their skin, and they're diaphoretic because the body's trying to cool itself off as we're kicking what response? Not the parasympathetic.
Sympathetic.
What response?
Sympathetic.
What response?
Sympathetic.
Also known as the
Fight or flight.
Fight or flight, right? Because the body's in survival mode. All right, if I got a patient who is red, aka flushed, what's it called? Flush. That means that they have vasodilation. So if they are hot, flushed, and diaphoretic, right, then that tells me they may have some type of infection. Okay, they're hot because they're trying to burn out whatever nasty stuff they have. They're flushed and diaphoretic as they try to cool themselves off. So if they got a big belly that's firm to the touch, so they're rigid and distended, with pain and awkward quadrants, and they have hot, flushed, and diaphoretic skin, what kind of organ is ruptured inside the abdomen? No. What kind of organ has ruptured inside their abdomen if they're rigid and distended with hot, flushed, and diaphoretic skins? Hollow organs, because those are full of? Full of what?
Nasty
Full of what?
Nasty
right,
stuff.
nasty stuff. So now they spilled all that nasty crap inside the abdomen, resulting in an infection. And the body doesn't like having infections in it, so it's going to try to fight it off by jacking up that temperature, and the body's going to try to cool itself off. But if they were to rupture a solid organ like the liver, right, they have all this blood spilling inside the abdomen. What do we call that? Internal bleeding, because they're bleeding internally. There's no fancy word for it, right? They're just bleeding internally. So they can be pale, cool, and diaphoretic because they're going into what kind of shock? No, not anaphylactic. Hypovolemic. What kind of shock?
Hypovolemic.
What kind of shock?
Hypovolemic.
Right, hypovolemic shock, because they're losing volume. They have low volume of blood in their body because it's all spilling out inside the abdomen. Okay. So based on the skin signs, that's how I tell what's happening inside the belly. Because both peritonitis and internal bleeding are going to present with rigidity, distension, and pain in all four quadrants. And if I can't turn on my X-ray powers, right, to see what's happening inside the abdomen, I have to use their skin signs to determine what's happening on the inside. Because again, we have a one-to-one correlation what's happening inside the body versus what we see on the outside. Just like signs of a tension pneumothorax. I can't see the tension pneumo happening inside their body, but are there outward signs to indicate that? Yes. All right. So one of them, of course, being tracheal deviation, where that trachea is shifting off to one side, right? The other one being JVD. Did you guys see it? You guys saw it? Yeah. Okay, so JVD, right? Also another sign of a tension pneumo. Okay, and we have that subcutaneous emphysema, that snap, crackle, pop from all the air getting stuck in the fatty layer of skin. If I see those three signs together, the only thing it tells me is they have a tension pneumothorax. Right? So we have to look out for those differences to help identify what's happening. Now, as far as the patient who's yellow, what do we call that? And that would indicate what type of infection?
Liver.
Did we call? No. Hepatitis. What is it?
Hepatitis.
Right, because meningitis affects their brain. Okay? So if I got a patient who's got yellow skin, that tells me they got some type of liver problem, more than likely meningitis. Okay? Now, as far as respirations, okay, now we care about numbers. Okay, so when I get to my vital signs and I get to respirations and pulse, now I care about numbers. All right, so for counting respirations, if they have regular respirations, so it's a nice consistent pattern, I can count for 30 seconds and multiply that number by 2 to get my breaths per minute. Yes, there will be math, sorry. Okay, so count for 30 seconds and multiply that number by 2. If they have irregular respirations, irregular meaning not regular, okay, then I count for 1 full minute. Okay, so if they got irregular respirations, that means not regular, not consistent, okay, we count for 1 full minute. Now, if we're counting for 30 seconds and multiplying that number by 2, can I get an odd number? No. Yeah, you guys are math challenged because that should be unanimous no. Okay, if we're counting for 30 seconds and multiplying by 2, we cannot get any odd numbers. Okay, we don't count half breaths. Okay, so if you guys tell us, oh, my patient has a respiratory rate of 17, okay, that tells me one of two things. One, you're either bad at math, or two, you're bullshitting. Okay, either one of those is unacceptable. Okay, now if they're counting, if they have irregular respirations, and you count for a minute, can you state an odd number?
Yes.
Yes, because then you're just telling me whatever it is you got in those 60 seconds. Okay, but the only indication for counting for a minute is if they have irregular respirations, if they're infants, or if they're severely hypothermic. Okay, the only times we can count for 1 full minute is if they have irregular respirations. So again, they're breathing not regular. If it's an infant, so any patient under the age of 1, okay, or they're severely hypothermic. Okay, so really, really cold. Those are the only times we're allowed to count for 1 full minute. All right, other than that, we count for 30 seconds, multiply the number by 2. So once we get the rate, we're going to figure out the rhythm, regular versus irregular, right? And the quality basically being the depth. Okay, so kind of like when we go back over breathing in the primary assessment, rate, rhythm, quality, doing the same thing, but now I'm getting numbers. As far as effort, we're going to see that the patient's working hard to breathe, also goes along with quality. Okay, as far as the lung sounds, noisy respiration, that's basically what it is. So do we have abnormal lung sounds or snoring or gurgling respirations? Right, those are things we're assessing in addition to the actual number of breaths per minute. All right, now as far as normal rates, okay, we have to be able to identify normal so we can identify abnormal. So with peds and infants and stuff, again, the numbers will change, so don't worry too much about those numbers. Okay, we'll just talk about the trend in a second. For adults, our normal breathing rate, again, is somewhere between 12 to 20 breaths per minute. Okay, that number is set based on what type of control center in our brainstem?
Vasomotor.
Not the vasomotor. Respiratory. The respiratory control center controls the rate of breathing. Finally clicked, right? Oh shit, respiratory control center controls respirations? Oh, who would have thought? I know. Cardiac control center controls the heart, or influences the heart? Interesting. Yeah. Okay, so as far as the respiratory control center, right, that's going to set the respiratory rate for us. Okay, the phrenic nerve is what controls our tidal volume and tells us how far down the diaphragm needs to contract whenever we inhale. Okay, and that's what's, again, going to go after tidal volume. Now, generally speaking, as the patient gets younger, okay, the respiratory rate gets faster. The exception is adolescents. Okay, now the reason why adolescents have a slower respiratory rate compared to adults, the adults also include geriatrics, fancy word for
elder people.
Elderly. Okay, because as you get older, you breathe faster right before you die, right? So we're going to kind of tie that in there with that. But with adolescents, right, their body's pretty much running at peak performance. Okay, so they don't need to be sucking as much oxygen as an adult patient. As far as kids that are younger, they increase their respiratory rate because they're based on cardiac output. They have to move that oxygenated blood as quickly as around the body as they can, right? Hence why they're sucking in more oxygen. All right, but right around the age of puberty is where they start transitioning from cardiac output for perfusion to blood pressure. Now, as far as terms, when it comes to fast versus slow breathing, we call it bradypnea. What do we call it?
Bradypnea.
What do we call it?
Bradypnea.
Right, bradypnea. Okay, whereas fast breathing, we call it tachypnea. What do we call it?
Tachypnea.
Right, tachypnea. Now, whenever you see Brady in front of something, okay, Brady is a prefix that means slow. What does it mean?
Slow.
Right, slow. Not low, but
Slow.
slow. So bradypnea, bless you, means slow breathing. Whenever you see tachy in front of something, that means fast. Okay, so tachy means fast, whereas Brady means slow. All right, the way I thought about it when I was going through the class, right? Whenever I see Brady, I think of the Brady Bunch, like an old slow show by today's standard, that's for sure, right? So that just means slow. And tachy, for those that know your cars, okay, the tachometer, right, tells you how fast your engine is spinning, right? Gives you the RPMs. Right? So that's another kind of thing you guys can do for this class, is related to things that you already know, right? So you kind of understand concepts a lot better, or just simply just relation. Okay, Brady is slow. Yeah, that makes sense. Tachometer shows how fast the engine's spinning. Okay, tachy means fast, right? Making those connections so it sticks a lot longer, right, is what's going to help you guys in this class. Now, as far as the blood pressure and pulse, okay, they're tied based off, or they're basically related to one another. The further the pulse point is away from the heart, the higher the blood pressure needs to be to generate that pulse. So for example, to get a palpable radial pulse, the blood pressure's got to be at least 80. Okay, so palpable just means we can feel it. So to get a palpable radial, systolic blood pressure's got to at least be 80. If I can't feel a radial pulse, that means your blood pressure is under 80. Bless you. Okay, and when we talk about shock tomorrow, okay, that is going to be a very significant clue that we need to look out for. If they don't have a radial pulse and they're in shock, that's a big problem. Okay, so now we'd go for the brachial. And to generate a brachial pulse, either at the elbow or under the bicep, okay, the systolic blood pressure has to at least be 70. And to generate a carotid pulse, the systolic blood pressure has to at least be 60. Okay, so radial is 80, brachial is 70, carotid is 60. And if I can't feel a carotid pulse, for all intents and purposes, our patient is dead. So we call for the AED and we start doing CPR. Okay, because if I can't feel it, we're going to assume that the heart is not pumping blood to the brain. So for infants, again, there we go, checking the brachial pulse as he's sticking his tongue out at us, bastard. All right, so we'll go ahead and check that pulse. And again, we'll be checking for a minute, okay, as we're checking that brachial pulse because it's an infant. Now, as far as checking the pulse we can count for 30 seconds and multiply that number by 2, just like respirations. Or I can count for 15 seconds and multiply that number by 4. If I multiply a number by 4, can I get an odd number? No, still math challenge. No, we can't. Okay, because it's a multiple of 2. So again, if you give us a blood pressure of 85, again, you either don't know how to do math or you're bullshitting. Okay, so if you're going to fake it, at least fake it in even numbers. All right, the only time I can count for a full minute is if the pulse is irregular, it's an infant, or a severely hypothermic patient. Okay, so the same indicators for checking for a minute in respirations also apply for a pulse. Okay, we're going to check the strength or the quality. Is it strong? Is it weak? Right? As far as it being bounding means super strong, and that typically is going to be associated with hypertension. Right? I mean a high blood pressure. Okay, so bounding is a super strong pulse, typically associated with hypertension.
Would somebody with high blood pressure have JVD?
Not necessarily. They might, but it depends on what else is going on with them. All right. Now, if the patient has a thready pulse, right? Thready meaning rapid and weak. Thready meaning what?
Rapid and weak.
Right. Okay, that might be an indicator of shock. Okay, tomorrow, again, when we talk about shock, there's different signs to indicate different types of shock. But the one common thread amongst all types of shock is the fact that they all have a thready pulse. Okay, all kinds of shock, no matter what kind of shock it is, will have a thready pulse. Hence why I say it's the one common thread amongst all of them. Okay, but skin signs will vary, cap refill will vary, right? All that stuff will vary. The main difference is the fact they'll have a thready pulse. Now, as far as fast versus slow heart rate, bradycardia, slow heart rate, tachycardia, fast heart rate. All right, so as far as heart rates, again, don't focus too much on the kids, focus on the adults. Okay, for us, resting heart rate should be somewhere between 60 to 100, and the heart rate is influenced by what control center in the brainstem? Cardiac. What is it?
Cardiac.
Right. Okay, the cardiac control center influences the heart rate. But does the heart need the nervous system to function?
No.
No. Right? There's a very special bundle of cells that's going to act as a pacemaker, sir? What bundle of cells acts as a pacemaker for the heart?
Automatism.
No, that's what makes the heart actually work independent, sir. Sir? Sir?
The bradycardia, like the muscles.
No. Sir? Miss? Miss?
Is it the Purkinje fibers? or
Purkinje fibers? No.
Is it the AV node?
It's not the AV node.
SA node?
There we go, finally. Okay, working backwards. Okay, it is the SA node. But what does SA node stand for?
Sinoatrial ventricle.
You said it, and then you added more crap to it. SA, what is it?
Sinoatrial.
That's it, right? So the SA node, or the sinoatrial node, what node?
Sinoatrial.
Right, that is the primary pacemaker for the heart. Located in the right atria, right, it's going to go ahead and be the primary pacemaker by setting out that heart rate. Okay, the AV node is a backup, right? Primary function is a gatekeeper, pausing electrical impulse for the ventricles to fill up with blood. And the Purkinje fibers are tertiary backup if the SA and AV nodes have both failed. Okay, but the primary pacemaker is the SA node. And the output rate for the SA node at rest is 60-100. Okay, and the cardiac control center will either tell the heart to slow down or speed up based on baroreceptors. What kind of receptors?
Baroreceptors.
That measure.
Oxygen.
No, those are chemoreceptors. No, those are chemoreceptors as well. Primary is CO2, secondary is oxygen. Baro pressure. Okay, so those things are going to be based off blood pressure and just general physical pressure itself. Okay, I didn't do this exercise with you guys yesterday because if I did, I probably would have passed out with how tired I was. Okay, but you guys can go ahead and palpate your radial pulse. Find your radial pulse. Okay, and then once you guys have a nice good bead, nice good feel on a radial pulse, and you know you're not going to lose it, I want you guys to bear down like you're constipated and push. Okay, now when you do that pushing kind of motion, okay, you're increasing intrathoracic pressure, stimulating those baroreceptors. Okay, now your heart rate's going to shoot up for a little bit, but then after that, what does it do?
Go back to normal.
It shouldn't go back to normal. It should slow down. Okay, so if you guys are sitting there and you're doing that long enough, your heart rate will speed up a little bit and then slow down. Okay, now for people that do that too hard or for too long, they end up what?
Passing out.
They end up passing out. Okay, because their heart rate drops so slow, right, that they can't maintain perfusion to the brain. Okay, and we'll talk about those types of patients later because that's something we do have to worry about, right? But that's all triggered by baroreceptors in the blood vessels. Okay, so if pressure is too high, heart rate decreases to prevent blood vessels from blowing out. If pressure gets too low, the heart rate's going to go up to compensate, right, to try to maintain that blood pressure. Again, think about that super soaker. Okay, relax her. Turning red over there. All right, so that's going to be influenced by the cardiac center. And again, as the kids get younger, or as the kids are younger, the heart rate's going to increase because their baseline cardiac output. Right, they got to continuously move that blood around the body. All right, so we'll go ahead and take our break here, and then we'll finish up our vitals and go through everything else. Okay, so come back at 8:15. Right, make sure you guys grab your remotes, and we'll go and take a quiz when we get back. Sounds. I like to call it moaning and groaning because that's all the patient does. Okay, they cannot put out any words or anything like that. It's just sounds that they make. And then if they're nonverbal, patient gets 1 point. Okay, so if I were to ask them a question, they're just staring at me and they can't talk, right, they would get 1 point.
None?
What's that? For none, yeah.
1.
1 point.
Sorry.
What?
Yeah, I just heard you say something.
So say someone like in the beginning, like you talk to them and they're like, oh, my hair color is purple, so like you score them a 4 because they're talking about it's disoriented. But then like
they want to get 4, they get 3 at that point.
Oh, they get 3, but then what if they came back with it? But they're like, oh no, like later on, like very shortly, they're like, oh no, that's not right. It's Sunday or something like that, and they were correct.
Then that's fine. Yeah, that's where we go back and reassess them. Usually they don't get better, usually they get worse. But yeah, we'll just go ahead and reflect it and rechange it. All right. Now, as far as motor response, okay, they get a maximum of 6 points. Right, and they get 6 points if they can follow simple commands. All right, and I'm talking very simple, basic motor commands. So, for example, if I'm checking a pulse and I say, hey, can I check your pulse? And they're like, yeah, sure. And they do this. Is that enough?
Yes.
Yeah. right? If I ask my patient to wiggle their fingers and they do that, is that enough?
Yes.
Yeah, if I'm checking cap refill or the next vital that we'll talk about, a pulse oximeter, and I ask them to stick their finger out, is that okay?
Yes.
Yeah. Okay, so anything like that is fine. All right. Sometimes we have the patient grab onto a pen light or something. Right? Hey, can you grab this pen light for me? Yeah, sure. Okay, can I have it back? Okay. All right. I think it's kind of dumb, but as long as they can follow a command like that, that's fine. Now, if our patient responds to painful stimuli, that's where we start getting into these responses here. Okay. So if I were to inflict pain on my patient and they do what's called localizing to pain, which essentially means that they react to it. If I were to do a nail bed pinch, localizing would be them, for example, maybe like smacking my hand, or at the very least rubbing the area after they inflict pain. Okay, so as long as they're doing something in reaction to pain, that's considered localizing. So I don't have to necessarily swat my hand away, but afterwards like, ow, that kind of hurt. Doing something like that, that'd be considered localizing. Now again, I only do that for patients who need painful stimuli. I don't be like, hey, you come here and do it just for the hell of it. Okay, that's why we have them do simple commands. Now, if our patient were to withdraw from pain, right, that's it. I provide painful stimuli and they pull away and they don't do anything else, that's withdrawal. Okay, so it's kind of a fine line, right, as far as localizing and withdrawal. Okay, but localizing, they're reacting to the pain, whereas withdrawal, they're just pulling away. Right, then we have our decorticate decerebrate posturing. And the simple word for decorticate is flexion. What is it?
Flexion.
What is it?
Flexion.
And the simple word for decerebrate would be extension. Okay, so like I said, these are really bad ominous signs to see if our patient has decorticate or decerebrate posturing in response to pain. Okay, now as far as why decorticate is a little bit better compared to decerebrate, right, it has to do with what the patient's doing. As I inflict pain, they're bringing in, right, their extremities. Okay, now think about it. If somebody were to make you flinch, right, whenever you flinch, you always kind of curl up into a defensive posture. Okay, painful stimuli, patients should be doing the same if they're in decorticate posturing. So if I do that and our patient starts curling in, they're almost protecting themselves from that pain. Okay, what's worse is if they open up to pain. Okay, so the patient starts opening up to pain, right, that's an abnormal reaction. I mean, some people are into that, but in this case, right, if that patient's opening up to painful stimuli, okay, that's not good. And the only thing worse than that is they don't do anything at all in response to pain, therefore giving them 1 point. Okay, now as far as rating patients on the Glasgow Coma Scale, the maximum score they can get is 15. The minimum score they can get is 3. Math, I know. Okay, so, right, the maximum score they can get is 15. 4 plus 5 plus 6 equals 15. The minimum score would be 3, 1, 1, 1. Okay, so nobody scores a 0 on the Glasgow Coma Scale. Okay, everyone gets some points for at least playing the game. Okay, so minimum is 3, max is 15, right? And you guys may have to calculate, right, the Glasgow Coma Scale for different patients. Okay, this is something we have to document on every single patient care report, and has been something we've had to document every single patient care report. Okay, but people sucked at determining a patient's Glasgow Coma Scale, and I sure as hell was guilty of it as well, because patients were either 15s or they were 3s, and there was no in between. All right, so you have to be able to run through your assessment and identify, oh crap, this patient has a GCS of 12, and document it as such. All right, so if it's a 15, you don't have to worry about writing 4, 5, 6, because we know it's a perfect score. But let's say our patient does respond to verbal stimuli, but they're able to get everything else correct. I would write the GCS as a total of 14, 3, 5, 6. All right, because they got a 3 for the first category. They scored 5 points because they could talk to me, right, and they can follow simple commands. All right, now we have a GCS on our patient care reports, so we do have a little cheat sheet every once in a while. Okay, but you have to be able to assess it in the field without your paperwork. All right, because if you have a stroke patient, you can be like, hold on, sir, I know you're having a stroke, but let me just calculate my GCS. Are you going to do that?
No.
No, right? You got to be able to go through it in your head, and then you can go back and confirm once you actually have time to document. All right. Now, as far as the pulse oximeter, okay, we're checking O2 saturation. All right. So, as far as what the pulse ox is measuring, it's measuring the amount of stuff. The amount of what?
Stuff.
That's attached to the red blood cell. We're assuming the stuff is going to be oxygen. Okay, so the pulse oximeter is measuring the amount of stuff that attaches to a red blood cell, and we're assuming that stuff is going to be oxygen. All right, so it's a little probe we put on the finger. You don't have to worry about how it works. For our purposes, it's just voodoo magic. It just works, and it just does. All right, so we put it on the patient's finger, and it's going to give us a percentage, right, as far as numbers. And that's basically telling us how much of the red blood cells are fully saturated with stuff, assuming the stuff is oxygen. All right. Now, as far as carbon monoxide, again, no meme there, right? Carbon monoxide, okay, is going to attach to the red blood cell about 100 times easier than oxygen actually does. Okay, so the red blood cells actually prefer having carbon monoxide attached to them for whatever chemical reason it happens to be. Okay, so when the patient is suffering from carbon monoxide poisoning, we're going to get artificially high numbers on the pulse oximeter. Now, the normal range for a healthy, quote unquote healthy patient is 94 to 98%. Okay, so the normal range for a healthy adult patient for an SpO2 is 94 to 98%. So what that means is 94 to 98% of our red blood cells are fully saturated with oxygen, or at least assuming it's oxygen. All right. If a patient has carbon monoxide poisoning, that's going to read 100%. Okay. So if they have carbon monoxide poisoning, the pulse ox is going to read 100%. Okay. Because remember, it's measuring the amount of stuff that's attached to the red blood cell. Normally, we don't have 100% of our oxygen, right, attaching to 100% of our blood cells. Okay, but carbon monoxide, because it will bind to red blood cells way easier, right, it's going to read it as everything is fully loaded with, assuming oxygen. Okay, but in addition to that, we also have to think about the patient. Okay, if the patient has carbon monoxide poisoning, are they going to have an ALOC? Yes. Okay, because they're not getting oxygen delivered around the body, they're getting carbon monoxide, which doesn't do shit for us. Okay, so the brain's not getting perfused, they will have an ALOC. They'll typically be complaining of headaches, and in the very, very late stages, they're going to be a bright cherry red, because those red blood cells start glowing a very, very bright red. Okay? Now, if you don't know what the number is, right, what's normal, and you're sitting there with a patient who's bright cherry red and they're unconscious and they just tried killing themselves, right, by funneling exhaust into their car, you're like, oh, everything's great, right? You're not going to recognize, right, what's going on with the patient. Okay? That's what I was saying last night. We treat the patient, not the monitor. Okay, we treat the hopefully living person that's in front of us, not what the machine tells us is going on with the patient. Now, as far as those that are working on the hypoxic drive, one patient that's going to work on that, they're going to have lower SpO2 levels because their brain is now looking at lower levels of oxygen to determine their breathing. Okay, so for that patient, those that are on the hypoxic drive, their SpO2 sat should be somewhere between 88 and 92%. Okay, so for my hypoxic drive patients, they need to be satting somewhere between 88 to 92%. Okay, they intentionally have to have low levels of oxygen because that is their stimulus to breathe. If the oxygen levels get too high, the brain's like, all right, cool, we got enough oxygen, I don't have to worry about breathing anymore. Since those chemoreceptors aren't looking at levels of acid, okay, if the brain says, all right, we got enough O2, we can stop breathing, what's going to start building up in the body? CO2 and other acids. Right, and again, the brain is completely ignoring that stuff because it's not recognizing it. Right, so you can just think of the brain sitting here, la da da da, everything's fine. Well, you have all this acidosis building up behind it because it can't recognize it. Okay, now that takes hours before that actually starts to happen. Okay, so it's not like I put them in an NRV and boom, hypoxic drive and they're done. Okay, it takes a long time for that to actually start, but it eventually will happen. Okay. Now, as far as end-tidal CO2, we don't really measure this, but we're just going to talk about it briefly just so you can kind of know what else is going on. All right, but medics, they're going to be looking at the amount of carbon dioxide coming out of our patient's exhaled breath. They're not always breathing when they check this. And of course, CO2 is an acid. So the more CO2 that patient is blowing out, okay, the more acidotic they are. And they can check CO2 levels for a variety of different reasons. Usually they'll do it during cardiac arrest, because that'll let them know approximately how long that patient has been, apneic for, to the point where they're not breathing. And the more acidotic they are, the longer they've been down. So they have different ways of measuring it. They have colorimetric devices, which are things that will change color in presence of carbon dioxide or other acids. We'll see a picture of it on the next slide. But they also have capnometry and capnography. And capnometry is going to give them a number, either based on pressure or percentage. Okay, so capnometry will give them a number, either based on percentage or pressure of CO2 in their exhaled breath or other acids. and capnography will present as a waveform on your cardiac monitor. And based on the shape of that waveform, the medic can look at it and be like, oh, this person's a little acidotic, or they're alkalotic, or they're where they should be. Okay, but that's all ALS's responsibility. We're just talking about it as a little bonus, so when you guys are on calls, you can look over the medic and be like, oh, hey, what's that? All right, that way you can see, hey, this patient's a little acidotic or whatnot. So here we have an example of a colorimetric device. So this thing will clamp onto the end of the endotracheal tube, that advanced airway I showed you on CPR night. Right, we attach our BMV onto this side, and this is basically going to change, basically it's litmus paper. It's going to change in response to contact with acid. And we're going to color match it to see where it's at to determine if the patient's acidotic, alkalotic, or about where they should be. All right, so based on the color of that, medic's going to go and take a look at it. So we'll talk about these numbers when we cover respiratory, okay, but this is one of the devices, and we'll come back to this when we hear respiratory next week. So those are going to be our different vitals, okay, going through Bell's RP Go. Now, as far as time that it should take you guys to get a set of vitals, okay, by the time you guys are done with this course, you guys should be hitting vitals in a set of vitals in about 2 or 3 minutes. Okay, so it should take you about 2 or 3 minutes to knock out a complete set of vitals by the time you guys are done with this course. Friday, we're going to show you guys how to take a set of vitals. Okay, and are you going to get it done in 2 or 3 minutes on Friday?
No.
Absolutely not. Okay, it's going to take you guys around 10 minutes, if not slightly more, to do a set of vitals on Friday night. Is that okay? Yes, because we're just showing you how to do vitals. Okay, but at that point, it's your responsibility to keep on practicing vitals over and over and over and over and over again, so that way 3 weeks from Friday, you can get it done in what time frame?
2 to 3 minutes.
What time frame?
2 to 3 minutes.
Right, because I have to go back and reassess my critical patients every...
2 to 3 minutes.
No.
5
Every 5 minutes. How often?
5 minutes.
Right, every 5 minutes. Okay, that way it gives you a few minutes to do whatever else you have to do before you go back to reassessing your vitals. Okay, and as you go through different skill days, you guys should be getting through your vitals quickly, right, compared to the last day, right, and more accurately as well. All right, now moving on to our medical history. You don't have to worry about jotting all this stuff down. Okay, but we do have to gather medical history from our patient, including certain types of information, which we'll go to in a second. All right, now 2 mnemonics we're going to use to get medical history. One of them is sample. And when it comes to sample, everybody gets a sample. Who gets a sample?
Everybody.
Who gets a sample?
Everybody.
All right, just like Costco, right? Where everybody gets a sample. I'm so happy that it's back.
Mm-hmm.
Right? So everybody gets a sample. Okay, it doesn't matter if they're medical, they're trauma, they're pediatrics, they're geriatrics. Everybody gets a sample. Now, my patient can't always tell me the answers to sample, especially if they're unconscious. But if I do have an unconscious patient and their family member's right there, would they know about their history, allergies, or meds?
Yes.
Possibly.
Hopefully. All right, so we can ask them instead. All right, hey, sir, do you happen to know your wife's medical history? Do you know if she has any allergies? Do you know if she's taking medications? Right, that way we know what's going on. Okay, so signs and symptoms. Again, signs are what we see or observe. So those are objective things. Whereas symptoms are what the patient feels or tells us about, those being subjective. Now, you guys can simply ask, sir, do you have any other signs or symptoms? You can ask that, or if you did a decent enough primary assessment, you should already know the signs and symptoms, and you can just repeat it, right? So he had abdominal pain, no trauma, there wasn't pain on palpation, no signs of shock, and that's it. All right, so it's like a little tiny micro field impression as far as what I've seen. Right, and then from there I can move on to A, which will be allergies. So we ask the patient if they are allergic to any food, any bugs, any drugs, and anything in the environment. Okay, so they're allergic to food, bugs, drugs, and anything in the environment. Because obviously, if they're having signs of anaphylaxis, we want to know what they're allergic to and what triggered the anaphylactic reaction. Okay, if not, then we just want to document it down for documentation purposes so the hospital knows later on. Okay, and the reason why we typically break it down to those smaller bite-sized questions, right, has to do with patients and them being in distress. If they're in distress, are they going to remember everything that they might be allergic to? No. Okay, especially if they're, gunshot wound patient, for example. If they got shot in the leg, the last thing on their mind is like, I should tell these EMTs I'm allergic to shrimp, right? So we want to kind of force it out of them. Hey, you allergic to any food? Yeah, now that you mentioned shellfish, and my leg really fucking hurts, right? That we just get the information that we need to for the purpose of class. All right, now as far as medications, okay, we're going to give it the same kind of treatment, smaller bite-sized questions. Are they taking medications that are prescribed by a doctor? Anything over the counter? Any vitamins or supplements they may be taking? As well as any recreational or illegal drug use. Okay, so prescribed medications, over-the-counter medications, any vitamins or supplements, and any recreational or illegal drug use. Okay, so prescribed meds, over-the-counter meds, vitamins or supplements, and recreational or illegal drug use. Now, we're going to talk about this on Tuesday, okay, but there are medications, we'll talk about one of them tomorrow. There are medications that we can help our patient with if they have it prescribed to them. Now, if I think that I can help them with that medication, I want to ask for that drug first by name. So, for example, okay, if a patient has asthma, what medication could they take for their asthma?
Albuterol.
Albuterol, and that's one of the medications we can help them with. So if I have a patient who I suspect is having an asthma attack, the first thing I'd ask when I get to medications is, do you have albuterol for your asthma by any chance? Right? That way I get that relevant information first, and then I can go back and follow up. Anything else prescribed by a doctor, over the counter, vitamin supplements, recreational legal drugs. Okay, but I want to get the pertinent relevant information first. Okay, you guys, for whatever reason, love playing 21 questions with your patients, especially when it comes to things like that. Okay, you guys will ask, are you taking any medications prescribed by a doctor, over the counter, vitamin supplements, recreational drugs? Have anything in like a little plastic container kind of shaped like an L, we spray it, it does that kind of noise? You have something like that. All right, you guys will do stupid shit like that all the time, instead of being blunt and direct and to the point. Okay, again, 80% of this job is communication. Okay, ask for the things that you need right off the bat so you can do your job. All right, as far as pertinent medical history, that's what I ask for a medical patient. Okay, so somebody who's got a nature of illness, I want to ask, has this happened before? And if so, were you hospitalized for it? Okay, so has it happened before? And if so, were you hospitalized for it? We want to know about any recent surgeries they may have had. Okay, so any recent surgeries. And I can even ask them if they're seeing any doctors or specialists for this condition. That's a totally optional question. Sometimes it's fine to ask, sometimes it doesn't really matter. All right, but at the very least, has it happened before? And if so, were you hospitalized for it? And any recent surgeries. Okay, now again, we ask that for medical patients. For trauma patients, those that have a mechanism of injury, okay, P now becomes past medical history. What does it become?
Past.
Right, past medical history. And that's anything in their medical history. So I usually will list off things like, do you have high blood pressure? Do you have diabetes? Have you had any heart attacks? Any strokes? Do you have epilepsy? Just general things in the medical history. Because could their medical history complicate this trauma?
Yes.
Yeah. Could their trauma complicate their medical history?
Mm-hmm.
Yeah. Okay, so I want to know about those things because that's going to make my job more difficult. All right, and I want to be prepared for that kind of stuff. Right? For medications, I can kind of do the same thing, ask about specific drugs for trauma. Things like blood thinners. Okay, if my patient got into a car crash and they're on blood thinners, do I got to be worried about that?
Yes.
Absolutely. Okay, so I can even go that far. Hey, are you on blood thinners? Do you take beta blockers? We'll talk about those later. Okay, because that's going to make my job a lot more difficult because they're going to crash a hell of a lot quicker. All right. Now, again, just think about it. Stop for a second and think about why do we ask these questions? Okay, and what are the questions we ask? For pertinent history, right? Has it happened before? And if so, are you hospitalized for it? Any recent surgeries? And do you see any doctors or specialists? Okay, if I got a patient who again gets shot in the leg, am I going to ask them, sir, have you been shot in the leg before? And if so, are you hospitalized for it?
No.
Right? Have you had any surgeries? Have you seen doctors for that by any chance? Again, the questions just don't make sense for trauma patients. Okay, but again, I want to know about their medical history. Do you have things like high blood pressure, diabetes, blah, 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 in the case of trauma. Now, as far as L being last oral intake, okay, phrase it in plain English. What did you have last to eat or drink and how long ago? Okay, so what did you have last to eat or drink and how long ago will be L for last oral intake. And again, that's how we know you guys are simply memorizing this, okay, not actually practicing it. Sir, what was your last oral intake? Okay, instead of speaking like you would like a regular person, all right, what did you have last to eat or drink and how long ago? All right, and then lastly, we have events leading up to. What were you doing? Okay, so what were you doing when the pain came on, or what happened, right, when the pain came on? Okay, now if you guys were to go and ask that question in chief complaint of what happened, are you actually getting a chief complaint?
Yes.
No. Okay, if you ask what happened, you're not going to get a chief complaint. The patient will go, I fell. Oh, okay. This is not a chief complaint. Okay, but by asking them what's hurting you or what's bothering you, right, what happened? Oh, I fell. Oh, shit, okay, well, what's hurting you? Oh, my neck and my back really hurt. Now do we have a chief complaint?
Yes.
Yeah. Right? So don't train yourself in asking what happened to get a chief complaint. We only ask that question here. And if you're going to do that on the final and ask what happened and leave it at that, that's an automatic fail. Okay, and again, asking the wrong question at the wrong time is enough to fail the skill.
So, if it's like an obvious trauma incident, like a gunshot, like, do you still ask that question and you just fill it in yourself?
No, we still ask. Right?
Like, what happened?
What were you doing? What were you doing when you got shot? No, what were you doing when you got shot? Right? Because the patient can be like, oh, I was involved in an altercation. Oh, okay, well, now we got to get law enforcement here if we didn't do so already.
Oh, wow.
Yeah. Okay. So, right, we're going to go and ask these questions, right, for everybody, because who gets a sample? Everybody gets a sample. Now, as far as OPQRST, okay, it's the alphabet, don't freak out. Okay, as far as the OPQRST is concerned, we only ask it for a responsive medical patient. Okay, so an OPQRST is only asked for a responsive medical patient. What kind of patient?
Responsive medical patient.
Right, responsive medical. And that's one of 4 categories we'll talk about in the next slide or two. Okay, but they're the only ones that get an OPQRST. Now, as far as the OPQRST questions, I like to refer to them as detective questions. Okay, because it's through the answers that the patient will give me with these questions that I'll be able to identify what might be going on with these patients when it comes to a medical problem. Okay, so we're essentially playing a little bit of a detective by asking these questions. We're trying to listen for clues the patient's going to tell us about. And here's where we also identify differences between different medical emergencies. So as far as onset, okay, we asked 3 questions in onset. First one, what do you think caused the pain to happen? Okay, so for onset, what do you think caused the pain to happen? Did it come on slow or did it come on fast? Okay, so for onset, what do you think caused the pain to happen? And by asking that question, I'm digging into the event just a little bit more. Right, so let's say I got a patient who's having chest pain, and the event was they were mowing the lawn. Okay, so you're mowing the lawn, we get chest pain started. All right, what do you think caused the pain to happen? Well, my wife was nagging me to get it done, so I may have overexerted myself. Okay, so now we think the chest pain was caused by exertion. Okay, because if I just leave it at, what were you doing? I was cutting the grass. Oh, okay. It doesn't really tell me much, right? My patient could have also sustained traumatic chest pain. There could have been a rock that got kicked up and hit him in the chest and now causes chest pain due to possible rib fracture. All right, so if I were to ask that, what do you think caused pain to happen? Oh, well, a rock got kicked up and hit me in the chest. Am I thinking medical or trauma?
Trauma?
Now I'm thinking trauma. Okay, so now I got to switch over back to traumatic assessment. All right, did it come on fast or did it come on slow? All right, certain types of issues come on quickly, others come on slowly. So I can use that in the difference. For P, we have palliation and provocation. So palliation is what makes the pain feel better, whereas provocation what makes it feel worse. So palliation, what makes your pain feel better, and provocation, what makes your pain feel worse. Okay, we want to ask those as 2 separate questions. That way the patient tells me what makes their pain feel better, and they tell me what makes it feel worse. All right, obviously we want to do whatever makes you feel better, and we don't want to do whatever makes you feel worse. For quality, I want to have the patient describe what they are feeling in their own words as I ask the quality of the pain. So I'll phrase it as, in your own words, can you please tell me what the pain feels like? And then the patient goes, well, I guess I'd say it's like an elephant standing on top of my chest. All right, which I can equate to a crushing chest pain. Okay, so remember, pain is subjective. Can I feel my patient's pain?
No.
No. Okay, so I need them to tell me what it is that they are feeling so I can get an idea of what's going on. Now, sometimes they can't tell you, especially with abdominal complaints. They'll be like, I don't know, it just hurts. Okay, at that point, you have to do what's known as an educated guess, basically using our clinical judgment, okay, to determine what type of pain they may be having. So for example, when we talk about abdominal issues later, okay, you can kind of think about the times you've had a tummy ache. Okay, usually when the abdominal pain starts kicking in, it's usually more of a dull, cramping-like pain. Right? So if the patient tells me, I don't know, it just hurts, and it's an abdominal issue, that's usually what I start with. Okay, would you say it's like a dull pain? Yeah, kind of. Would you say it's like a cramping pain? Yeah, I guess that's how I could describe it. Right? That way I kind of know what the patient's having. If they say, no, not really, well, then I know the second most common type of abdominal pain would be more of a sharp stabbing pain. So I'll phrase it as, okay, is it like a sharp kind of stabbing-like pain you have in your belly? Yeah, I guess it would feel like that. That way I'm kind of leading that patient on. And I'm not just going to sit there and start listing a bunch of different types of pain. Be like, hey, is it a crushing, stabbing, throbbing, burning, aching-like pain? Because the patient goes, yeah, I guess, right? Which doesn't tell me anything. Okay, so I want to kind of lead them on to what I think might be happening, but obviously I don't want to steer the call in the direction in which I want it to go. Right? I still need to try to be objective and get information, but sometimes I have to nudge the patient a little bit. All right, for R, it's region, radiation, and reoccurrence. So for region, we have the patient point with one finger to where that pain is at. So we want to have them pinpoint the pain if possible. And there are some conditions where they can't localize the pain in one specific area. Okay, they may draw it out if it's a diffuse pain. All right, so usually they're like, it hurts right here. They're like, it hurts in this area. Radiation is, does that pain move anywhere? So does it actually move to different parts of the body? So for example, people are having heart attacks, right? Usually it's a crushing substernal pain, right? They feel it here, but it does move out to the left shoulder and down the left arm. That's all considered radiation. We have another kind of pain called referred pain that we'll talk about later on, but it's not the same as radiation. All right, and then lastly, we have reoccurrence. So I want to ask the patient, has this happened before? Now, as far as that question of has this happened before, have we already asked that question before?
Yes.
Yeah, right? When I got to P in sample for pertinent medical history. Has this happened before? And if so, were you hospitalized for it? Any recent surgeries? Okay, I can ask it again when I get to reoccurrence. Now, there's nothing wrong with being redundant in your assessment. Okay, you can be redundant as much as you want, that's fine. Okay, we can't fail you for that unless you dramatically delay patient care. Okay, but can we fail you for skipping something?
Yes.
Yeah, so if I never ask that question of has this happened before, that is also enough to fail you on that skill. Okay, now as far as you asking in sample, has it happened before? Yeah, it has. You can just confirm when you get to recurrence. Okay, so you said you've had this issue happen before in the past, correct? Yeah, that's right. Okay, that's fine too. I'm at least acknowledging they've said it, and that's totally cool. You have a question, Ramon?
You answered it.
Cool. All right, now as far as severity, okay, that's going to be having the patient rate their pain on a scale of 1 to 10. So 1 being the least amount of pain and 10 being the most, how would they rate the pain? Usually they'll say 10. All right, so on a scale of 1 to 10, 1 being the least amount of pain you've ever had, 10 being the most of pain you've ever had, how would it be, or how bad would it be? Okay, now sometimes we can ask the patient to quantify their pain. So if they do say a 10, okay, so what else, right, would be a 10 for you? And they'll be like, oh, it was a 10 when I broke my shoulder. Oh, okay, so that's pretty painful. All right, or it was a 10 when I got a paper cut last week. Okay, well, suck it up. All right, so we want to try to have them quantify the pain. All right, sometimes we can call BS on that. Sometimes we can't. Obviously, I can't feel their pain. But if I have a patient sitting there texting like, oh yeah, it's a 10. Is it really a 10? No.
Can you give them quantifiable? Be like 10's getting stabbed in the gut, 1's being smacked. Can you do that?
Well,
with them, kind of?
do you know what being stabbed in the gut feels like?
No, or can you do something like that, quantifiable, you maybe?
Usually no. Matt actually got mad at me at the last class because students were asking questions like that, right? So for example, right, I used to say 1's a paper cut, 10's a broken bone, right? Well, some people have never broken a bone before, so they don't know how bad it hurts. I've broken a bone before, and I know how bad it hurts, right? So for me, a 10 would be when I broke my bone. Right? But other people, again, they have different things. That's why you'd ask them, okay, what is a 10 for you? Right? That way they can quantify that.
I know that scribes have scrub notes. Is there a scrub note version for EMTs that we do all this on?
No. Not always. Right? Sometimes, again, you'll have time to document. That's fine. Right? What some people do is they'll put a little piece of tape on their thigh, but even then, patient care comes first. Right? So, for class purposes, you won't have that stuff either. Right? So I'll tell you a little hint on how to practice this and how to retain it, right? But you've got to be able to run a full patient assessment with vitals and everything else in here, okay? That way, if you need to, right, you can do what you got to do and document later on. All right, now lastly, we have time. Okay, so how long has this pain been going on for? All right, so how long has it been going on for, or what time did it start? Either one of those would be fine. Okay, now time is not the same as onset. Okay, a lot of times people will confuse those questions. Onset is how quickly that pain came on, whereas time is the duration. How long have they been feeling that pain? Okay, now like I said, these are my detective questions. So as I'm asking these questions for responsive medical, I'm listening to the answers because those answers will help me identify different types of issues. For example, when we talk about cardiac emergencies, okay, there's two different conditions, one being an AMI that you guys are pretty much familiar with, another one being angina pectoris. Okay, both are going to be pretty similar, but there are differences between the two. And the way I find the differences between them will be based on the answers the patient will give me to the OPQST. Right? One's going to hurt more, the other one's going to hurt less. One's going to last a lot longer, the other one doesn't last as much. One is caused by exertion, the other one may not be caused by exertion. One does get better with rest, the other one doesn't. Okay, so as I'm listening to these questions, or the answers to the questions, I can go, okay, this is sounding like it might be this type of problem versus this type of problem. Okay, so the differences between different medical issues are found here in the OPQST. All right, so for right now, again, the questions, you just got to memorize that and know what questions we ask. But once we get into medical starting Tuesday, you've got to know what the answers actually mean. And we'll cover that as we cover different issues. All right, we'll say, hey, this type of problem, patients will describe this type of pain, usually rated around this type of severity, lasting for this long, and so on and so forth. Spilling it all right out for you. That way, all you have to do is plug it into the actual assessment and then treat your patient appropriately.
Did you say there were 3 questions per onset?
Yeah, fast and slow we count as separate ones.
Oh.
Yeah. All right, so that's gonna be our medical history. All right, now this tangled thing, all right, that we have up on screen, it's on the bottom portion of your algorithm. Okay, this is gonna be all the stuff that's gonna be laid out in a secondary assessment. Now, with secondary assessment, again, there's no strict, rigid order that we need to follow when running a secondary assessment. I can mix and match to my heart's content as long as I get everything done in the assessment. Okay, so up across the top here are the 4 categories of patients that we have. Responsive medical, unresponsive medical, major trauma, and minor trauma. Okay, so patients can fall into 1, sometimes 2 of those different categories. Okay, so you got responsive medical and unresponsive medical, major trauma, and minor trauma. Now, as far as responsive medical patients and minor trauma patients, they're going to get a focused physical exam. What kind of physical exam?
Focused physical
kind of physical?
exam.
Focused. Right. They get a focused physical exam. And that means that we simply focus on one particular body part. Basically, their chief complaint. Okay, so the focused physical exam, we focus on one particular body part. And the reason why those patients get a focused physical exam, it's simply because they can tell me where it hurts. They can go, ow, my stomach hurts, right? So therefore I only have to focus on their abdomen. Or they go, ow, my leg hurts. So I only have to focus on that injured leg. Right? So it's not complicated. Because they can tell me where it hurts, I only have to focus on that particular body part. Now, as far as the unresponsive medical and major trauma patients, okay, they have to get a rapid and detailed assessment because they cannot tell me where it hurts. Unresponsive patients, can they talk to me?
No.
Why not?
Unresponsive.
Unresponsive, right? They're not talking to anybody. Okay, so therefore, they can't tell me where the issue is, so I have to go over the entire body and try to find it. As far as major trauma patients, yeah, they might be able to tell me where it hurts, but the MOI could possibly indicate spinal injury. And if they broke their spine, right, and can't feel anything past the injury, could they feel their broken leg? No. So to them, they don't know their leg is broken, right? So we have to try to find out, right? And if I start doing this and the leg starts flopping all over the place, oh, that's not normal, right? Now we know they got some type of injury. Okay, now as far as the difference in between a rapid and detailed assessment, the only difference is time. Which one do you think is faster?
Rapid.
The rapid. That's why we call it a
Rapid.
Okay, it should take us 60 to 90 seconds to complete a rapid physical exam. And that's a head-to-toe, front-to-back assessment. Okay, so 60 to 90 seconds for a rapid physical exam. which would be top to bottom, front to back. With a detailed, it's another head to toe assessment, front to back, top to bottom, but we don't have to worry about time. Okay, we can take a little bit longer to run a detailed assessment. Should take half an hour long, but it can take a couple minutes to do a detailed. All right, now within the physical exams, be it focused, rapid, or detailed, we're going to be looking for DCAP BTLS. Okay, we'll talk about what that is in the next slide. All right, but that's stuff we're looking for in a physical exam. We have our vitals, right, being Bell's RP Go. We got sample, which everybody gets. Okay, and then once that's all done, we can do our provider impression, where I go back and summarize everything, and then we do the ongoing assessment, where I reassess and reevaluate our patients. Yeah.
So we only do OPQRST with responsive medical patients?
Correct.
No other, like, not even unresponsive if they like wake up or anything like that, nothing?
Well, then they're responsive if they wake up. Yeah, for, again, trauma patients, the questions don't make sense either, right, for an OPQRST. All right, again, patient got shot. Sir, what do you think caused the pain to happen? Did it come on slow? Did it come on fast?
If they're a trauma patient that, like, say, like you said earlier, like a grandma had a heart attack and then crashed into
Then
a
that's
tree,
fine.
would you still do OPQRST because you know it's trauma still?
Because again, if we can rule in that there was a nature of illness, well, I want to assess the nature of illness as well on top of the traumatic issue. That's why I said some patients can fit into 2 categories. All right. So as far as the physical exam, you guys can go to your patient assessment packet and go to page number 7. Okay, so go to page number 7 in your packet. All right, and this is going to be where all the stuff is in your physical exam. So if you guys want to make it a little bit easier, you can star, circle, highlight all the stuff we're going to cover. Done for about writing everything down at once. Okay, and you guys will need to bring this packet with you on Friday when you go through different patient assessment stations. So at least you'll have it right there with you, right, when you're going through different stuff. Okay. Now, as far as the physical exam, throughout the entire body, doesn't matter if it's the head, the neck, the chest, the abdomen, et cetera, et cetera, et cetera, we're always going to be looking out for DCAP BTLS. What are we looking for?
DCAP BTLS.
Right. Okay, and this is what we're looking for over the entire body. Looking for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, laceration, swelling and scars. And we'd also palpate for tick. Palpate for what?
Tick.
Which is tenderness, instability, and crepitus. Okay, so we're looking for DCAP BTLS, and I'm palpating for tick. Tenderness, instability, and crepitus.
What's crepitus?
It's basically the sound the body makes when you palpate. Oh. So it could be subacute emphysema or bones that are rubbing against each other. All right, so we're going to be looking for DCAP BTLS and palpating for tick. Okay, and one of my biggest pet peeves when it comes to patient assessment is when you guys say you're going to do a DCAP BTLS. Okay, you do not do DCAP BTLS. You look for it. Okay, you don't deform your patient, you don't contuse your patient, abrase, puncture, penetrate, tenderize, lacerate, swell. You don't do any of that stuff to your patient because that's all illegal. Okay, instead we're looking for that stuff as we go over the entire body itself. All right, now we don't care about DCAP BTLS. What? Yeah, we don't care about it because we look for it everywhere. So it doesn't tell me the difference between anything. Okay, instead what we care about is all the individual stuff we're looking for each body part, which is all the stuff we'll be covering right now after we cover trauma. So as far as significant mechanism of injury, so here's where we get to our major trauma patients. Okay, ejection from a vehicle. If our patient gets thrown out of their car, that takes a lot of force. We're probably going to see a lot of injuries. You don't have to fear about writing all this down. We'll talk about it tomorrow as well. Death in the passenger compartment. So if I have a patient who's dead in the passenger compartment and I have somebody who's alive, okay, well, why is this one dead and why is this one alive still, right? Subject to the same force, right? But it's still pretty serious that, again, it killed somebody, right, versus somebody else is still alive. Falls greater than 15 to 20 feet, right, super duper high falls, rollovers and high-speed collisions, auto versus pedestrian, right, auto versus bicyclist, okay, penetrating injuries to the head, chest, torso, or abdomen, okay, where all the vital stuff is at, right, that too would be considered major trauma. Okay, so if we see this, right, we may want to go ahead and consider doing a rapid physical exam, since they are major trauma patients. All right, so when it comes to performing the physical exam, as I'm palpating around the outside of the skull, okay, I want to use my hands stretched out nice and wide, and I'm just looking for generalized DCAP BTLS. Okay, there's nothing really specific we're looking for besides other head injuries we'll talk about tomorrow. Okay, we're going to palpate around the patient's face. Okay, checking around the eyes for raccoon eyes. Checking for what?
Raccoon eyes.
Right, and Matt usually does a little like kind of thing. All right, so we're looking for raccoon eyes, which would be bruising around the eyes. Okay, and that indicates a very particular type of injury, that being a basilar skull fracture. Okay, so raccoon eyes would indicate a basilar, again spelled like basil, like the herb, but with AR at the end. Okay, so it's a basilar skull fracture, which is a fracture along the base of the skull, pretty much along the occipital bone. Right, and that's more of an anterior basilar skull fracture, which meaning is closer to the front, closer to the front. Okay, causing bruising around both eyes. Okay, we're also going to look out for drainage coming out of the nose. Okay, particularly CSF, which is cerebral spinal fluid. Okay, so we're going to look out for cerebral spinal fluid, or CSF, coming out of their nose or out of their ears. All right, now I call CSF brain juice because that's basically what it is. All right, if that's coming out of the patient's head, that tells us the patient has ICP, which stands for
Intracranial pressure.
Intracranial pressure. What does it stand for?
Intracranial pressure.
Right, and that's going to be caused by buildup of pressure inside the head, usually due to brain swelling. And brain swelling is bad. Okay, so as that brain begins to swell, something's got to give, so therefore CSF will start to move out of the way to make room for brain swelling. And if those meninges have been torn, the protective layer around the brain and spinal cord, okay, then we start getting brain juice leakage out of the nose or out of their ears. Okay, and we'll see a picture of a patient who's got CSF drainage coming out of their ears following head trauma tomorrow. All right, we're going to check behind the ears for battle signs, okay, which will be bruising behind the ears. Technically, it's Battle's sign, named after some doctor named Battle. All right, but that too indicates a basilar skull fracture, but more of a posterior basilar skull fracture, meaning it's on the back side of the head. Okay, now with bruising is always a late sign. What kind of sign?
Late sign.
All right, it's always a late sign. All right, just think about whenever you get a bruise, it doesn't show up just like that. All right, it takes a couple of hours before it finally starts getting all black and blue and all that kind of stuff. Our purposes in pre-hospital, a few hours is late. Okay, so we're going to start seeing bruising behind the ears or around the eyes, telling us I got a basilar skull fracture. Right, we'll check the face for any type of facial injuries. Right, and check the mouth for any broken teeth, any blood, any vomit in the airway. So these are all things that will cause airway obstructions. And we also want to look for something known as coffee ground emesis. Okay, so we also want to check for coffee ground emesis, E-M-E-S-I-S. And coffee ground emesis is partially adjusted blood that comes from the upper GI tract. Okay, our body does not like to digest our own blood. So if we have something going on in the upper GI tract, in the mouth, the esophagus, or anything like that, that blood goes into the stomach, the stomach's like, I don't want this, bleh. It's going to throw it up. And if it's partially digested, it starts getting dark and clumpy, looking just like
Coffee grounds.
Coffee grounds. That's why we call it
Coffee ground.
Coffee ground emesis. Okay, but it does not smell like coffee grounds. Okay, it's going to have a very, very foul smell to it, indicating that it's partially digested blood. Now, when it comes to GI bleeds, and we'll talk about that more next week, the brighter the blood, the closer to an exit. The darker the blood, the further away, or the more time it's spent in the body. So with coffee ground emesis, because it's darker, right, in color, it's going to be in the body for a little bit before it finally gets puked back up. Okay, but if it's bright red blood, that means it's relatively fresh or relatively close to an exit. It hasn't spent that much time in the body. All right, for the neck, okay, we're going to be palpating for a tracheal deviation. Okay, so again, seeing if that trachea is shifted to one side or the other. Right, that's a late sign of a tension pneumothorax. Late sign of a what?
Tension pneumothorax.
Right, and that's when you have all this air building up in the patient's potential space. Okay, now whenever we talk about that potential space, you've noticed I've thrown up air quotes every single time. Okay, that's because it's not always there. Right, the visceral and parietal pleura are usually stacked up against each other, and when things start getting in between, that's when we develop this potential space. What kind of space?
Potential space.
What kind of space?
Potential space.
Right, now you guys should start throwing up the air quotes as well. The what?
Potential space.
The what?
Potential.
The what?
Potential.
I'm not hearing it, but I'm not quite seeing it from everybody. The what?
Potential
Right,
space.
it's a potential space. Okay, now if we have a little bit of air in that potential space, that's just a pneumothorax. But when we have a lot of air in that potential space, That's when we get a tension pneumothorax because things are now starting to shift. Starting to what?
Shift.
Starting to what?
Shift.
Right. So as things are getting shifted over, eventually that trachea is going to get shifted over to one side. Okay? That poor little heart that's between the lungs is getting smashed. Okay? Causing blood, right, to start backing up from the heart through the vena cava up into the jugular veins, causing JVD. But is that the only thing that will cause JVD? No, right? There's a lot of things that will cause that to occur. Okay, so the patient will have some jugular vein dissension, and because of all that air in that potential space, okay, generating a lot of pressure, it wants to escape and leave the body. But on its way out, it starts getting stuck in that fatty layer of skin that we call the subcutaneous layer. Okay, so when I go to palpate, what kind of sensation do we get? Right, snap, crackle, pop, just like what cereal?
Rice Krispies.
Okay, and that's what this is a picture of. It's kind of hard to see, right? But you can kind of make out there's a little bit of a bulge right here on the side of this guy's neck. Okay, and if you guys look up subcutaneous emphysema, all your patients that you see are just really puffy and bloated, right? Because they have all that air that gets stuck in their skin and they almost inflate a little bit, all right? Now, if I were to palpate this guy's neck, right around this region, I'd get that snap, crackle, pop as they're popping all the little tiny air bubbles in their fat.
Is that
Now,
bad?
what's up?
Is like popping them bad or no?
No, it's just something we'll find. Yeah, what they'll have to do is they'll actually have to bleed out all that air by taking needles and like just venting it out. All right, now as far as subcutaneous emphysema, we can technically get that anywhere in the body because we're covered in skin, right? But in the case of the neck and upper chest, that's going to indicate it's a tension pneumothorax. Okay, now those are the big three because they indicate a pretty big problem, that being a tension pneumo. Next slide, I'm going to play a video to kind of give you guys an idea of what's actually happening inside the chest when there is a tension pneumo, so you'll kind of be able to see it. Now the other two, medical alert tags and stoma. So these are medical alert tags that will let us know the patient has some type of problem. Okay, and we also have a stoma, which is a hole at the base of the patient's throat. Okay, that is the patient's airway. So do you want to take your thumb and plug it up? No, because then they can't what?
Breathe.
And then they
Die.
Yeah, we call that murder, and that's illegal. Okay, so you want to make sure that you're assessing for a stoma and making sure that it's clear. That way they don't, choke. Okay. Now I call those two the forgotten two. You know why?
You forget it.
Because you always forget them. Okay. So don't forget the forgotten two because they're still important things. Okay. We got to look for those medical tags to let us know they got some problems, and we got to check for the stoma because that is their airway. So let me just go ahead and switch them. Might be some feedback.
Okay, here we have some goat's lungs and a heart in there. It's intubated in a plastic bag to mimic the pleura. Now this lung does have a little hole in it, so we have a pneumothorax just around the side, just a little wee punctured lung. I'm bagging a bit faster than we normally would. But as you can see, the air is escaping from the lungs and into the pleura. And little by little, the bag is getting filled more and more. So currently there's no pressure against the lungs that I'm feeling. It's just as easy as it has been. It's starting to get harder to bag it now. It's really hard to bag it now. And those lungs just are not inflating at all. So it's really tensioned.
Need a needle decompression
Would you like
drug?
to do a,
Or pharyngothoracotomy?
no, need a finger thoracotomy on this bag. Let's see if we can release the pressure. A little hole there.
Now the lungs can inflate.
And inflate the lungs. It's quite a tiny hole you made there, so it's still a bit hard to inflate the lungs. It's certainly easier than it was before. Maybe enlarge that hole a little bit. Yeah, this is on the side there. into thoracostomy. There we go. And we can re-inflate those lungs.
Right, so if somebody were to develop a hole in their lung for whatever reason, or a hole in the chest, right, air is going to start leaking into that potential space, right, eventually causing more and more and more pressure buildup, kind of like we saw in here. Now, with the plastic bag, right, because there's no dividing line, we'll talk about later, right, we're going to have a shift, but in this, everything just kind of evenly compresses in on these lungs in the bag. Right, for us though, one side's going to start filling up and just start pushing things over to one side. Hence why we see all the stuff in the neck. Okay, to try to fix that, somebody, not us, has to make a hole in that patient's chest. All right, they got to relieve all that pressure. Now, if there already is a hole in the chest causing this issue, then we can do something about it, and we'll talk about that tomorrow. All right, but we have to try to find a way to relieve all that pressure. Otherwise, eventually the patient can't breathe, heart gets compressed, the patient dies. Okay. So we'll be talking about, again, tension pneumo. This is the third of about 15 times we're going to talk about it over the next few days. Okay, so we'll be talking about it tomorrow, and this is going to be one of the things that can cause shock in a patient. And obviously, if we see it, we treat it as best as we can, which again, sometimes we can, sometimes we can't. Now, as far as things we're looking for in the chest, okay, we're going to be looking out for a flail chest. Okay, we're going to be looking out for a flail chest. And a flail chest is when I have 3 or more ribs that are broken in 2 or more places. So the flail chest, we have 3 or more ribs. How many ribs?
3 or more ribs.
That are broken in 2 or more places. How many places?
2 or more.
Right. So 3 or more ribs that are broken in 2 or more places. And when that happens, the patient's going to have what's known as paradoxical movement. And paradoxical, in this case, is a fancy word for opposite. Okay, so the patient will present with paradoxical movement, which in this case is a fancy word for opposite. Now, the reason why they have paradoxical movement, okay, those 3 ribs that are broken in 2 or more places are no longer attached to the rest of the rib cage. Okay, they're essentially free-floating and they're isolated from everything else. Now, as far as why we get paradoxical movement, it has to do with our mechanics of ventilation. Basically, what goes where when we breathe. As we inhale, diaphragm goes down, intercostals go out, creating what kind of pressure? Negative pressure. Okay, and that negative pressure is what allows us to suck that air in. The broken ribs that are no longer attached, they get sucked into the chest as well. Okay, and when the patient exhales, diaphragm goes back up, intercostals go back inward, creating what kind of pressure? Positive pressure, allowing us to blow that air out. But that broken piece of the chest is going to pop out. Okay, moving opposite of everything else that we see in the chest. Years ago, we used to have treatments for it, but they found out it was ineffective. So we don't do anything about it. We just go, damn, that sucks, right? And then we just transport it, right? But we are going to see paradoxical movement, and we'll see a video of it tomorrow night as well, okay, where we can see that movement going on. Now, you got to be really careful about that because broken bones in general are super sharp, okay? Especially ribs, right? What can the ribs poke, right, as they're moving back and forth? Which would then cause a pneumothorax that can go tension because of all the air building up in there.
Potential
in their what?
Potential space.
In their what?
Potential space.
You're not seeing it in their what?
Potential space.
Right. Okay, so we got to look out for that. Now, as far as a sucking chest wound, okay, it's a wound in the chest that sucks, literally and figuratively. Okay, all right. So we'll talk about management a little bit more tomorrow, but basically it's a hole in the patient's chest that sucks. All right. So as far as auscultation, now during a rapid and detailed assessment, I'm not terribly concerned about anterior auscultation of lung sounds because I've always got access to the front. Okay, so we're not going to make it a big deal that you don't auscultate in the front because you've always got access to that. You will need to auscultate in the back because you generally only get access to it once during a physical exam. Okay, now as far as auscultation along the back, again, we go about the 2nd, 5th, and 7th intercostal spaces, tracing out the patient's scapula, which is somewhere right around here. Okay, so we want to go and listen here, 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 zigzagging back and forth across the chest. Okay, when we auscultate, we never go down one side and then down the other. Okay, because we want to compare lung sounds. All right, I want to know, okay, is there a subtle difference between the right and left lungs? Because lung sounds is probably one of the hardest vitals to master. Okay, because it's not going to be a clear-cut lung sound every single time you auscultate. Like I said, it can be hard to tell the difference between rales and rhonchi in some patients. Right? I've been out of it long enough to where I probably won't be able to tell the difference in some patients. Right? So you really, really have to tune your ears. And if you go down one side and down the other, you may not pick up those subtle differences between lung sounds.
If you say like you hear something but you don't know exactly what it is, can you ask them to breathe one more time to like double check it?
Yeah. Yeah, you can ask them to breathe. Just don't keep them doing it because then they're going to hyperventilate and pass out. But we can ask them to do it a couple times if need be. All right. Now, as far as the abdomen, okay, we're going to be looking out for 5 things in total in the abdomen. We're going to look for rigidity and distension. Okay, so we're going to be looking out for rigidity and distension. And there are 2 problems in the abdomen that can lead to rigidity and distension. All right. So, sir, what is one problem in the abdomen that can lead to rigidity and distension?
Death?
No, because these things will cause death.
Okay.
No? Sir?
The rupturing of a hollow organ.
Perfect. Which is going to cause what?
Bad stuff to go to the rest of the body.
Not to the rest of the body, to the abdomen. It's not bad stuff, it's nasty stuff.
Nasty stuff.
Okay, so you get all that nasty stuff in the abdomen. What infection does that create? What do we call that infection? Sir?
Does it start with H?
It does not start with an H.
I don't know.
Peritonitis. What does it cause?
Peritonitis.
What does it cause?
Peritonitis.
Because it's infection of the peritoneum, which is the lining of the abdominal cavity. Okay? Do we have X-ray eyes?
No.
No. So can I see the nasty stuff filling inside the abdomen? No. But are there signs to indicate that?
Yes.
Yeah. Okay. So rigidity, dissension, pain, and outward quadrants can tell me, but that also indicates something else. So how would I be able to tell it's peritonitis versus this other problem that we'll talk about in a second?
You could tell because of the.
Think about it. It's an infection.
Because they're gonna be like sweating and like have like fever, like I don't remember.
Well, you're kind of close. Yeah, they're going to be sweating, but both of them will be sweaty. But fever. What do you mean by fever?
They're gonna be like drenched in like sweat. And they're gonna
Well,
be
we already
hot.
said they're both going to be sweaty. They're going to be hot. Okay, and what color skin would they have?
Pale.
Not pale. What color skin?
Flushed.
Why?
They're the vasodilation.
Right, they're vasodilated. Their blood vessels are opening up, okay, in compensation for that temperature increase. Right? Peritonitis is an infection because we've got nasty stuff in the abdomen. Does the body like having nasty stuff inside of it?
No.
No. So it's going to try to cook out that nasty crap by jacking up the temperature. Does the body like being hot?
No.
No. So to try to cool off, they are going to vasodilate, getting that hot blood away from the vital organs so we don't cook them, getting them out to the skin so we can radiate that excess body heat. And when the patient's really, really hot, they get really, really
Sweaty.
that we call diaphoretic. It's called what?
Diaphoretic.
Called what?
Diaphoretic.
Not clammy, because clammy is kind of sweaty. Diaphoretic, again, is drenched in sweat as it's trying to cool himself off. Okay? Now, we have hollow organ rupture, right, with all the nasty stuff. Miss, what other kind of organs do we have in the abdomen?
Solid.
Which are full of?
Blood.
Full of blood. Okay, and if we rupture one of the solid organs, we have all this blood filling up in the abdomen, essentially filling it up like a water balloon. And does it take a little bit of blood or a lot of blood to make that happen?
A lot of blood.
Right, so much blood the patient's going to start going into what?
Shock.
What kind of shock?
I'm sorry.
You too, deal with it.
Hypovolemic shock.
Right, hypovolemic shock. What kind of shock?
Hypovolemic.
Right, hypovolemic shock, because they're losing lots and lots of blood. So, miss, what skin signs would they have if they're going into hypovolemic shock?
They will be pale.
Uh-huh.
The clammy.
Not clammy, because again, that's kind of sweaty.
Okay. Then diaphoretic.
Diaphoretic, and?
They would have like the distended.
Well, yeah, we already said that. But as far as skin signs,
Pale.
Right. They're going to be pale, cool, and diaphoretic because they're going into what kind of shock?
Hypovolemic.
Kind of shock?
Hypovolemic.
Right. Hypovolemic shock because of all that blood loss. So the body's simply kicking that sympathetic response, trying to compensate for blood loss. So they take blood from the skin and redirect it back to the core to maintain core perfusion, giving them pale and cool skin. Okay, does the body like being hot or does the body like being cold? No. Which one? It's hot or cold? What is it like?
Middle.
No, it likes to be cold.
Oh.
Okay, we'd much rather be cold than be hot. Okay, so to try to cool ourselves off, to run a little bit better, right, we're going to start sweating. Okay, so patients will be showing those skin signs. But again, it's not the similarities because both internal bleeding and peritonitis will present with a rigid and distended abdomen with pain in all four quadrants. Which means every time I palpate, what are they going to say? Ow. Ow. Okay, but when I do this, and they're hot, flush, and diaphoretic, crap, they got peritonitis. Or if I do this, and they're pale, cool, diaphoretic, crap, they have internal bleeding and are going into hypovolemic shock. Okay, so again, we got to start focusing on the differences and not the similarities. And again, pay attention to the stuff that's happening on the inside versus the signs that I see on the outside, because there's a one-to-one correlation between those two. All right. Now, the other things we're looking for in the abdomen are going to be a pulsating mass to the lower left quadrant. Okay, again, that's going to be an indication of a AAA, which is an abdominal aortic aneurysm. Okay, so pulsating mass indicates a AAA, which is abdominal aortic aneurysm. Okay, and we'll see that underneath the patient's skin. Okay, doing a little something like that. Now, if I see that, do I go, ooh, and touch it? No, because if I do, it ruptures, and then what happens to your patient? They die. Okay, so we leave it alone. And there's going to be other signs besides the pulsating mass. Patients are like, oh, that's kind of cool. All right, there's a lot of other things that's going on with them to indicate that they have a AAA. Okay, now again, that's happening because the layers of the blood vessel are getting super duper thin to the point where it just bulges out due to the pressure, right? And eventually it may rupture and then cause the patient to bleed out pretty much within 30 seconds or less. All right, we're going to be looking for signs of pregnancy, obviously in female patients. Okay, so look for any type of baby bumps or anything like that. And then lastly, look for abdominal eviscerations. And that's when their insides are now outside. Okay, we went over the treatment of that last night, but again, it's more reference for osmosis than anything else. We'll cover the treatments again later. Okay, but if their guts are hanging out of their body, obviously we want to take care of that. All right, after that, we're going to move on to the pelvis. So when I squeeze the pelvis, we push once medial, once posterior. Okay, now just a disclaimer, LA County in the field does not recommend pelvic palpations for any patient with pelvic injuries. Okay, because we can lose up to 2 liters of blood. How much blood?
2 liters.
Right, from any type of pelvic injury. And like we were saying last night, that's just the broken bones. That's not the major blood vessels that are passing in that region. Okay, so LA County does not want us palpating when we're in the field. But for class purposes, do we have to know if you know how to check a pelvis?
Yeah.
Yes. Okay, so for class purposes, you will have to assess the pelvis. So basically out there, if they get hit by a truck, do you check their pelvis?
No.
And here, if they get hit by a truck, do you check the pelvis?
Yes.
Yes. Okay, which would be 1 push in, 1 push back. Now, as far as what we're looking for, okay, we're going to be looking for incontinence. Looking for what?
Incontinence.
Okay, which is the loss of bowel or bladder control. Okay, so we're going to check for incontinence, which is the loss of bowel or bladder control. So that they pee or poop themselves, involuntarily, usually. Okay, and we like to call that a code yellow or a code brown for obvious reasons. See if any of that's going on. Yeah, a little late now. All right, so as far as incontinence, okay, we're going to check for any bleeding in males. Okay, any excessive bleeding for females. Okay, so any bleeding in male patients, any excessive bleeding for female patients. And in male patients, we're going to be looking for a priapism. Okay, so for male patients, we're going to be looking for a priapism. And a priapism is an unwanted erection caused by a spinal injury. Yeah. Okay, so he's not happy to see you if he has a priapism. So don't flatter yourself. Okay, patient's got a spinal injury. Right, so that's the stuff we're looking for. And then we get to the extremities. And we're going to palpate using offsetting pressure going down the length of the limbs to try to see if there's any type of decap, ETLS, or tick. Once I get down to the hands or feet, we got to check CMS. What do you got to check?
CMS.
Which stands for?
Circulation, motor, sensory.
All right, yeah, it's on the screen. All right, so check circulation, motor, sensory, okay, in the hands and feet. All right, so check pulses just to see if they're there. Check motor if they can wiggle their fingers. And then sensation if they can feel what finger or toe we are touching. Okay. Okay, tomorrow when we cover musculoskeletal injuries, CMS is going to be super duper important. Okay, 4 rules of splinting, again 4 being the magic number of this class. Rule number 1, and the one you always screw up, okay, is checking CMS before and after splinting. Usually you don't, right? Because we need to check the neurological status before and after I apply a splint to see if there's any changes. Okay, and that's all stuff we'll cover tomorrow. Okay, but you do need to know that, hey, when I get to the hands and feet, I got to check CMS. If we haven't done so yet, we'll roll the patient over to assess their back, especially if they have spinal injuries or anything like that. So we're just going to go and check the back of the head. Okay, so we're going to palpate, just checking for general decap BTLS. We can walk along the spine if we haven't done so yet, checking for step off. Checking for what?
Step off.
And step off is any misalignment of their vertebrae. So the vertebrae should be stacked on top of each other, pretty much straight on top. But step off is any shifting of the vertebrae whatsoever, pinching or possibly severing the spinal cord. Okay, and we'll feel that, right, because we'll feel the difference between the vertebrae.
Is it like clearly obvious that it's not like scoliosis? Scoliosis?
Yeah.
Yeah.
Okay.
Yeah, because it's all based on MOI. Right. We're going to check the sacrum for any sacral edema, so any fluid buildup back there caused by a lot of different things. Check the back for incontinence, make sure that MP approved himself. And for the back of the legs, we're just going to visualize. We're just going to take a peek to see if we see anything. We don't have to worry about palpating the back of the legs. Okay. Now, once you've done that, now we're going to roll the patient onto the floor or backboard, and that will complete our assessment. Okay. On Friday, we're going to take you guys through a physical exam station, where we're going to give you the hands-on demonstration of how to do a physical exam, top to bottom, front to back.
When you're doing that back check, I see it kind of looks like a log roll. Would you do that while you're putting them on the backboard? Say like you're about to put them on, you check it and then you put them on there.
All right, so that's going to be our physical exam. Now, as far as a rapid physical exam, how long should it take to do a rapid physical exam?
60 to 90 seconds.
All right, 60 to 90 seconds, done for an unresponsive medical major trauma patient because they can't tell you where it hurts. Right, so therefore I got to check the entire body. As far as a detailed physical exam, it's the same thing. I'm just not worried about time. Okay, I'm still doing a front to back, head to toe assessment, just a little bit slower. Whereas a focused physical exam, because they can tell me where it hurts, I only have to focus on that one particular body part. Okay, so we don't have to go cutting off all their clothes and touching them head to toe in a focused physical exam. All right, we only have to focus on the area of the chief complaint. Now, as far as the provider impression, right, basically just go back and summarize everything down there. Okay, once we do all that, we're now going to get ready to do the ongoing assessment where I reassess and I reevaluate our patient as we transport to the hospital. Okay, now as we're doing so, we're going to be checking to see if the patient's getting better or if they're getting worse. Okay, and we do so by checking their vital signs. Again, the first set of vitals that we get, we call it the baseline. What do we call it?
Baseline.
All right, the baseline set of vitals. That way I know, again, if the vitals are getting better or if the vitals are getting worse based on that starting point. Okay, so we check those baseline vitals. We check to see if there's any new issues that are developing. We can go back and reassess like an OPQRST. Right, okay, hey, is your pain getting better? Is your pain getting worse? Is the pain changing? Is it moving to different areas? We can go back and reassess an OPQRST. Sample's probably not going to change. Right, I can maybe do a physical exam again if I have to, if there's something new that may have developed or gotten worse. Right, but you want to go back and reassess things in the secondary.
Is there, because I know you like reassess this, there's certain times depending on some patients, but if they start complaining, can you like move it ahead of schedule? Say,
Yeah,
like,
of course. It's got to be at least every 5 or 15 minutes.
Okay.
So if I got a stable patient, I want to check them off in 10 minutes, that's fine. All right, so as far as reassessment, again, stable patients every 15, critical patients every 5. Okay, so we'll just go back and check their vital signs and stuff like that, at least that frequently. All right, and of course, we'll just document everything as we're going through. All right, you can tell it's an old picture because he's wearing shorts. Nobody wears shorts in EMS. All right, but we'll just go and do that as we're transporting our patients. All right, now we're going to be talking about communication, documentation stuff in a little bit, so we'll go back over this. But there are going to be some things that will complicate our assessment, right, when it comes to certain types of patients. And like I said, we'll cover that in the next chapter. So as far as secondary assessments, okay, secondary assessments can be split up over different people. So for example, here in LA, is it just me and my partner that show up on calls?
No.
Usually not. Okay, usually we're going to have a bunch of people there. Okay, so for example, right, we can have a medic who's taking the lead. They're running a primary assessment. I might be doing vitals. right? My partner may be doing a medical history. We might have somebody else, right, who's going to be gathering medication specifically, right, doing that kind of stuff. So we can split up the secondary assessment. I can either do it on scene or I can do it en route to the hospital. So for example, if I've got a major trauma patient, how much time do I want to be on scene for?
Less than 10 minutes.
How much time?
10 minutes.
Right, 10 minutes or less. Okay, so if I got my patient stabilized, packaged, ready to go, right, my partner's in the middle of their vitals, I'm not going to wait for them to finish. Okay, the patient's ready to go. Let's get them in the back, and you can finish up as we drive. Okay, so we can do a secondary assessment, either on scene or en route or both when it comes to our patients. I can do them in any order that I want. Okay, but we have to get everything else done whenever possible. You want to try to prioritize which part of the secondary would come first. For example, major trauma patients, do I want to ask them questions, do vitals, or do a physical exam first for major trauma?
Physical exam?
Physical exam. I want to get that physical exam done so I can package them and get them to the hospital. Because I can do vitals en route, I can ask questions en route. Okay, but I want to get them off scene and out of here as soon as possible. Now, if I got a patient who's stable, okay, I can do a physical exam later if I want to. I can ask them questions now. I can do vitals now. It doesn't matter, right? But we still have to do everything in the secondary assessment. And because they're stable, screw it. Let's hang out on scene, right? And then we can go to the hospital afterwards. All right, so you just have to figure out what you have to do, when you have to do it, depending on your patient. Okay? So I'm going to go run through a secondary assessment for you guys so you can hear what a full one's supposed to sound like, and then we'll move on to the rest of the stuff. So just to recap, right, he's got abdominal pain. So we got a male patient, early 20s, sitting in the Fowler's position, complaining of abdominal pain. He's stable, no signs of shock. We've exposed and palpated the abdomen. He's got pain to the lower half of his belly, no obvious signs of trauma. So we're going to hang out on scene and run a secondary assessment here on scene, and then get ready to transport code 2, checking vitals every 15 minutes. So there's my field impression, and now I can jump into a secondary. So because I have Casper with me, as soon as we got consent, what did I have Casper start working on? Vitals, right? And what mnemonic do we use for our vitals?
Bell's paper.
Bell's RP Go. What is it?
Bell's RP Go.
What is it?
Bell's RP Go.
And is that the order in which I do it for all of my patients? No, right? But in this case, would that be okay?
Yes.
Yeah, because I'm not worried about his brain, not worried about his heart and circulatory system, and I'm not worried about his lungs. Okay, so Casper can do vitals and Bell's RP Go, and that'd be totally fine. Okay, as far as the physical exam, he is a responsive medical because he can tell me where it hurts. So therefore, what kind of physical exam does he need to get? A focused, right? He needs to get a focused physical exam because he can tell me where it hurts. Now, I like to palpate in the primary assessment. And because I did that, I've already done a focused physical exam. Okay, and that's why we recommend you do it. You get it over with, and you don't have to worry about it in the secondary assessment. And it gives me more information earlier on, so I can kind of guide my secondary assessment a little bit. Okay, so my focused physical exam is complete. All I have left to do now is medical history, going through sample, and because he's responsive medical, asking him what other set of questions? OPQRST. So I like to start with the sample first because I just want to get it out of the way. Signs and symptoms I already know. He's got abdominal pain, no signs of trauma, there was some pain and palpation, and no signs of shock. Cool. Sir, do you have any allergies to any food?
No.
No? Allergic to any bugs?
No.
Any medications you're allergic to?
No.
No? Anything out in the environment, like grasses or pollens or anything like that?
Yes.
What are you allergic to?
To pollen.
Allergic to pollen. All right, cool. As far as medications, are you taking anything prescribed by a doctor?
Albuterol?
Taking albuterol.
Yeah.
Okay. Anything over the counter?
Yes.
What are you
Flonase.
taking Flonase. Okay. All right. Any sort of vitamins or supplements?
Everybody I don't know, zinc?
Okay, sure. That's a supplement. All right. Any recreational drug use?
No.
Are you sure?
No.
You positive?
I am positive.
What'd you test positive for, sir? Works every time. Every time. Okay. So, as far as pertinent history, have you had any type of abdominal pain like this in the past?
No, I haven't.
No? Okay. Any hospitalizations I have to be aware of for anything at all?
There isn't anything related to this.
No? Okay, but have you ever been to the hospital for anything?
Yes.
For what?
Stitches.
For
on my
stitches.
head.
Because you hurt your head?
Yes.
Obviously. Okay, cool. All right. Any doctors or specialists you're seeing?
Mm-hmm.
No?
No.
Okay, cool. What did you have last to eat or drink?
Chick-fil-A.
At Chick-fil-A? How long ago?
About 3 hours ago.
About 3 hours ago? Okay, anything to drink with that?
I had water.
You had water, and that was with the meal?
That was with me.
Okay, cool. And what were you doing when your stomach pain started?
I was studying for the anatomy quiz.
Studying for your anatomy quiz, okay. So, right, based on my sample history, okay, I got some basic questions that I need to ask everybody. right, getting some pertinent information from our patient. So now I want to try to figure out what's going on by asking him an OPQRST. So just answer as best as you can, okay? So as far as onset, what do you think caused your abdominal pain to occur?
The Chick-fil-A.
Sounds about right. Okay. Did the pain come on fast or did it come on slow?
It was during the anatomy quiz.
So did it come on fast or did it come on slow?
Slow.
There we go. Okay. So what do you think makes your pain feel better, if anything?
When I lay down.
When you lay down? Okay.
Yeah.
What makes it feel worse?
When you're checking it.
When I was checking it, when I was pressing down on it?
Yes.
Okay. Sorry about that. All right. As far as quality, can you tell me in your own words what your pain feels like?
I'd say I can't describe it.
Can't really describe it. Would you say it's like a cramping pain?
It would be, yeah.
Yeah, kind of like a cramping pain? Okay.
Yes.
With one finger, can you show me where that pain is?
It would be more in the bottom.
More in the bottom half, and does it like bounce back and forth there, or does it go anywhere else in your body?
It just stays more to the left.
Just stays more on the left side?
Uh-huh.
Okay, and you said you've never had anything like this before in the past? Okay, on a scale of 1 to 10, with 1 being a little bit of pain and 10 being the most pain you've ever felt, how bad would you rate this?
6.
About a 6, and what's a 10 for you?
A 10 when I broke my ankle.
When you broke your ankle? Okay, as far as time, how long ago did this all start?
I would say 2 hours ago.
About 2 hours ago.
Yeah.
Okay, so there's my OPQRST. Now, like I said earlier, okay, for you guys right now, those questions don't mean anything because we haven't gone into medical. Okay, but once we do get into medical, right, then certain types of medical issues will cause certain types of things, therefore giving us certain answers in the OPQRST. So, now that we've done that, we can go ahead and give our provider impression as we get to the hospital and we transport. Okay, pretty much talking to a doctor or nurse or ALS or anybody else who has no idea what's happening with this patient so far. Okay, so we pretty much want to provide a summary from start to finish. Okay, so let's say we now have a doctor, right, who has no idea what's happening. We get to the hospital, so we want to tell him what we got. So you have a male patient in his early 20s. We found him at home in the phallus position, complaining of abdominal pain. He was pretty much stable on scene, no shock, no O2 was administered. We exposed and palpated the abdomen. There was no obvious trauma, no pain of there was pain of palpation to the lower quadrants. Patient states he does have a history of asthma. He does take albuterol for it as well. He does also take Flonase due to his allergy to pollen. Patient states he had Chick-fil-A about 3 hours prior to EMS arrival. He was studying for his anatomy quiz when the abdominal pain came on with the gradual onset. He rates it about a 6 out of 10. Patient states he does feel a little bit better as he lays down, but it does get worse upon palpation. It does radiate a little bit, but he did say it stayed more to his left-hand side, and the pain came on approximately 2 hours prior to our arrival. Vitals are blah, 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 and we reassess them every 15 minutes on the way here. Okay, so you're pretty much just going back and summarizing everything we got on that call so far. Okay, now, as far as writing it down, again, do we always have the opportunity of writing stuff down? No. Okay, so to help kind of remember that information, every time he answered a question, what did I do? I repeated it back. Okay, by repeating back, having this closed loop communication, okay, it serves two purposes. One, more importantly, it helps me remember what he said so I can regurgitate that information later on. Because all I'm doing is pretty much replaying what he said in my head. Okay, he said this for onset, he said this for P, he said this for that and that. That way I'm just going back and restating it. For the patient, it makes him feel like I'm actually listening to what he has to say. But again, more importantly, it's for me, right? But at least it shows that I'm kind of engaged, right, with that patient and what he's saying. Okay, so that is how you're going to be able to retain that information as you go through. Okay, if you're getting vitals, okay, you are calling out your vitals. Hey partner, I got a blood pressure of 110/70. Hey partner, I got a heart rate of 78. Hey partner, his pupils are pearl. Okay, by you saying that, again, you're able to retain that information for later terms. Now, if my partner is calling it back out, I'll repeat it back. Going back to that closed loop communication. All right, cool, I got that. Blood pressure 110/70. Okay, heart rate 78. Cool, got it. Pupils pearl. Awesome, thank you. Okay, that way I'm also communicating with them. I can remember what's being said.
If you said you check his vitals every 15 minutes, what if the drives aren't that long? How often would you check?
Then we'll check once we leave and once we get on scene for the hospital. Oh. Yeah, so especially here in LA, if it's like an 8-minute transport, okay, I'll check when I leave and I'll check when I get there. And that's fine. All right. So any questions on the secondary assessment? All right, so we're going to go over documentation, communication, more fun stuff. All right, but I'm going to tell you guys pretty much exactly what you got to write down, okay? Because most of this, just like most of our job, has to do with what? Communication. Communication. Okay, so as far as communication, okay, it is a mixture of both verbal and nonverbal communication. So verbal is obviously everything that we say, right? Nonverbal will be things like hand positioning, body gesturing, things like that, okay, that we do have to be mindful of when we are dealing with patients. Okay, again, things like taking a knee, right? It's going to help calm that patient down right? Instead of, some big old tall firefighter who's leaning over grandma, gonna make her freak out, okay? So we wanna try to make our patients comfortable when we communicate. Now, as far as proxemics, okay, that's gonna be distance and communication, right? And how both kind of relate to each other. Now, as I'm dealing with my patients, okay, do I wanna be super duper far away from them? No, right? I don't wanna be yelling at my patient from across the room as I'm running my assessment. But at the same time, okay, do I wanna be all in their personal space? No. Okay, I want to kind of provide a little bit of a cushion between myself and my patient. 3 to 4 feet they found is kind of the sweet spot, right, when it comes to communicating with somebody. All right, you're close enough to where you're still, able to communicate with them, but you're far enough away where we're not in their personal space. Okay, it's also a safety thing. Okay, especially with psych patients, are they going to be calm 100% of the time?
No.
Hell no. Okay, they can snap just like that and then become violent. And having that 3 to 4 foot gap gives me a little bit of time to start reacting, right, and getting away. Okay, and that's why we never really want to sit on our butts either in this job and appear lazy. Okay, but I also want to be ready to move at a moment's notice. Okay, so we take a knee, that way all I have to do is spring back, right, and I'm back on my feet and I can do what I have to do. Right? So you want to make sure that you are kind of ready to move as needed. Now, as far as communication, again, we use open-ended and closed-ended questions. Open-ended questions are what we ask for A&O questions. What's your name? Where are we? What time is it? Okay, it forces the patient to give me more than a yes or no answer. All right, so for A&O questions, we always use open-ended. But there's other times, like consent, where I can do a closed-ended question. Can I help you? Yeah, you can. Perfect, that's all I need. Okay, I can also use that for patients who have shortness of breath, right? Because I don't want them to tell me full-on sentences if they're having a hard time breathing, right? A simple yes or no, right, will be fine in those circumstances. Okay, so we have to know when we can use those different types of communication techniques. Now, as far as age, culture, and life experience and things like that, okay, we do have to alter our assessments based on those factors. For example, if I have a patient that's my age, I'm going to keep it super casual. Hey, bro, what's going on? What's hurting you? Can we help you with that? Super duper casual. Okay, if I'm dealing with a kid, right, am I going to talk it the same way I would somebody my age? No, I'm going to dumb it down for them, right, to make it a little bit easier. Okay, if I'm talking to an older patient, am I going to talk to them the same way I would a kid or somebody my age? No, right? I'm going to be a little bit more respectful, speak a little bit slower, right? And explain things a little bit more. Okay, that way they can understand what's happening. So you have to alter, right, the way you talk based on your patient and essentially your audience. Okay, as far as culture, if possible, try to figure out, what area you're going to be working in, right? What the dominant culture is, and at least learn some of their customs. That way you don't accidentally piss somebody off. Most of the time, they're okay with it, making mistakes because they know that we're not there to, do all that kind of stuff and be rude on purpose. But every once in a while, you do the wrong thing, somebody gets pissed off. So you just want to try to minimize that as much as possible. Okay. As far as touch and whatnot, okay, we can use that every so often, right? But you have to know when to use touch. Obviously, we have to palpate. Okay, so we do have to do it objectively to actually figure out what's going on with the assessment. But sometimes we can do it for comfort. Okay, so like right here, holding onto the patient's hand, holding onto the shoulder, is that okay?
Yes.
Yeah, right, as long as for a couple seconds. Okay, but do I want to be like this for the entire assessment? No, right, because I got a job to do, right? But again, showing that every so often, okay, showing compassion and empathy and all that kind of stuff, right, putting the patient at ease, that's fine. Okay, now if I have to, excuse me, then I have to go and of course, palpate the chest, the face, and all that kind of stuff. But I don't want to sit there, can I? All right, I don't want to sit there and hold on to my patient and be like, all right, sir, it's okay. Right, I don't want to do that kind of stuff. Okay, so we have to know, again, when to use, right, touch and all that kind of stuff. All right, as far as the golden rules of assessment, okay, never lie to your patient. Actually, let me rephrase that. Almost never lie to your patient. There's a couple exceptions. All right, so we do want to tell them the truth in most aspects, especially again if they ask us, am I going to die? Okay, like I said in intro, okay, don't tell them, yeah, you're done, but hey, we're doing everything we can, but it's not looking good. Okay. Again, be aware of body language. Okay, for some patients, we have to speak slowly, clearly, and distinctly, especially geriatric patients. Okay, and we'll talk about why, because there's an actual physiological reason as to why we got to talk like that to them. Okay, we'll cover that when we hit geriatrics. Okay, and this is something, again, we've been trying to go after you guys for the last couple of days, and we'll continue to go after you guys for the entire course. Act and speak in a calm, confident manner. Okay, you should be comfortable and smart enough to be able to run an assessment without getting too worked up and too stressed. Okay, when you guys are out in the field for the first time, it's totally natural to be scared. Totally fine. Okay, but can you let that affect your job?
No.
No. Okay, so one thing that pisses me off is when you guys are going through scenarios, sitting in class, like, oh, I can't think, I'm nervous. Okay, this is all simulation. Okay, it's not personal either. Okay, this is designed to get you guys to freak out on purpose, right? That way you get that sympathetic stimulation and you can calm yourself down for when you actually have patients that are in front of you that are bleeding out, that are crying, that are screaming, right? Because you can't let that get you into a spin to where you can't do your job. Okay, so as we're barking at you guys in scenarios and whatnot, tune it out. Okay, it's all by design. That way you can do what you have to do, right, and get your job done. Okay, and again, going in class, you guys are like, I think it's this, right? You are going to see. Are you sure? Are you asking me a question? Or are you telling me, right? Because I want you guys to at least say, hey, it's this. If you get it wrong, big deal, right? Again, we can fix your knowledge base. Can I fix your personality?
No.
No. Okay, and again, you have to be that more type A personality when you're in the field. Even if you're not, you still have to be type A when you're on work. Okay. Now, as far as communication tools, there's a few things we've got to use, right? As far as communicating with patients, obviously one of them is reflection and repeating back, right? That closed loop communication, like I was just talking about. Okay. Summarizing and explanation. Okay, telling the patient what you're going to do before you do it usually is nice, right? Especially if it's going to be a painful procedure. Let them know ahead of time it's going to hurt. All right. Things you want to avoid, okay, is belittling your patient, okay, talking down to them, right? Obviously, you don't want to do that, okay? Giving any type of advice, right? We're not in a position to give advice, okay, especially if we've never been in a situation like that, okay, where it's identical. So, for example, when we talk about, depth of pediatrics, okay, I can't tell the parent, be like, hey, if I were you, here's what I'd do, right? We can't do any of that stuff, okay, because we haven't been in identical situations. Okay, we don't want to speak in professional jargon to the patient either, okay, because they'd have no idea what the hell I'm saying to them. Okay, kind of like you have no idea what I'm saying half the time to you guys right now. Okay, but you do have to explain to the patient in layman's terms what's happening. Okay, so for example, if I have a patient who is having an MI, right, I'm not going to tell them, sir, it appears to me that you're suffering from acute myocardial infarction, secondary hypoxia due to blockage in your coronary arteries. We're going to take you over to cath lab. They're going to go and give you some thrombolytic medication, dissolve that blood clot, and restore perfusion to your myocardium. That patient understood nothing that I said. All they think is, oh shit, I'm dead. Okay, because they have no idea what I just said. But if I tell them, hey, it looks like you're having a heart attack, right? You have a blockage in one of your blood vessels in your heart. So we're going to take you to the hospital. They're going to give you some medications to open it up and pretty much get that blood flow back in. Oh, that doesn't sound too bad, right? At least the patient knows what I'm saying. Okay, so again, we have to dumb it down when we're talking to patients. But if I'm talking to other medical professionals, do we have to use proper terminology?
Yes.
Yeah. Okay. So again, to avoid looking like a dumbass, make sure you're using your proper terms in the right way. All right. When it comes to bystanders, okay, if they're going to be assets to us, leave them be. Right. Let them stay on scene. Okay. But if they're going to be liabilities, do we want them there?
No.
No. Okay. So if you have family, friends, or anybody like that that can act as a translator, by all means, keep them there. Okay, if you have patients who have behavioral issues or anything like that, and they're familiar with somebody and it calms them down, leave them there. Okay, but of course, we all have that one friend who wants to help out when they're drunk and they're plastered. Do you think you want them there? No. Okay, because then they just get in the way. Right? If you have patients again who are victims of assault or anything like that, and the attacker's there, try to separate them as best as you can. Okay, so we do have to manage that scene. Right? And don't be afraid to have somebody else on the team who's not doing anything, usually a firefighter. Right? Pull that person aside to get them distracted. Okay? Yeah.
So I know you said like people like especially if they have behavioral problems or something like that. Can that person come with us in the ambulance during transit? So say like they don't speak English and someone like in their family does. Can that person come in the ambulance with us to like translate with us on the way to the hospital?
That usually is based on company policy, right? And how the patient is and how critical they are and stuff like that. So that's usually down to the individual company as far as who they'll allow in the back and when. All right. Now, when it comes to geriatric patients, okay, I know it's going to sound kind of weird and messed up right now, and we'll talk about it when we cover geriatrics. Okay, but we treat them like a regular person until proven otherwise. Okay, no, it sounds kind of weird. Okay, so what I mean by that is don't assume that just because they're old that they're senile and they have Alzheimer's and they're deaf and all that kind of stuff. Okay, we treat them like a regular patient until we find out those deficiencies. Okay, so if I'm walking up and I'm talking at my normal volume and they're totally ignoring me, right, then I'll start slowly elevating my volume to the point where the patient goes, oh, I didn't see you guys were there, right? That way we know that they're actually hard of hearing. Okay, we want to speak slowly, clearly, and distinctly for them. Again, we'll talk about why when we cover geriatrics later. Okay, if we have the time, gather any type of equipment they need to help them out. Hearing aids, glasses, dentures, mobility equipment, things like that. For kids, okay, we have to try to dumb things down so the kid can understand what's going on. Okay, get down to their level so they're not freaking out. Okay, now most of the population doesn't know the difference between an EMT and a paramedic, and a kid definitely doesn't know the difference. Okay, all they know is that we're with the ambulance and we're the good guys, but we also give them shots. Okay, which obviously we can't really do injections as EMS, as EMTs. Okay, but we want to try to explain to the kid what's going on prior to doing it. Okay, if they have little things that make them feel comfortable, like their little teddy bear or whatnot, okay, if we can, we'll go and let them gather that piece of equipment to put them at ease. Okay, have them sit on mom or dad's lap, right? That way they're more comfortable. We can give them the equipment, let them handle it if they're critical or if they're stable enough. That way they know that, oh, when they check the stethoscope on my chest, it's not going to hurt me, right? Or do it on mom or dad or do it on their teddy bear. That way the kid goes, oh, it's not really scary, it's fine, right? And they're not going to freak out as much, okay? Again, if something's going to hurt, tell them ahead of time, right? I can't tell you how many calls that I've been on where I've had some burnt out medics who are going to start a line on a kid. They did it out of sight, out of mind, and all of a sudden they give the nod, and then everyone just jumps on that kid, right, as they try to start the line. Okay, so, right, you just want to try to tell them ahead of time that, hey, they're going to give you a little shot. It's going to hurt, but they're going to give you medication to make you feel better, right? That way they're like, okay, right? At least they know what's happening. Now, as far as hearing impaired patients, okay, again, we want to talk to them at normal volume until we get to the level where they can actually understand what's being said. Okay, so just because family says, oh yeah, they're deaf, don't come yelling right at the top of your lungs because they may have a hearing aid that's already on, right? So just speak to them and slowly and gradually increase your volume until they can actually hear us, all right? For visually impaired patients, you want to explain everything you're doing as you're doing it, okay? Because they can't see anything, all they do is hear a bunch of weird stuff, okay? If you're going to move the patient, again, explain to them where you're going to move them and all that kind of stuff, right? So for example, if they're sitting on a chair and I want to get them on my gurney, okay, I'm going to tell them, all right, we're going to go and pick you up by your arms here. We're going to lift you up on 3. 1, 2, 3. All right, here we go. Okay, we're going to turn you over to your right. We're going to take about 7 or 8 steps over that way to my gurney. All right, we're going to walk, 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 walk. Cool, we're going to stop right here. You're going to feel the gurney hit the back of your legs, and when you do so, we're going to go and bring you down on 3. 1, 2, 3. Sitting down, we're going to grab your legs, going to swing you over the top. All right, we're going to go and put the buckles on. We're going to lift you up. It's going to feel like you're on an elevator. All right, we're going to lift on 3. 1, 2, 3. That way the patient knows exactly what's going on as we're doing it. Okay, we don't want to surprise them because that can increase anxiety and make the problems worse depending on what it is. All right, if they have any type of mobility aids as well, such as canes, all right, we can go and bring that. Depending on your company, you can also bring the guide dog with them if they have it, as long as we can provide safe transport for the animal. If not, then we may have to have somebody else bring them to the hospital. Okay, but we can bring that stuff with us. As far as patients where there's a language barrier, again, if we have translators, right, we can go and use them. Okay, depending on company policy, if the patient's stable enough, they might be able to allow us to ride in the back with us, if not in the front seat. Okay, but we do want to leave them there. If we don't have them available, at least nowadays, we didn't have it when I was working, right? But we do have, translator apps on phones. Obviously not 100%, but at least it's enough to get a conversation going, right? If we have an online system, I can simply call the hospital. Use the hospital resources as well. Right? We'll be like, hey, hospital, we got somebody who is speaking this language. We don't have anybody here that can do it. No translators. Do you have anybody by any chance? Right? And they can pull somebody from wherever they got and act as a translator for us over the radio. Right? So again, use resources. If none of that is available for whatever reason, then we may be able to use law enforcement to transport this patient safely without kidnapping the patient. Right? And if they're kicking and screaming, making a fuss, probably don't want to go. But if we suspect it may be altered or something like that, then we get law enforcement involved. All right. As far as communication, okay, we do use radios and whatnot to communicate with the hospital and stuff like that. So, gonna want to jot this down. For base station radio, okay, a base station radio is a two-way transmitter that's in a fixed location. Okay, so that would include dispatch, because dispatch is able to send and receive messages to and from the field, and they're stationary, they're not moving around. Okay, hospitals, they can be considered base stations as well. And usually we call them base hospitals, right, if that's where we're going to be getting our orders from. So they can send and receive messages to and from the field. As far as mobile and portable radios are attached to the ambulance. And we can use that to communicate to hospital, to dispatch, sometimes to other units as well. Whereas the portable radio, okay, we're going to be having that on our person, and we can use that to communicate to the same people, dispatch, hospital, other units. Okay, we typically use that if we're not in the ambulance itself. So if I'm on scene, right, and I got to talk to somebody, I'll pull out my portable, and we'll go and communicate with them that way. Okay, so again, base station is in a fixed location that can send and receive messages to and from the field, like dispatch. Right. So, with base stations and most EMS systems, we use a repeater-based system. You're going to want to jot this down too. Okay. So, as far as a repeater-based system, it's going to take a frequency and then rebroadcast it through another antenna to therefore extend the range. Okay. So, just for numbers' sake, right? We have dispatch here, our base station. They have a relatively low-power antenna that, let's just say, has a radius of 5 miles. So usually it's a lot more than that. But just for numbers' sake, they got a 5-mile radius with this antenna. But within that 5-mile radius, right, we have this repeater antenna that can rebroadcast and extend out to 50 miles. Okay, if this unit's 20 miles away from station, this ain't going to cut it. But because we're in the range of this repeater, we're able to get the messages from dispatch. So think of it like a relay. Right, so that's pretty much what they call it sometimes. Right, it's going to take a message, rebroadcast it, retransmit it to get out to where it needs to go. Now, theoretically, okay, we could have coast-to-coast EMS communications with this repeater-based system, because we will have repeater antennas with wide enough ranges to where I could technically talk from somebody from California in Boston, right, bouncing back and forth all the way through. We don't have that because then radio traffic would be crazy, right? So the FCC, right, they're going to go and limit the frequencies that our companies and EMS systems are able to use, and therefore limit the range, right, of our radio transmissions. So they could say, oh, you guys can only use these frequencies, right, which gives us a range of, let's just say, 200 miles, for example. Okay, so if I'm outside of that 200-mile range, okay, I can't communicate via radio with my dispatch center. So we'd have to go to alternate forms, which would just be calling them up on your cell phone. Yeah.
So say for like in cases like rural areas stuff like that, if they are like how you said they're out of like range or whatever, like say they're out of the repeater range, are they able to switch channels if they're close enough to something else?
Yeah, they can switch frequencies as need be. And 200 miles, for example, is just LA because that's a pretty far area. But in rural areas, they can have counties that are hundreds of miles wide, right? So they'd have to use multiple repeaters to communicate within different parts. All right, so it's pretty much also like how cell phones work. They work in a similar fashion where they repeat from cell tower to cell tower, cell tower, cell tower, so on and so forth. Kind of work in the same manner here. All right, you don't have to worry about jotting this down. Okay, but there's digital equipment, so some of the newer stuff can transmit via Wi-Fi and Bluetooth, like cardiac monitors. They can send it to hospitals, so they already have the EKG before we actually get there. All right, so newer stuff. Cell phones, again, we can use that to communicate. And usually if that's the case, dispatch will get a hold of us somehow and tell us to landline dispatch, right? Which just means they want us to call. And usually with that, it's usually more informal ways of communicating because we have to keep it objective and formal while we're on the radio. So for example, let's say dispatch is going to give us a lunch break, right, or something like that. So let's say Unit 24 landline dispatch. Okay, we call them up. Hey, it's contact on 24. What do you want? Oh, sweet, we're on lunch. Cool, thanks. Right, and that's it. Instead of having to tie up radio traffic, right, they can just go on landline and be more informal and stuff like that. As far as sat phones, right, we don't have to worry about that. But in the case of like large natural disasters or something, then we can use that to communicate, right, without having to use any radio or any other cell networks or anything like that. All right, jot this down too. As far as simplex versus duplex, simplex is your standard walkie-talkie setup, push to talk, release to listen. Okay, so simplex is your push to talk, release to listen. So just like when you're on the radio, you push the button, you say whatever you want to say, and then you let go. And then the other party's going to do the same thing. They push on their button, they talk, say what they're going to say, and then they let go. When it comes to duplex, that's simultaneous talk and listen. So just think of it like a cell phone conversation. Both parties can talk at the same time without having to basically yield traffic from one to the other. Okay, but with the simplex system, you have to. You have to yield for one person to communicate. So if I try to step over somebody on the radio, I'm basically cutting off their communication and I'm taking over their spot. That's why you usually hear people say like, blah, 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 over, and then that's it. We don't really say that, but that's what that is for. All right, multiplex, I think of it like a group chat. So we have 2 more frequencies, they're all talking to each other. And for med channels, we use that for cases of MCIs or mass casualty incident, because there's a lot of people that have to communicate. So we're gonna have our own strict channels just for med personnel. Okay, and we'll be covering triage and stuff like that much, much later on. By the way, that reminds me, because I usually forget to say it. You guys need to take care of your FEMA courses, ICS 100 and 700, okay, no later than skill day 2. Let me rephrase that. They have to be turned in by skill day 2. Yeah.
Does FEMA 100 ever like they're like renewal, like you've done it before, you can just print it out?
No, they never expire. Yeah, so if you guys have taken those courses before, right, then you can just go ahead and go back to your emails, print them out, and give them to us, and that's fine.
It's not for continuing education, is it?
No. You still might want to have them just in case they wanted to like recertify or whatnot, but you should be fine. Yeah.
So do we have to make an account with them?
Yes. Yeah. Right, and the link for those classes is going to be on your online content, which again you also need to make an account for. Right, that way you can take it right there, or you can just Google ICS 100 and 700. Okay, so get that done probably this weekend, right? Because it has to be turned in on skill day 2. Okay, so just give you guys heads up now. 100 and 700.
ICS?
ICS, Incident Command System.
Is like radios and stuff?
Not necessarily. It's all like mass casualty incidents, how we are going to function into the actual triage system and all that kind of stuff. All right, and we'll talk about that too, but we have the lecture at the very end of the class, which you guys got to have completed by skill day 2. All right, so don't worry about this stuff either, but we have mobile data terminals, basically the laptops that we're going to have in our ambulance that we can use to communicate with dispatch, so they can send information to us, update us on dispatch info, things like that. All right, so the FCC, again, they're going to go and regulate our frequencies, therefore limiting the range of our repeater-based systems. Okay, they're going to monitor radio operations. Okay, so if I were to violate any type of protected health information, like giving out patient information, okay, if the FCC were to hear that, they go, wait a second, that's PHI, right? That is illegal. Here you go, here's a $20,000 fine, right? So you want to make sure that you're not doing any of that stuff over the radio, okay? And if you cost your company 20 grand, they're going to do what? Fire ass. Okay, so just make sure that you're not doing any of that stuff over the radio. Okay, they also establish your call signs. So sorry, you don't get to choose your own name with the radio. Okay, it's just going to be your unit number. All right, that's how you're going to be identified over the radio. Damn it. All right, so as far as dispatch, all right, dispatch is going to go ahead and gather information from the caller, usually a third party or sometimes a third party. Okay, so they're gathering as much info as they can. So you might want to jot this down. All right, so they're going to try to figure out, okay, what type of call it is. Okay, so they try to gather the nature of the call or the incident or anything else like that. Okay, so they may ask, okay, well, you know, why are you calling us? Oh, my stomach really hurts. Okay. All right, or I just saw a car crash. All right, so that way they kind of have an idea, but is dispatch always going to be accurate?
No.
No. Okay, again, they'll tell you it's an unknown medical. Basically their way of saying good luck. Right? Or calls will just change. Right? I've been on diabetic emergency calls that end up being full arrests. Right? So the easiest calls that we'll run become some of the more complicated calls that we can run. Just like that. And you have no way of knowing until we actually get on scene. Alright? Location of incident, so obviously they want to know where to send us. So they'll gather the address, you know, cross streets, business names, anything like that, so they know where to send us. Number of patients, so they'll try to determine how many patients are there. And usually in that case, if they know it's a scene with multiple patients, they'll dispatch multiple ambulances. Okay, so if they know, for example, it's a car crash that's got 3 cars involved, at minimum we have how many patients? 3, right? But if it's, you know, 3 Honda Civics, that's up to 15 patients that may be there on scene. So they'll probably say, okay, it's at least 3, there might be multiple, let me send 5 ambulances just in case. And oh shit, every single one of those was fully loaded, plus 1. Right, well now we got to send a bunch of other ambulances. Okay, but again, they'll try to send you know, what they feel is an appropriate amount. Responses by other agencies, so they'll let us know if fire's going to roll with us, if PD is going to be there, if hazmat's on the way, right? Because they'll communicate with their dispatch as well. So if they're, somebody calls 911 for a domestic dispute, okay, and EMS dispatch were to pick up the call for whatever reason, and like, oh, victim of domestic dispute, okay, cool, we'll send an ambulance, and we're going to send law enforcement. Law enforcement gets there first, they make sure it's safe for us, and then we can go in. And if that's the case, if dispatch and law enforcement says it's not safe, we're going to stage a few blocks away until we get the all clear. Right? So we're not going to sit there and be like, is it safe for us to come in yet? As we're like peeking in the window, right? Because we don't want the scene to become unsafe and us be right there. Special information, so things like gate codes or anything like that we need to get to the actual patient, they'll provide that info too if they can, and time. Okay, dispatch is going to be responsible for documenting times that we check in and all that kind of stuff.
How do patients so I'm guessing our dispatch is the 911 dispatch.
Sometimes.
How does like patients get in contact with our dispatch rather than just 911 dispatch?
It just kind of is the luck of the draw. Those 911 dispatchers are trained in different things. So they kind of know basic, okay, this sounds like a medical call, so I'd have to dispatch EMS. Or it sounds like a fire call, I'd have to dispatch fire or law enforcement or whatever.
And my other question is, because I know like there's like a non-emergency and of course there's 911, so does EMS services have a non-emergency phone number that people can contact?
Yeah, so like the private ambulance companies that are here, they have their own dispatch number, just a regular 7-digit number, and whoever needs them, they would call that and schedule that kind of stuff. Yeah. And when you guys do your ride-alongs, you'll probably be calling their dispatch center, right? And you'll be scheduling your rides with them depending on the company that you sign up for. So as far as time, again, we want to keep up to date with dispatch. Okay, 1, for documentation purposes and legal purposes, everything's going to be time-stamped. But 2, it's also our safety. Okay, so we need to tell dispatch, hey, dispatch, we copied the call. That way they know that we got it and we've started our duty to act, essentially. Okay, we want to let them know that we're on the way, and usually we do that together. Dispatch, Unit 24, we copy the call, show us en route. Okay, so time stamp, okay, they got the call at this time and they're en route 30 seconds later. Okay, then we want to tell them that we got on scene. All right, so hey, 24, dispatch, we got on scene, we'll timestamp it. Unit 24 dispatch, we're en route to this hospital, ETA 7 minutes. So they timestamp that we left, and then we get a hold of them again saying, hey, we got to the hospital with 1 patient on board, everything's fine. They timestamp it. And then once we're clear from the call, Unit 24 dispatch, we're clear, and they timestamp it. Okay, and we have to document times as well. But if for whatever reason I forget, let's say we're transporting to the hospital, I'm busy in the back, I don't remember what time it is, I can always, hey, dispatch, what was the time that we were en route to the call again? Or what time did we get to the hospital? They can go back and we can just retroactively fill it in. Okay, so things have to be time-stamped. All right. Now, as far as them, again, acting as safety, let's say we show that we're en route to the call. Okay, they know where we're at on GPS, and that's how they send the call. They know, okay, it should take them about 7 minutes to get to the call. 9 minutes later, if we haven't checked in, they'll say, hey, Unit 24, where you at? Or especially if they see us on the map and we haven't moved in a while, right? Now, like, shit, something's not quite right. Then they'd have to go and check up on us and maybe even send units to us if we got into an accident or anything like that. Okay, so they are kind of providing a little bit of overwatch for us in cases where, again, something may have happened. So, as far as communicating with the hospital, all right, if we have an online system, we can go and talk to them. Like I said, it's kind of a mother may I system where I need to ask for orders, or they can at least provide advice for certain things. So, go ahead and jot some of the stuff down. All right, at the very least, that blue stuff right there. So for a radio report, okay, we want to give a very basic, brief report over the radio, kind of like your field impression. What I've seen, what I've done, and because we're an online system, maybe asking for orders for what we want to do. So here in the white and blue, we have the general key points that we want to hit, and in red would be a script that we're going to follow. Okay, so you want to go and identify your level of services and make sure you're communicating with the hospital that you're actually going to be delivering the patient to. All right, because the last thing you want to do is call a hospital that you're not going to, show up to the one you actually are going to, you're like, who the hell are you? All right, because if you've got a critical patient that requires specialty care, okay, they need that time to get that stuff ready to go. And you show up to a hospital that you didn't call ahead to, they're like, yeah, we don't have a trauma bay for you, so you're kind of screwed, right? Because they don't have the equipment set and ready to go. Okay, so you always want to verify, hey, this is Unit 24, BLS unit, contacting such and such hospital, how do you copy? And then be like, hospital, blah, 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 we copy, go ahead. All right, so we know we're talking to the right person, and then we go and start talking about what we need to talk about. We have a 65-year-old male patient with a chief complaint of neck and back pain following a car crash. right? Patient's vitals are blah, 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 blah. Patient dies, history, allergies to meds. We've done this for our patient. How do you copy? Okay, cool. Requesting orders for this, this, or this. All right, copy, thank you. We're going to be there in an ETA of about 12 minutes. Okay, just kind of giving basic information to the hospital, painting a decent picture, and giving them that ETA so they know how much time they have to prep their equipment. Okay, that way when we're there, just kind of like in the movies, we just roll right in, take them to the hospital bay as we're talking to the nurses and doctors, giving a report, moving that patient onto the bed, and they can do what they have to do. Okay, we want to try to make sure that patient care and transfer is as seamless as possible.
When do we get cleared of that patient? Once they sign the paper?
Yeah. Technically, once we give the verbal report, that's when the transfer of care is done, but legally, it's when they sign off. All right, because if it's not written down, it didn't happen. All right, now with some radio reports, we don't have to do a full sample. Okay, instead we just give them some ham, history, allergies, and meds. All right, where we just state the relevant information. Okay, on the radio, they don't really care about the patient's last or oral intake, right? Because it's not relevant in most cases, right? But when I get to the hospital, especially if they have to go into surgery, do I want to tell them what they had to eat and when?
Yes.
Absolutely. Okay, if it's an abdominal complaint, okay, maybe last or oral intake would be relevant. You know, this patient said he had some sushi from the gas station and he found a warm beer on the street and drank that too. All right, that's something that may be relevant, indicating some type of foodborne illness. All right, relevant vital signs and treatments and things like that. Okay, these are all things you want to pass on to the hospital. So you don't have to worry about this, but again, as far as medical control, okay, if we're in an offline system like we are here in LA, okay, we're not going to be giving radio reports. Okay, we just follow the protocol, and then usually ALS, they'll give the radio report to update the hospital, and if they're shipping the patient BLS, they're like, all right, cool, yeah, we're setting a BLS unit, they'll be to you guys in about 12 minutes, right? And then that way they expect us without us having to give a call. Other places, though, again, we just call directly in. Now, if we have an online system, I'm going to write this down too, if we have an online system, okay, we have to repeat the orders that are given to us. We don't just blindly follow them just because they were told to us over the radio. Okay? So, doctors and nurses sometimes don't really know the difference between EMTs and paramedics. Okay, so they don't know what we can and cannot do, especially doctors, because they're assholes. Right? But as far as docs, okay, they'll go and say, all right, just start a line and push 12 milligrams of adenosine. Right? So we're like, okay, we copy, start IV, push 12 milligrams of adenosine. But as an EMT, can I start an IV? No. Can I push meds through an IV? No. Okay, but I'm still going to copy that order, but then I'm going to tell them, hey, by the way, I can't do that because that's out of my scope of practice. I'm an EMT. Okay, so the doctor at least knows that we acknowledge the order and we politely and respectfully tell them that we can't follow it. Okay, because it's out of our scope of practice. Right? Don't be like, all right, doc, I'm going to go and do it because they told me to. Right? Because, again, we don't have to worry about this, but adenosine is a drug that actually stops the heart, hoping that it resets itself. It's like chemical defibrillation. Okay, if I push that drug at that dosage, that can kill somebody. Right? Or if I were to start a complication with starting an IV, that can kill somebody. Okay, so we tell the doctor, hey, I copy your order, but I can't do it. It's out of my scope of practice. But here's a paramedic that I can pass the radio to who can actually follow that order. Right? And the doctor's like, oh, okay. And that's it. But if I go, no, screw you, click, okay, that's already get in trouble. All right, when we are talking on the radio as well, okay, use plain English. All right, we don't use 10 codes, as cool as you may sound, right? There's different codes for different agencies, different companies, different counties, all that kind of stuff. All right, 10-4 is kind of like universal, right? But other than that, we don't use really any other 10 codes. Okay, so just use plain English when we're talking on the radio. That way there's no miscommunication. All right, now as far as the orders that would be given, okay, it's all based on how well of a picture that we paint over the report. Okay, so if I give a really shitty radio report, okay, they're going to be like, yeah, I don't really know what's going on, so I'm not going to authorize you to do anything, just bring them to us. All right, because they don't want to make a mistake of giving the wrong call because that responsibility falls on who? It falls on them. Okay, so we're just going to go ahead and follow whatever orders they order for us. Right, and again, if I don't paint the right picture, they're like, yeah, I don't know what to do here, so don't do anything, just stabilize them and bring them to us.
At that point, if the patient died en route, would that be our fault because we didn't paint a picture to get medical call from them?
It's not really whose fault is that. It's just that there was a miscommunication and a really bad consequence that came with that. So that's why you just want to paint decent enough pictures. What you've seen, what you've done, and that's about it. All right, don't worry about the stuff. But as far as radio being our lifeline, again, we got to use that to literally save our ass every once in a while. Okay, again, if we are involved in a car accident or something, we have to contact dispatch and say, hey, you know, me and my partner were injured. We're going to need an ambulance to help us out, right? Or patient, you know, is more injured. We're out of service. We got into a car accident. We need somebody else. So we need to call for that stuff. If the radio fails, we're going to have a backup plan. We always have a written protocol, even for an online system, okay, because equipment does fail. As far as transfer of care, like we said, officially it's when you give a verbal report, but legally it's when we have them sign off. All right. As far as the report, it's just like our provider impression, what I've seen, what I've done, anything left I want to do, summarizing everything that we have in that call that's important. Now, as far as the patient care report, also known as the PCR, okay, this is going to be our documentation. Nowadays, it's all electronic, so it's on laptops or tablets that we go and fill it out. Okay, so we have a lot of drop boxes, check boxes, stuff like that. Okay, but it still is going to do the same function. Okay, it is a legal document. So should you lie on a patient care report? No. Okay, do not falsify anything that's a legal document. Okay, and we want to make sure we document honestly, accurately, and thoroughly as well. Okay, as far as standard abbreviations, if we can, we want to try to abbreviate to save space. Right, with ePCRs, we have all the space we want. Right, but in the good old days, we only had a certain amount of space to write a narrative. Okay, so they did allow us to use abbreviations. So, for example, CP, right, or C/P would be chest pain. C/C would be chief complaint. O2 is obviously oxygen, right? LPM, liters per minute. Okay. ALOC, of course, stands for what? Okay. SOB stands for shortness of breath. Okay. So again, with that one, we do have to be careful because it is approved, right? But we have to be careful how we use it. So you'd write 56-year-old male, positive CC SOB, right? Positive of chief complaint of shortness of breath. Not 56-year-old male, positive SOB. Because then we think, yeah, he's a son of a bitch, right? But we do have to be careful how we're using that one, so make sure you put chief complaint in front of that. Okay, as well as spelling correctly. Okay, yes, you have to spell medical terminology correctly. Okay, so do the best you can again with ePCRs, right? They've got spell check for medical terms. You lucky bastards. Okay, because for us, right, we have to document, okay, hand, right? So we have to know how to spell our words. All right. Now, if this thing goes to court, okay, that lawyer is going to do everything they possibly can to make you look incompetent. Okay, that includes going after your spell. Okay, sloppy handwriting, same thing. If they can make you look incompetent, they will attack you for that kind of stuff. Okay, so you had to make sure. Yeah. All right. You need to make sure. Yeah. So all your doctors are screwed. All right. So we want to go and make sure we're writing legibly, spelling correctly. Because again, they'll be like, yeah, this freaking idiot can't even spell glucose correctly. How can he possibly treat patients? Right? So again, they will do everything they can to make you look bad. So jot this down. As far as the 6 functions of the PCR, okay, the number one function of the patient care report is for the continuity of patient care. Okay, that is the PCR's primary function. It's to ensure that we document whatever we've done on scene, because like I said in intro, right, everything we do is going to be the foundation for everything else that this patient's going to have done to them throughout the course of their treatment. Okay, so if we didn't write it down, it didn't happen. Okay, so we need to write down treatments, right, reactions to treatments, and vital signs, things like that, to paint that picture of what happened on scene, so they can use that in the ER and the other specialty centers, right, to rehab facilities, right, things like that, so they know what's been done. Now, for our purposes, right, there's really not a whole lot, right, that we can get away with not documenting. Okay, but for example, ALS, I gave you this example too. If they gave the patient morphine, right, 5 minutes before they showed up to the hospital, but they didn't document it, okay, did it happen? No, not in the eyes of the law. So the nurses and doctor is going to see that and be like, damn, this dude's got an 8 out of 10 pain and they didn't give him anything for it? Well, that sucks for him. Let's give him some more morphine. And then, oh shit, the patient stopped breathing, right? Because they didn't see that it was documented that they had been given that pain medication. And now they basically overdosed this patient. Okay, so they need to make sure that things are documented, right, for that continuity of patient care. Its secondary function is as legal documentation. Okay, again, we need to write it down so we can actually prove that it happened. Right, but the number one primary function is for the continuity of care, to make sure that it has been done for further medical treatment. Education purposes, kind of what we covered right now. Administrative info for things like billing and whatnot. Okay, that's what we also use the PCR for. Research, so if we are going to be updating protocols, okay, they'll go back and essentially do audits of patient care reports. if they're doing, trial periods, stuff like that. Okay, we did this type of protocol for 250 patients. Okay, what was the outcome? We'll go back and check the PCR. All right, and then CQI, so continuous quality improvement. Again, do we have to, update training? Do we have to provide remediation, things like that, based on whatever it is we documented on the PCR? All right, documentation of the narrative. We got to write everything how that happened. Okay, preferably in a chronological order. Now, whatever company you work for and hires you, okay, they will train you on how to fill out their patient care reports and how to do narratives to their style. But it all pretty much accomplishes the same thing. Okay. As far as documentation and reporting stuff, we are mandated reporters, so we do have to report things every once in a while, especially abuse of any type. Child abuse, right? Geriatric abuse, elder abuse, anything like that, we have to go and document. Now, as far as mistakes that are made, again, back for written PCRs, okay, we would simply draw a line through our mistake, initial date, and then write whatever we wanted to next to it, rectifying that mistake. Okay, what we wouldn't do is color it out, because again, if this goes to court, that lawyer is going to make you look guilty as hell through whatever means necessary. Okay, so again, you could have simply misspelled glucose and you're like, shit, and you're just like coloring it out. But when you go to court, you're going to be like, yeah, whatever he's hiding under there is definitely what caused my patient their harm. He's definitely trying to cover up his tracks. And all you did was misspell a word. Okay? So by drawing a line through it, you're keeping it transparent. They're like, oh, well, he couldn't spell. I mean, he did fix his mistake, so I guess he's not that incompetent. Right? So we want to try to keep it transparent. All right? Obviously, don't lie on any type of legal document, because if you get caught in that lie, you're going to be in big, big trouble. Okay? Just like those EMTs that I told you about that let their patient end up jumping out of the back of the rig because they falsified their vitals already. Right? So that's a big no-no. As far as documenting an AMA, okay, so we do have to go over the 4 things. So again, make sure the patient is informed of the risks up to and including death. Okay, so we explain to them, blah, 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 and you could possibly die if you don't receive treatment. Okay, make sure they understand those risks. Okay, so do you understand the risk of not being treated or transported? Right, document how we try to convince them to be transported, or at the very least, do they have plans for further medical care? Are they going to see their doctor in the morning, going to go to urgent care, they're going to drive themselves, etc.? Okay, and let them know that they can always call for another ambulance and one will show up. Now, as far as the documentation, okay, we do have to have a witness sign patient care report. Okay, in the case of an AMA, somebody does have to sign as a witness. Preferably somebody on the patient side, right? Because it looks kind of guilty and weird if we have somebody on our side signing off, especially if something happened to that patient. Okay, it definitely looks like we're covering something up. So if you got the patient's spouse or family or friend there, right, you can have them sign on that witness form. Now, when it comes to law enforcement, okay, for documentation, okay, law enforcement is regarded as a neutral party. Okay, so they don't pick sides when it comes to documentation. But whose side are they usually on? Usually on our side. All right. But again, when it comes to documentation, they're neutral. So if we have law enforcement there and they see the patient sign out AMA, they can sign the witness form too. Now, if we don't have that option and it's just somebody on my team that has to sign off, we want to document, okay, thoroughly that there was nobody else available to sign as the witness form. Or we can have the patient sign and document that they signed off for that. Okay, it's all about that CYA, which stands for
Cover your ass.
Cover your ass. Okay, you want to fill out as much of the PCR as you possibly can, especially when it comes to vitals. Okay, that way if they decide to sue, you can be like, no, I did a full set of vitals. They were totally stable when I was on scene. I explained to them, hey, this stuff can happen up to including death. Patients stated they understood those risks. They said they were going to go to urgent care in the morning. If they didn't, that's on them. And they knew that if they wanted to, they can call for an ambulance and one would show up. Okay, you want to document, right, have a nice solid defense. That way, if this goes to court, you're not going to get in trouble.
Is AMA common?
Mm-hmm. Yep. A lot of times they'll show up and they'll do something or be like, I changed my mind. I don't want to go. So we have to go through this whole procedure. All right. So that's that. All right. Now, as far as tomorrow, okay, tomorrow is where it all starts coming together. Okay. We're going to be talking about shock. Okay. So we're going to go ahead and start getting through different types of shock, different recognition and whatnot. Okay. We're also going to start covering trauma. Okay. It's going to be one of 2 nights of trauma, Monday being the second night, and then Tuesday is where it switches, right, and goes into medical. All right. So make sure you guys are solid in your anatomy, physiology. Okay, in your patient assessment, okay, because we are expecting you guys to know all that stuff tomorrow. Different parts of the brainstem, blood flows to the heart, abdominal cavities, and stuff like that. Okay, all that stuff you're expected to know by tomorrow. All right. So, see you guys tomorrow.